Okay. Good morning, folks. If you can move to your seats, we're going to start momentarily. Well, good morning again. I'm Michael McGinnis, the executive officer of the National Academy of Medicine, executive director of the Leadership Consortium on the Learning Health System. It's my distinct pleasure and privilege to be able to welcome each of you to this really important conversation around Clinicians Forum on AI and health and medicine. It's a conversation that is stewarded and shepherded by our Digital Health and AI Action Collaborative, which we'll hear more about in just a minute. Most importantly, I want to thank you for setting aside time for the conversation in this period of warp speed activities in which the ground beneath us seems to be shifting with some frequency and occasional intensity. It's all the more difficult to keep our schedules dedicated to the kinds of things that are really important for the progress in society. And so I realize what a commitment that you've all made, and thank you all for being here. Special thanks, of course, to our Digital Health and AI Action Collaborative co-chairs, Peter Lee and Ken Mandel, for steering the ship. And we're going to turn it over to them in just a few minutes after I offer essentially three comments. One is the welcome and thanks. Second is a little bit about us. And the third is a little bit about you and the conversation here. With respect to us, you're going to hear from Sunitha Krishnan, who's been in touch with probably most of you, probably many times, in a few minutes about the work of the Action Collaborative and the National Academy of Medicine in this arena. I'll just give you a sort of brief preview in this respect, and that is to say that looking around the table, there are quite a few who are veterans here at this table who we've had the pleasure of working with. Also quite a few people who are at least new to this particular conversation stewarded. And so I want to, of course, give a special welcome to those of you who are first visitors to the building. By the way, this building, we're part of the, on that context piece, we're part of the National Academy of Sciences, Engineering, and Medicine, formed in 1863 with a charter passed by, actually, a charter proposed, written, voted on in Congress, and signed by the president in one day on March 4th, 1863. Those were the days. The National Academy of Engineering was added in 1960. The National Academy of Medicine with the predecessor Institute of Medicine in 1970. Together, our responsibility is, in a general sense, to serve as advisors to initially to the government, but now broader to the nation. I'll just say one more thing about that. The advice early on until relatively recently predominantly took the form of consensus studies of one sort or another that were undertaken at the request of government or other parties. That's still a very important part of our function. But in many ways, the kind of conversation we're having today, that is our convening responsibility as an independent, trusted counsel to the nation, is very critical, at least from our perspective. We take it very seriously. All the more reason for our gratitude to you for being here with us. The Leadership Consortium is the vehicle within the National, by the way, the National Academy of Medicine's mission, in part drafted by Peter Lee as a member of our strategy group, is health for everyone, everywhere. That's our vision for the Academy. And we in the Leadership Consortium are the vehicle within the National Academy of Medicine to bring public and private sector leaders, about 4 dozen or so from 9 different sectors who represent leadership in the health system across the country, with the primary aim of aligning the forces in play. We have, as we all know, we live it every day, a fairly fragmented system, and some call it a non-system. The new Mission Impossible movie's out, isn't it? Our mission that we've chosen to accept is to enhance alignment among the various forces in play in the system, and to work extensively with the private sector and as well as the public agencies involved. And one of the things that we have taken on as a special interest is naturally the issue of artificial intelligence. It's the future. There's no sector in which AI is going to make a bigger difference, at least from my perspective, than in the health sector. We recently released what we call our primer on generative AI in health and medicine, a product of this collaborative. And then also released earlier this week was the Artificial Intelligence Code of Conduct for Health and Medicine. The hard copy version will be coming out in, I think about a month, but the preprint version is available online. And we have a very robust agenda. These are 2 examples, naturally, in the arena of artificial intelligence. We've had our eye on this issue since the beginning of the development of the Leadership Consortium. It was formed in 2006 with a charter that coined the term a vision of a learning health system in which all the key forces were aligned for continuous learning and improvement. At the time, it was a distant vision in the view of a number of the stakeholders, but it was also one in which one could clearly see the beginnings of what might be in store with machine learning and artificial intelligence. And we are clearly at that moment now. And that's why it's so important that we have you folks around the table to work with us in ensuring that the clinical community is as prepared and as providing as much leadership as possible in this respect. So before getting to the you part, I want to turn it over to Sunitha Krishnan. And Sunitha, Thank you very much for all the good work with everyone, and we'll look forward to hearing your.
Good morning, everyone. It's a pleasure to have you all here with us today. As Michael mentioned, my name is Sunitha Krishnan. You all have definitely received multiple emails from me. I apologize for all of the spamming, but I'm a senior program officer here at the National Academy of Medicine, and I oversee our Digital Health and AI Action Collaborative that brings us together today. Before we begin, I want to highlight and thank our great staff for making this convening even possible. So in the back, from right to left, we have Lauren Williams, Audrey Elliott, Annie Murph, Amanda Hunt, Julie Tarrant, Hannah Ingberg, and Jan Trausch. So thank you. Before we jump into the rest of our agenda, I wanted to build on Michael's introduction of the NAM Leadership Consortium elements to provide more information to one of our three core areas, our action collaboratives, and walk you through the briefing book containing important resources related to the event. Next slide. The National Academy of Medicine Leadership Consortium provides a venue for the leaders of public, private, and independent organizations spanning diverse health systems to collaborations in service of effectiveness, affordability, equity, and continuous learning in health, medical care, and biomedical science. Next slide. Actually, can you go back to the last slide? Sorry. On this slide are three areas of activities that advance the consortium's aims: the Learning Health System Shared Commitments Initiative, our action collaboratives, and the Commission on Investment Imperatives for a Healthy Nation. Together, they provide a multi-stakeholder common vision, vehicles for collaborative action and alignment, and promote the conditions necessary to align values, incentives, policies, and actions across health system stakeholders and sectors. Next slide. The Leadership Consortium defines a learning health system as one in which science, informatics, incentives, and culture are aligned to support health system effectiveness, efficiency, discovery, equity, continuous improvement, and innovation. Each of our four action collaboratives are dedicated to one of the four elements of the learning health system. So representing science is our evidence and data action collaborative. Representing informatics is our digital health and AI action collaborative. Representing incentives is our values, incentives, and systems action collaborative. And representing culture is our trust and engagement action collaborative. Next slide. Today's meetings of our Digital Health and AI Action Collaborative has a sort of operational focus. Its strategic aim is to promote digital tools and architecture for seamless connectivity, learning, and innovation, including accelerating the responsible development and application of AI and other emerging technologies for transformed health, healthcare, and biomedical science. The focus of this exploratory meeting is to identify opportunities, special considerations, and key steps related to the establishment of a clinicians forum on AI in health and medicine, composed of key health professional organizations, including medicine, nursing, pharmacy, physician associates, social work, physical therapists, and developers, patients, and related stakeholders. The forum will gather regularly to consider developing tools and critical questions related to the effective and ethical integration of AI into healthcare. Insights gleaned from today's meeting will help identify priority needs, preferences, and topics for near-term exploration through the forum. Next slide. To help further ground this meeting and the program in which it is housed, I ask that you please turn to your briefing books as I review the main sections. On the inside cover, you will see the complete list of our LHS shared commitments, which provide context for everything we do. Under the first tab, you will find meeting information, including today's agenda and a participant list. Tab 2 supplies information on recent DHAC activities related to the day's discussions, such as a summary of our October 2024 DHAC meeting, which sparked the creation of the Clinicians Forum, a one-pager describing the forum in greater detail, a one-pager describing our various NAM AI activities, which you will see span from broad convenings to deeper dive explorations, the cover and NEJM companion piece for our NAM special publication on generative AI in health and medicine, and you also have the physical copy at your seat. The cover and summary one-pagers for our newly released AI Code of Conduct special publication, and a bibliography of resources and other synergistic initiatives. Tab 3 provides information on the broader leadership consortium, including our member roster and information on the evolution of our learning health system work. Tab 4 contains an impact timeline that shows how LC deliverables have influenced national programs and initiatives. And the biographies of meeting participants and general logistics can be found under tabs 5 and 6. I'll now hand it back to Michael.
Thank you very much, Sunitha. Typically efficient and effective presentation, as Sunitha and her colleagues behind us are really an extraordinary group of allies and leaders for us in this work. So now I want to make a brief comment on you before we go around the table and then turn it over to our co-chairs. The fact that we have such incredible transformative potential for health and healthcare in this nation brought to us by artificial intelligence compels us in the National Academy of Medicine and each of you and the organizations that you represent, whether they're clinician organizations, and they're primarily clinicians, but also product developers we have at the table as well, to work as intensively as we can to ensure the responsible and effective and rapid uptake. Not that we're going to have to quicken the pace because things are moving pretty quickly anyway, but we want to make sure that the quickened pace is moving to the extent in an aligned fashion and in the right direction. The fact that we're so focused on the role of the clinical setting is underscored not only by the conversation that we're having now, and you're representing the leadership of clinicians across the nation, but typical for these days for our focus on convening the right folks, 2 doors away is our standing roundtable on primary care. So we're devoting a substantial share of the building's resources today to ensuring that we are closely engaged with critical players in setting the stage for the future of health and healthcare. I would like to start looping back on one thing that Sunitha mentioned. And on the inside, and I think also with the leadership consortium description, you have the little page marker of our shared commitments. And most of you have seen this in one way or another. But as you look down the list of the shared commitments, and these are a product of our learning health system activities, launched initially in about a quarter century ago with 2 Errors Human and Crossing the Quality Chasm, 2 of the major contributions of the then Institute of Medicine, and built upon through the Leadership Consortium over the intervening period, so that we now have and are working with many of you, most of the organizations around the table, to provide common ground framework on shared commitments. And if you look at each of these, that is the commitment to ensure that we're fostering a health and healthcare system that is engaged, safe, effective, equitable, efficient, accessible, accountable, transparent, secure, and adaptive. Imagine what AI has in the way of potential to change our ability to break out of what in some of these arenas might even be viewed as stagnation. No one can quarrel with the objectives, but we now have, through the potential of AI, one very important tool developing for progress in each of these shared commitments. As Sunitha mentioned, when she went over the purpose of today's meeting, which is also on the cover of the agenda, is the focus on exploring really how a clinician's forum on AI might be able to make a difference. And the questions that are posed there, in effect, amount to what are the opportunities before us now, and what actions need to be taken collectively and individually with respect to the kinds of things that we're going to be looking at around the what, the who, the why, the what is the tools, who are the players, and why. What are our stakes? What are the stakes for society in the arena? And then the outcomes of this meeting that we're seeking is essentially are two. One is whether, that is to say, we have committed to making possible a clinician's forum of this sort, but only if you feel that it's something that will really add value from your perspectives and in your context. So we still have the whether question on the table, and then the question of how. There are complex issues, complex organizations, large numbers involved, so we need to think in a dedicated fashion about what the how is. So those are actually longer comments than I would have made usually as an Action Collaborative meeting, but I think that this one is so important that we all need to start to the extent possible with a common understanding of what we would like to move toward. Now, to finish off the U, let's go quickly around the table, and I emphasize quickly. We've got 6 minutes according to the schedule, but we can go a little faster, a little slower if we need. And just if you could just say who you are and your organization, and again, with thanks, I'll turn to Jeffrey.
All right, good morning, everyone. My name is Jeffrey Smith, and I am with the Assistant Secretary for Technology Policy / the Office of the National Coordinator for Health Information Technology, which is the longest name in government, I believe.
6 minutes up.
Yep, exactly. And I think just real quick, Michael, to answer your question of whether and how, the answer on whether is absolutely yes. So anyway.
Thank you, Jeffrey. Jackie?
Good morning. I'm Jackie Gerhardt. I'm Chief Medical Officer at Epic. I'm a family medicine physician by background, still practice, and have used multiple AI tools. Thrilled to be here.
Thank you, Jackie. Connie?
Thank you. Good morning, Connie Delaney. I am Dean and Professor of Nursing at the University of Minnesota and deeply involved CTSI, et cetera. And I'm here representing the American Academy of Nursing, where I chair a national task force on AI. Thank you.
Thank you, Connie. Helen?
Morning, everybody. Helen Burston, Chief Executive Officer of the Council of Medical Specialty Societies.
Thank you, Helen. Kimberly?
Good morning, everyone. I'm Kim Lomas. I'm Vice President for Medical Education Innovation at the American Medical Association. Previously a general surgeon, but no longer in practice.
Thank you, Kim. Matthew?
I'm Matthew Diamond. I serve as the Chief Medical Officer at the Digital Health Center of Excellence at FDA's Center for Devices and Radiological Health. Glad to
Thank
be
you,
here.
Matthew. Anita?
Good morning, everybody. Anita Gerard. I'm here representing the American Nursing Association, and I've been a nurse for many years and have implemented AI and virtual nursing, and we're working on our competencies right now. So thrilled to be here. I think this is an incredibly important conversation. Thank you.
Thank you, Anita. Anne?
Good morning, Anne Sheehy, Chief Medical Officer and the Director of the Office of Planning Analysis and Evaluation at HRSA.
Thank you, Anne. And we move to Lisa.
Lisa Gables, good morning, everyone. The CEO of the American Academy of Physician Associates. So thrilled to be back at the table.
Thank you, Lisa. Ethan?
Morning, Ethan Booker. I'm the Chief Medical Officer for Telehealth at MedStar Health, practicing emergency physician and wearing another hat as a member of the Clinician Council of the American Telemedicine Association.
Thank you, Ethan. Gwen?
Hi, Gwen Darian. I am a 3-time cancer survivor and long-term patient advocate, and I am the Executive Vice President for Patient Advocacy Engagement and Education at the Patient Advocate Foundation. And I am also a member, just because all of these different threads come together, of the National Cancer Policy Forum of NASM.
Thank you very much, Gwen. Jana?
Good morning, everyone. Jana Patterson, a former neonatologist and currently Chief Education and Global Health Officer at the American Academy of Pediatrics.
Thank you, Jana. Jim?
Good morning, everyone. Jim McAdams, representing the American Board of Internal Medicine, responsible for innovation, strategy, and solutions, everything from upskilling, reskilling resources to disrupting ourselves with transformative innovation.
Thank you, Jim. Stephanie?
Good morning, Stephanie Quinn. I'm with the American Academy of Family Physicians.
Thank you, Stephanie. Drew?
Hi, I'm Drew Contreras, Vice President of Strategic Affairs at the American Physical Therapy Association, where my portfolio is digital health and innovation.
Thank you, Drew. Laura, as Laura speaks, I should let you all know that Laura has been our spearhead for the work on code of conduct for the use of AI in health and medicine.
Thank you, Michael. Good morning, everyone. I'm Laura Adams. I'm Senior Advisor at the National Academy of Medicine.
Thank you, Laura. Dave, welcome back.
Thank you. I'm Dave DeBroncart, known on the internet as ePatient Dave. I have no organization. I'm best known as a free radical.
Thank you, Dave. Sue?
Good morning. I'm Sue Sheridan. I'm with Patients for Patient Safety US. I'm also here representing my family. We live in Frontier, Idaho, and I'll be sharing later on today how we have all used AI and technology to achieve the best outcomes when you live up in the mountains with very few doctors.
Thank you, Sue. Susan?
Great. Good morning. I still work for the Veterans Health Administration and am I was thinking maybe I wouldn't say that, but then after these two fun folks, I figured I would chime in.
No, it's good to know that it and you are here.
I'm here. I'm very happy to be here. So I'm the Deputy Assistant Undersecretary over Research, Innovation, and Health Professions Training, working with Dr. Clancy, who's been a member of the Academy for a long time, really passionate about how we look at AI and other digital tools and make it work in the clinical care delivery and back taking care of veterans at the DCVA a little bit in the emergency department. Thanks.
Thank you, Susan. Gina?
Good morning, everybody. My name is Gina Galanu-Luchin, and I am the Director of Digital Health and Data for the American Society of Health System Pharmacists. So very pleased to be back here today.
Thank you, Gina. Morgan?
Hi, everyone. My name is Morgan Cheatham, and I'm a partner and head of healthcare and life sciences at Briar Capital, which is a venture capital firm that invests broadly across AI with a particular focus in medicine. And in about a month, I will be a first-year resident at Boston Children's Hospital in the Combined Pediatrics Genetics Program. Thanks for having us.
Yes, Morgan, having spent 10 years in venture capital, decided he wanted to be a physician, so he graduated on Sunday.
Hard to follow. I'm Lisa Howley. I am a Senior Director for Transforming Medical Education at the Association of American Medical Colleges, and delighted to be here and truly honored to be co-presenting later today with my colleague to my right. Thank you.
Thank you, Lisa. And let's leap back just a bit to Shauna.
Hello, everyone. Shauna Overgaard. I am Senior Director of AI Strategy and Frameworks at the Mayo Clinic. Part of my work was also to co-chair our AICC Health Systems and Payers Working Group. And so I'm trying to bring directly that information, that role into practice at Mayo Clinic to operationalize what we've been discussing. And I plan to do the same today. Thank you.
Thank you, Shauna. Tom.
Hi, Tom Mason. I'm the Chief Medical Officer of the Assistant Secretary for Technology Policy with my colleague here, Jeff. I'm an internal medicine primary care physician by training, and my goal for today is to not be a free radical. I wish I could be, though, but I'll pass.
Thank you, Tom. Anna.
Anna Miller, the VP of Nursing Informatics at Epic, and previously was a bedside nurse. Today, I focus a lot on nurse well-being and making sure our nurses are getting the most out of the system.
Thank you, Anna. My cousin, Vinny.
Yeah. Hi, Vinny Liu. I'm a pulmonary critical care physician, chief data officer for the Permanente Medical Group within Kaiser Permanente.
Thank you, Vinny. Q.
Hi, I'm Q Ree. I'm also a MedPeds physician, still volunteer at a health center. I'm the CEO and president of the National Association of Community Health Centers, which represents our nation's largest primary care system that serves about 1 in 6 people across the nation.
Thank you, Q. And Shiv.
Good morning. I'm Shiv, founder and CEO of Abridge, also a practicing cardiologist. It's a privilege to be here.
Thank you, Shiv. And thanks again to all and to our chairs.
This is an incredible gathering. I was trying to remember the last time I've been in a meeting this size entirely in person. And I know whether you're in government or industry or academia, this is an incredibly busy, fast-paced, and turbulent time. And so for all of you to take time out to attend this meeting in person, I think is really remarkable and very, very much appreciated. Just a couple of things. I think you all did this. Even though we are in person, the room acoustics here aren't this is a wonderful room, but the acoustics aren't state of the art. And so please do remember to use your microphone and bring it close to your mouth so that we can all hear and engage in conversation. I think at some point in each of our sessions, there'll be a chance for open discussion. And if you want to speak, we can use the standard approach of putting your tent card up, and we'll be able to call on you as we go on. As Michael said, I think what we're trying to decide here is whether there is utility in establishing a clinicians forum on AI in health and medicine. And I wanted to just express a little bit about what I see as what's at stake here. Obviously, there's a lot of intensity around artificial intelligence, and you know, it's something that is very important to me. It's important to all the people I work with. And while there is oftentimes a frustration in the world of healthcare, that the world of healthcare feels slow and resistant to technological change, if we reflect back on the last 2 years since the release of OpenAI's GPT-4, or the 2.5 years since ChatGPT, we should actually understand that a lot has happened. I think we'll hear from people like Shiv and others that there are extremely large amounts of AI-generated data and content and analysis of data that are happening on a daily basis today. And exactly, you know, how that can be best supported, I think, is one of the important questions here. The National Academies itself has been working in new ways and incredibly rapidly. Michael highlighted the 2 recent publications. Those publications not only have been released on timelines that are dramatically accelerated for the traditional National Academies things, but they haven't cut corners in the process. I would especially call out the AI Code of Conduct, where I don't know how many talks in how many different cities Laura engaged on here. It's probably in the triple digits in time. And it's not just the National Academies, but the American Medical Association, many of the societies and boards that are represented here, the World Health Organization, and so on, major governments around the world have really been putting a lot of thought and effort to really confront the reality of artificial intelligence and its potential impact in healthcare. And so the question before us is whether there is something very useful and important and engaging to do in creating some form of clinicians forum, something that would provide very practical, sound, and engaging advice, convening the world and showing an example to the world on best practices, and really addressing the questions about effectiveness, about safety, and ultimately empowering clinicians and patients to achieve better health. While there's a lot of focus on artificial intelligence, in a discussion I was having with several people at the National Academies, I actually think in this action collaborative, the most important word is action. I had mentioned early on that there is tremendous turbulence in all of your lives. That turbulence is definitely true also for the National Academies. And what is very important now for the nation and for the world is for organizations like the National Academies to show that it is able to mobilize action, and to mobilize action in very effective, highly engaged, and visible ways. And so as we think about the discussions today around the Clinicians Forum, I would really urge people to think about how that would spur action. and action that would really help advance all of what we're aspiring to in the concept of a learning health system. And so, yes, this is about artificial intelligence, but I think actually the focus here should be on action. What should this Clinicians Forum address? And it's not just the questions, but how and whether. And so if we can't do that, then I think Michael's first question about whether we should have a Clinicians Forum at all, I think is really pertinent. There's a very strong intuition that it's good time and that there would be a lot that could be done here. But it's important. It's important for healthcare. And frankly, it's important even for the future of the national academies. So I think you all know that. I think that's why you're all here in person. And I'm looking forward to engaging with all of you. Ken?
Thank you. A real pleasure to be here. And I'll just say that I've taken on also a new role. Starting in July, I'm going to be Morgan's mentee at Boston Children's Hospital.
That's so bad.
So, so a lot has been said, and we want to get to the main event here. So I'm just going to rattle off a few random thoughts in bullets. One is that just yesterday, there's an article in Axios where Dario Amodei of Anthropic basically said that there's going to be a workforce bloodbath with 20% unemployment within 5 years and 50% of white-collar entry-level jobs gone. So whether that's an exaggeration or whether that's only partially true, I just want to keep us grounded in the amount of change we may be facing so that our comments and our thoughts today aren't too muted compared to, I think, the pace of change. Things are changing very rapidly. The infamous reviewer number 2 on your papers, if you write papers, is going to be a language model soon. And that's coming directly from top journal editors, okay? That's a big change. The question about what regulatory regime we will be working under, if any, and what direction we're heading it's a completely open question now. We don't really know where the regulatory what the regulatory stance will be, and it's not really also clear that language models, for example, are being used in a way that's completely regulatory compliant now. Certainly, for example, one could imagine a lot of HIPAA violations in the way patient data are being shared, as just one example. I mean, there's just no question that that's going on. Does it matter? Does it really matter, or does it only matter from a compliance perspective? That's another question. But we know that something will have to give at some point. Adam Rodman has a recent preprint, Superhuman Performance of a Language Model on the Reasoning Tax of the Physician, where in real emergency department cases, not in real time, but the O1 preview model outperformed emergency department physicians. And you know, having played with these models, I'm not that surprised. In the education realm, which is where we'll be having a conversation here, you know, many universities are still trying to figure out how to prevent their students from using AI. You know, like let's think in a forward way. And then I really want to reiterate Peter's call for what we can do and within this Clinicians Forum. The Clinicians Forum and the National Academy, you know, it is a moment for the National Academy, you know, just like it's a moment for everything else, from Harvard University to many government agencies. And I think there's an opportunity for, if we did the Clinicians Forum correctly, for it to be a real voice for doctors and other clinicians. And I think it could be very complementary to to professional organizations and advocacy organizations that have different agendas that come at this from different ways. And many of us are here around the table today. And I wonder if there could be a voice that is guiding, a neutral voice in the sort of a classic National Academy way that is guiding us towards the future and is engaging the clinical community directly through physicians and other clinicians, directly through the professional organizations that represent them, but in a way that is genuinely future looking. So with those comments, I will go to the housekeeping. So I think there's a slide with the agenda. And just so you remember where we're headed today, we're going to hear from Shiv in one moment on emerging applications in AI and clinical care. Then there's going to be an open perspectives session. We'll have a brief coffee break. We're going to go into a deep conversation on education and training. And again, here also, I encourage us to be very forward-thinking and not to pull our punches. We'll have lunch for 45 minutes. Then we're going to get on to the all-important impact of AI on patient experience and patient-clinician interactions. Then again, an open perspective session. And there we're going to really dig in on some of the clinician forum questions and whether we can cohere one that is impactful. To remind everyone, this meeting is private. It's not open to the public. It's being recorded for internal purposes, like writing up the conversation, and you'll get those summaries, and nothing will be attributed to an individual. So you should feel free to make a comment knowing that you're not going to be called out for that comment. And there's a large enough group that you've got anonymity here in that report. And as Peter said, you raised your 10 card for the thing, and then we all make the rookie mistake of not having our microphones close enough. So just try to keep that in mind. You push the button, you bring it in, you talk, and that'll get it on the recording and make sure everyone in the room can hear you. And also just give your name and your organization and role when you ask a question. So with that, we'll turn it over to Shiv.
Excellent. Well, thank you so much. This is such an honor, such a privilege to be here. Over the course of the next 25, 30 minutes, maybe, I'd love to share a little bit of a sense of this historic moment that we've all been in the middle of over these last these last few years. A little bit about me. So I'm the founder and CEO of a company called Abridge. I'm also a practicing cardiologist. Prior to this, I used to be an executive at UPMC in Pennsylvania. I sort of violated Peter's Principle 10 times in 5 years and led innovation for them. A couple lifetimes ago, I went to Carnegie Mellon as a kid. Carnegie Mellon factors did. Okay. Thank you. I really appreciate that feedback. Hopefully this is a little bit better. Okay, excellent. So I want to share from my humble vantage point, from our humble vantage point in the market, what these last few years have actually felt like. And what I'd love to lead with is just a little bit of like a how did we get here timeline. And we've got pioneers in the room like Peter Lee, but I think at a high level, there's a convergence that's happening right now between what's happened in AI over decades, but also what's happened with healthcare data over decades that sort of led us to this incredible moment that we can all kind of really seize. Now, I won't go through everything that's on this timeline, but I think the key sort of bits is that from 1945 with the first general computer all the way to the late 80s and back propagation and neural networks all the way to the 2010s and 2020s with the rise of deep learning and GPUs to really the generative AI boom that we're in the midst of. It's interesting to sort of map that timeline with AI to the timeline around all things related to healthcare data. On the healthcare data side, obviously Medicare, Medicaid in the 60s, but then, the VA's digital health record, the DHCP, in 1989 to the 90s, up to early 2000s with HIPAA and the Human Genome Project, to then the HITECH Act and the 20th Century Cures Act, to this incredible moment right now where we're digitizing data across any number of different sort of mediums, different formats, in a way that allows us to really capture this moment because we've got these tools with AI and we've got all of this data that is increasingly digital that allows us to really refactor and reimagine what care delivery really looks and feels like. This slide is thanks to Morgan here in the room. And really what it's trying to get at is certainly the researchers across the industry recognize that this isn't a hockey stick moment. This is more like a telephone pole moment where all of a sudden, out of nowhere, we are doing unprecedented amounts of research. We're really figuring out what this technology means. And as fast as the research community can move, what's really also quite fascinating about this moment is that it feels like we're always behind. If anyone is sort of keeping track of how the ground is shifting around all things related to AI, it feels like every couple of weeks there's a paradigm shift in some way, shape, or form. And so obviously a lot of the research that comes out is in some ways like a lagging indicator of where we were. And sometimes even the research that we do internally inside of a bridge feels like a high school yearbook photo, by the time that we put it out, a little bit embarrassing, and and it's sort of gotten a little bit moldy, and there's no way to sort of keep up with ourselves in some ways. Over these last few years, I wanted to sort of now transition to what we've been seeing, the patterns we've been sort of recognizing across healthcare systems and how they've been thinking about AI. Over the last couple of years, every single venture capitalist, I think Morgan would attest to this, has put out their own manifesto. You have too, on AI and what AI is going to do in healthcare and in general. One of the really interesting ones that I read from last year came from a VC that sort of likened the evolution of AI to that Daniel Kahneman book, Thinking Fast and Slow, where thinking fast was that 2023 moment for a lot of us when we went on ChatGPT and we prompted the model and we got information back that almost seemed like it was memorized, regurgitated. And still, I live on airplanes now, and ChatGPT is my best friend. I can say that with especially now that it has memory and it remembers me and really knows me. I can just ask it questions about me, and they say it's sycophantic. I don't agree. I think it's very, very honest. But I think the thinking slow moment, the way that this VC group sort of broke it down, it was Sequoia. They sort of said, well, the thinking slow moment is where models can actually take a problem, unpack it into its constituent parts, and then reason through to get to the answer. And in that thinking slow world, AI can get jobs done. And what's so fascinating about this idea of getting jobs done is that there are just so many jobs in healthcare that nobody wanted to do in the first place. So how can we now start to point this new tool at all of these jobs? How can we start to, force multiply all of our people? Ken mentioned the CEO of Anthropic, Dario. He famously, maybe earlier this year or late last year, said that, earlier this year, he said that by the end of this year, 97% of software engineering would be automated. Now, when he said that, all of our engineers went on to the Anthropic website to look at who they're hiring, and all we saw was engineer, 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 engineer. And so there is this paradox, Jevons paradox, that a lot of people invoke in relation to AI, whereas something becomes more available, cheaper, if you will, we just end up sometimes using more of it. And the same phenomenon, I think, is what we're going to see, not just in software engineering, but we're also going to see in healthcare, where as in my, own practice, I see patients maybe 1 weekend a month. There are more and more patients who are coming into the health system who are equipped, with information, who are sometimes coming into the hospital because of something they've learned, maybe through a family member who went on GPT and got worried about, some new symptom of theirs enough that they were seeking help. We're going to see more and more patients seeking help, and we're going to need more and more tools then as providers to actually, deliver that help. And so that's I think a part of the moment that we have to be up to the challenge for. Healthcare is perennially understaffed, as we all know, and we have 14.7 million Americans employed in this industry. It's just the largest surface area, for really, disruptive, potential over these coming years. So now I want to get into those patterns that we've been seeing across the industry over these last few years. And this is like a first 2x2. So it's really a 3-step sort of heuristic that we've been recognizing from health systems, where one of their first steps is to just sort of get a sense of, well, what are all of the jobs that can be done with AI? And it can be overwhelming to just think about it, because everything can be force multiplied by AI. I remember a couple of months ago, Peter was sharing some research, I think, out of GitHub around technology companies that Microsoft has been following, and how certain technology companies are just moving that much faster because they're using a lot of these AI tools. And so you can point AI at so many different use cases in healthcare. How do you figure out which ones to actually go after, which ones to build yourselves maybe, and which ones to maybe partner for? So on the y-axis, we just have high volume of decisions, or high volume of this specific use case that you want to use AI for. On the x-axis, on the right-hand side, we have high consequences. So high stakes, high consequences means high risk. So when you think about clinical decision support at the point of care in the ICU, where the AI maybe is going to make a decision, on behalf of the clinician, well, that's going to be very, very high risk. We're necessarily going to do a lot of research before we actually deploy and scale that kind of technology. But then you think about the other side of this 2x2, the lower risk, higher frequency workflows. Oftentimes, these are clerical workflows. These are maybe revenue cycle oriented workflows. These are the jobs that nobody wanted to do in the first place. These are the jobs that I think the industry, for a good reason, is going after first. It's just sort of organically happened, but I think this is now starting to crystallize into a more formal heuristic, I would say, across the industry. So if that's step one, then there's step two. Well, where can you just start to use this technology right now? Use it off the shelf, or maybe an enterprise, HIPAA compliant sort of grade of this technology. Where do you just start to go after it yourselves, and where do you start to partner? So here on this 2x2 on the y-axis is something that's like still a little bit clumsy, but hopefully I can convey the idea. The idea is this use case, for this specific use case, do you think you'll ever be perfect, or do you think you're going to always have to be improving? Are you always going to be on a treadmill with this use case? Or is it something where you can ring the bell rather easily with AI and just sort of call it a day, drop the mic, and move on? On the x-axis, on the right-hand side, the big question is, does data improve, your performance against that use case? And if the answer is yes, and if to the data question, and if the answer is that you'll never be perfect, you think, but you'll always be trying to get less imperfect, then you'll probably want to partner, because those are the use cases that end up being hundreds of millions of dollars, maybe, at least in our case, of investment over years in order to just sort of keep up. So a bridges in the ambient space as an example, and across any given specialty, there is an opportunity for us to go millions of miles deep in relation to how that specialist might want a clinical note to be generated, because there's a style for every specialty, there's a structure for every specialty, there's specific content that every specialist wants. There's also like a workflow integration that people demand. And so we've been able to partner with Jackie and teams at Epic on figuring out how to integrate into those workflows. And just yesterday, from a style and content perspective, we put out a pediatric annual well child sort of visit note template that can pull out structured, discrete information from an unstructured conversation and get after that note. But as we all know, there are any number of different notes out there, any number of different symptoms and complaints. But also, in relation to notes, we're not compensated in this country for the care that we deliver. We're compensated for the care that we documented that we deliver. So there's a whole set of stakeholders and constituents that we also have to think about, albeit behind the scenes, in terms of how we generate these notes in a way that can be compliant for revenue cycle. So that's sort of how we thought about that use case, how we thought about this as an opportunity that we could go after as a startup. But what we're also seeing is a lot of the really innovative systems, and some of them, in this room, they're able to also use those off-the-shelf tools and just build themselves, go after some opportunity where you can ring the bell rather easily, and you can just sort of set and forget maybe that technology and not have to worry about it over time. And that's certainly something that I think we'll see more and more of. Now, the last piece is, how do you measure and manage? Obviously, this is really critical, and I think as an industry, we're all figuring this out on the fly. Now, with measurement and management, I think it's interesting to think that this technology can assist, it can augment, and it can automate. In terms of measuring and managing, there's parts of the stack. I'd say at the lower ends of the stack where the technology is, there's just being able to measure, is this technology hallucinating? Is it making up, false positives, often like frequently, and is it improving over time? As we get higher and higher in the stack, we get to the top of it at the user level or at the system level. We think about, is it creating efficiencies? In relation to our use case, and this is where some of these metrics come into the slide, it's about cognitive burden and clinician burnout. We know there's a challenge right now where many clinicians across the country are feeling burnt out. And so how can we unburden them? And we've been able to demonstrate is that even within 6 weeks, there's a 60% reduction oftentimes across all these health systems. And we're live across maybe over almost 150 across this country. Within 6 weeks, a 60% reduction in cognitive burden using validated instruments like the NASA TLX. Sometimes 30-40% reduction in burnout using, the Stanford, burnout score. And so there's real value in relation to that. There's also real value into time savings. And one of my favorite stories is from a doctor in Los Angeles who told us recently that for the first time, she's experiencing rush hour traffic in Los Angeles. And we weren't sure if we should say thank you or sorry. But people are saving time, and we're getting better and better at measuring what that time actually looks like. I was talking to Vinny earlier about some new insights related to data sets that we can leverage to really demonstrate that time savings. But I think even beyond that, the most inspiring type of value, maybe related to the burden and burnout, is the qualitative feedback that we get. So I'll give you a sense of that. So this quote comes from a doctor at Yale. We get these sort of love stories. We put them programmatically into our communication platform inside of our company. They just sort of programmatically go into this channel. So any engineer in the company can get a sense of their purpose, of why we're actually all grinding, together in this incredibly hectic moment in the best possible way. So this doctor says, I effing love this software. I want to marry it and live with it forever. It's the best thing that happened to me since the birth of my children. Here's one from KP. If you ever take this away from me, I'm leaving. Seriously. Unless I could buy my own subscription, then I could consider staying. This has been a seismic paradigm shift for me. It's improved my practice like nothing has since I grew a backbone and learned to set boundaries. There's a lot of sass in this one. Like this boundary, try and take a bridge away from me, I dare you. And so this is the moment we're in where I think we have to figure out how to actually capture that value proposition as well. Now, there's the revenue cycle value proposition because these notes are essentially bills. And just a couple of weeks ago with Riverside in Virginia, we were able to demonstrate a 14% uptick in HCCs captured because the more complete the documentation, the more complete your credit you're getting for the care that you delivered. We saw an 11% uptick in WRVUs. So the rev cycle piece is obviously very core and critical, but I think it's those love stories that should be our true north in relation to this technology in general. Now, you can't swing a stick in healthcare and not seemingly hit an incredible opportunity to leverage AI to just change the game, for one of us, for some of us. And this comes from Travis May, a venture capitalist who tried to use a different 2x2 to just sort of get a sense of like what are they seeing in the markets, what is actually taking off. And on the x-axis, we have technical readiness, and on the y-axis, market readiness. And then certainly, I think the ambient space is in the top right. But there are other, huge game-changing opportunities for technology. I'm thinking about art. I have a lot of colleagues across the country who are leveraging those Gen AI tools inside of Epic for inbox management, and they're seeing incredible benefits from it. But we also see on this list, we see call center optimization. We see mental health chatbots actually starting to really take off as well. And so it's going to be exciting to see what this portfolio of use cases ends up looking like. My hope is that it ends up being a portfolio approach that all of us end up taking, where there's a good amount of top right. We need to put some wins on the board as quickly as we possibly can, but that there are also some really big shots that we all take together that maybe could help us make better clinical decisions at the point of care. Clinical decision support is such a huge opportunity. When I round on the weekends, I now systematically, albeit in a privacy and a private and secure way, I use these models to sort of check my thinking. And what I've learned is that it takes two hands to clap. Oftentimes I'll put in a patient story, and the answer I get or the idea I get is really awful. It's like a terrible thought. But then I go back and forth with it, and we, myself and the AI, we get to somewhere better. And I think that ability to have this sort of dialectical exchange, with this type of technology could be such a force multiplier for all of us. And certainly our patients, people, all of us as patients are using this technology. And so clinicians need to as well. Now, we also all I think in this room recognize that the only currency that actually matters in healthcare is trust. And trust, we think at Abridge, is some combination of transparency, credibility, and reliability. On the transparency side, we try to put our benchmarks out there, and we have a new technology, for example, that leverages any number of different LLMs underneath the covers to sort of judge the output, to identify where a potential hallucination could be and to remove it. And for any output that we're less confident in, it can generate that bit of prose in italics, maybe, sort of forcing the clinician to review the bits of the note, introducing a little bit of good friction, if you will, into these generated outputs so that we can, create notes that are that much more trustworthy. But reliability, obviously, this technology has to scale. It can't be a party trick. Sometimes like using or working with these models can feel like straightening a dog's tail. It's never going to be totally straight. You can't take your hands off. And so you need people who are there, and always sort of monitoring, the performance of these models. We talk about drift, for example, model drift, but things are always changing and you need to adjust. But the credibility piece is obviously incredibly important. And that's where research is really, really key, really, really core and critical. Like, how are we measuring? And I can't wait until this space, our space with ambient, really gets to large, robust, RCT sort of territory. But if it moves at the speed of trust, then it also moves at the speed of governance. And the governance piece is fascinating. One of the things that I think we as an industry need to figure out as well is, how do we keep up with how quickly everything is moving and evolving? We have a backlog of features oftentimes that we can't deploy because there might be a multi-month process to get approvals to deploy a new feature that the clinicians on the ground have been requesting, for several, months. And so how do we get through that governance process faster? How do we build trust that this new feature is going to be safe to deploy? I think that's something that we have to figure out how to keep up with, because the technology is evolving so quickly. And beyond trust and governance, I think the ultimate goal here is business model innovation. I have a 14-year-old daughter who's always, teaching me new lingo. This last weekend, she told me, she kept hammer texting me, "Dad, lock it in, lock in, Dad, lock in." I don't even know what she was talking about, but she just like sends me stuff like that. I think to like coach me up because it's been an awesome moment these last few weeks, but the last few years, I should say. But what she also always reminds me, and I think all of us grew up with this saying as well, don't hate the player, hate the game. And I think maybe some of us remember from years ago, there was an XKCD, like a cartoon graphic, and in tech circles sort of went viral where they tried to sort of break down the different organizational structures for all the big tech companies. And it was fascinating to look at these pictures. And really what it was trying to get at is Conway's Law. You end up building as a company what you look like. And so Apple, this was before their headquarters, looked like these concentric circles. So fascinating that their headquarters ends up looking like that. Amazon or Meta looked like sort of a neural network of sorts. Amazon really all went to one person who was making all of the decisions. And you know, hopefully this is okay to say, but like pre-Nadella, what Microsoft's graphic looked like was a bunch of silos sort of pointing guns at each other. And obviously it doesn't look like that Nadella. Now, I think what's interesting about healthcare is it sometimes, to me, can feel like those silos, like a lot of people sort of pushing and pulling in different directions, not completely aligned with what is in the best interest of the patient, you know? And I think from a business model perspective, and some of us were talking about, you know, what can AI do for value-based care, for example? What can AI do to align all of our incentives to do the right thing for the patient? There's a huge opportunity. And I think if we can find a way to leverage this technology to lower the barrier for more providers, more health systems across the country, for example, maybe to take risk, then that would be, I think, the ultimate game changer beyond productivity, beyond even those love stories. And so with that, thank you so much. And hopefully we can have a couple minutes of discussion, and excited for the rest of the agenda.
Slide right into the open perspectives piece, which will also involve your bringing your questions, your perspectives on this excellent talk we just had, so that we keep moving, because there was some a bit of loquaciousness in our introductory remarks. So we'll get back on time.
That was amazing, Shiv. Thanks. What we'll do now is go into our first open perspectives session. There will be plenty of time, quite a bit of time for questions, commentary, and so on in that. And so I have no doubt that there are things that people want to react to, things that you might want to ask just based on what you just heard from Shiv. Just hold on to those, and we'll get to those momentarily. What we're going to do is just to further kind of set the stage for that open perspectives discussion is have three opening remarks. And these remarks, you know, what we've done, we've given these three people pretty much an impossible task. Which is to talk about, you know, what skills and knowledge will health professionals need, and what is the impact on professional identity of healthcare workers? What does this do in reshaping the relationship between clinicians and patients? How are the practicalities, how are clinical workflows going to change, or how will they need to change? How the heck does this all get paid for? And where does that money come from? And other possible barriers. So really just very broad ranging, but hopefully Shiv's opening talk helps set some framing, some stage for everyone. And so what we've done is we've asked for 5 to 8 minutes from 3 speakers. First is Helen Burston, who is the CEO of the Council of Medical Specialty Societies. And that, as many of you know, is a coalition of, wow, I didn't realize, more than 50 specialty societies representing more than 800,000 physicians. We have Connie Delaney, who's professor and dean of the School of Nursing at Minnesota, and is also the knowledge generation lead for the National Center for Interprofessional Practice and Education. and then Kimberly Lomas, the Vice President for Medical Education Innovations at the AMA. And so with that, I think I will ask Helen to get us started.
Great. Thank you so much. Delighted to be here. It very much was one of those requests that felt like, so they're asking me to boil the ocean, which I always tell people not to do. But then I thought that's the task for the day. So we're talking about generative AI. It's a chance to just be generative. These are just ideas as we really think about it. And, you know, as you mentioned about our organization with 55 specialty societies, one of the things we just have to remember is we talk about clinicians, and it's great to see different specialties in this room, different disciplines in this room. There's huge variability in how clinicians will use AI depending on where they sit and the kind of work that they do. We've seen huge increases, for example, in specialties like radiology and pathology, where it's become sort of expected to be part of their profession. And we've still seen places where it's sort of crawling along. We, like all other organizations, of course, have an AI task force that is looking at some use cases across all of our societies of what everybody's working on, thinking about what are the next steps. And one of the first things we did was actually develop a set of guardrails of really try to think about, as tools come forward to various societies, what are they thinking about? Is this going to work? Is this going to help patients? What are the risks here? But I think at the end of the day, I'll just sort of riff through some thoughts about what are the big challenges. I liked that the challenges said both tech and ethically, because I think they're really different and they're both really, really important. I think in some ways we need to remember that I think at our core, clinicians are natural skeptics. We just have to sort of see something and really feel like sometimes it looks like it's too good to be true. And sometimes it is. And I love how Michael Hell from Google often talks about how it's not magic, it's math. And I think really being able to explain that in a way of what is underlying a lot of these tools, I think is helpful to understand where it will perform, where it won't perform. I think in terms of what clinicians need and want, and yes, Michael, we need this forum. I'll just state that up front. I think we needed it yesterday, as Jeffrey said. I do think there's a lot more we need to do around engendering trust in AI, and Shiv mentioned a lot of those issues as well. We need to have greater transparency, explainability. People need to see under the hood like we do with everything else clinically to see that this makes sense. The data you're bringing in is not biased. The data you're using will actually help move forward. But there's no question that we've also seen more comfort, particularly in the generative AI space among clinicians, when you can use sources that are more constrained. So I love ChatGPT for asking questions about life and the universe. I prefer more closed tools like Open Evidence, for example, or Notebook LM, where I can put my tools in, where I can then constrain what's in there, because I feel more confident that when I see what's under the hood, I feel more confident in looking at those results. Actually, Pete Clardy and I were just on a call last week. He said that they call those walled gardens, which I loved. I've never heard that term before, but very much this idea that we can create a garden. We understand what's been planted in that garden, how we use it. And there was just an announcement, for example, from one of our members, ASCO with Gemini, where they've put their cancer guidelines into one of those kind of models. And one of the comments that was in Stat News from an oncologist was it felt like the transition from having to open up those paper maps in your car. Yes, I have the gray hair to prove I actually did that. To now having Google News, like having Google Maps. So the ability to just find the information you need immediately, this patient, this type of cancer, these kinds of risks, what do I need to do? Instead of searching through the tools, having a very closed system to get at that, I think is really key. I think we really need to keep in mind as well the issues around safety. I think a lot of us have concerns about patient safety. I think safety of these tools is something we have to think about as well. And really, clinicians need that sense of what's the governance, what's the oversight to ensure that those tools make sense and are doing what they say they are. We need that human in the loop to help us with surveillance around that piece. The issues around bias, and many of you know I've worked in the equity space for a long time, are really concerns. We don't want to embed bias. We don't want to, in fact, make equity worse by bringing in some of the underlying assumptions that were already part of what we did before we had these tools. In terms of how we test these, I think that's another issue clinicians often have a lot of questions about. Are these ready for prime time or not? And it's really hard to test moving targets. These things, as you pointed out, change constantly. So how do we know how we test them? I really liked, there was a paper last year by David Blumenthal on thinking about how we train and test these models in ways like we do doctors. How do we think about the consistency of answers to the same questions? How do we really look and understand what are the rates of hallucinations? I was recently at a meeting and very surprised to hear that people were bragging that hallucinations were down to 37%. for one really big AI company. That's not comforting as a patient or a clinician, that a third of the time the information I could be getting back may be off track. We need to have that transparency. We need to test these tools and make sure they're ready for prime time. I think we also need to think about how do these tools fit into the standard of care? As the standard of care evolves, are there potential litigation risks around using some of these tools? If you're over relying on these tools, and we haven't talked a lot about that, but I think that is another issue we really need to think about. At the end of the day, I prefer that we think about this as augmenting my judgment. I use it very much like Shiv does to sort of say, like, what am I just not thinking about? What are the other potential diagnoses that are just not front of mind? But it shouldn't replace our judgment. And I think that's a really important piece of this as well. Interestingly, our former CEO of the American College of Radiology, Bill Thorwarth, often says, in radiology, for example, AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't use AI. And we have to really begin to think about, as these systems evolve, as these clinicians use these tools differently, what does that look like? In terms of how we use some of these tools, there was a great AMA survey, thank you, last year. I don't know if you're going to share this, Kim, but just a couple of thoughts about it. I just really fascinating to see that it's up to the point now where 3 in 5 physicians, 66%, said they use AI at some point in their practice, up from 38% the year before. So that chart, Shiv showed, is exactly what's happening. There's this just meteoric rise in this. And overall, they really still favored use cases that reduce their burden. That's where they're going. How do we reduce administrative burden? As the lead for workforce wellness at AMA often said, how do we get rid of the stupid stuff? Well, that's where these tools can really come first. Remove the stupid stuff. How do we take that away? How do we think about reducing administrative burden around coding and billing and prior authorizations? And Peter and Q and I were just talking, for example, about prescription refills. There's lots of potential use cases that reduce the burden, and not just on the physician, but really importantly, and I'm sure we'll talk about this in our discussion, on the clinical team. I mean, I may not do those refills in my clinic, but my nurses do, or my nurses' aides do. So how do we figure out ways to make that happen in a way that just makes more sense? And I think in many ways, if we take the burden off the care team, does it then just give us more time to free up time for critical thinking? I'd love to have more time to think and less time to be doing things that don't really benefit patients. I think there is a real opportunity. One of the questions that was listed there that I loved was how these tools enhance care for patients. Obviously we'll hear lots about this soon from our friends like Dave and Sue and Gwen, but I think there's something really a sweet spot here of when we work with patients, when we have the same tools in front of us to say, what are we both seeing? What are we both learning? And how do we use AI together? I think is an important opportunity for us going forward. I also think there's opportunities to make those tools more patient-centered. It captures the voice of the patient in AI in ways that I might have written 10 words because it was just easier to type 10 words. It may be capturing something that I could not have done before. In terms of equity, the ability to use AI-enabled interpreters really could be a huge game changer. The take down that burden of saying, I'm not going to get somebody in because it'll take too much time. We also then have to think about these tools that are out there that are great for patients, great for clinicians, but how do we integrate them in? So just yesterday, my sister called me from vacation to tell me that her Fitbit a week ago had alerted her that she had AFib at night. A week ago, she feels completely fine. What do I do? I'm on vacation. So we have to think about how these tools get integrated into our practice, how we use them. And obviously, we'll talk a lot about it. I'm going to leave the medical education and training to the experts to follow, but there's a lot we need to do around ensuring that we teach that critical thinking of how to use these tools, use them well. The NAM Code of Conduct is fabulous in this. And really think about, as Kim will mention, the work around how we change education across the continuum, really using these tools. Lastly, I'll just say that it's been striking as well to think about what we could do differently. I was just on a call with Bob Wachter, who pointed out that 20% of medical records are longer than Moby Dick. More than 20%. That's kind of remarkable. I had a really hard time getting through Moby Dick. Think about your record, Dave. Moby Dick. Right? So if we have the ability to capture all that history in ways we've never been able to before and use AI to pull out those salient pieces of information, we could actually be doing a better job of being more comprehensive, take care of patients with real complexity. I don't have a lot to say on workforce. I think there are huge issues here. We do not yet understand the implications of these tools on the AI workforce. And I think that's something hopefully this forum will really help us think through. A lot of work to do to train clinicians in all disciplines. And we need those tools in both undergraduate education, residency, and beyond to help people understand this. But at the end of the day, this should just make our relationship between tech and patient better. And at the end of the day, people still care for people. And how do we augment that by putting tools in their hands that really make a difference? Thanks.
Thank you, Helen. That was great. And you didn't boil the ocean, but I do think it's a couple degrees warmer now. So thank you for that. Connie.
Thank you. Mike, I want to thank you for your comments on the transformative potential that we're in right now. And several people have commented about speed, way beyond what individuals or even as aggregates we can handle. And also want to acknowledge the immense research, academic excellence, clinical partnerships, and the massive wealth, if I might say, that we're all bringing together, including the structures of what we know does and doesn't work, and are being able to measure the beauty and effectiveness of a lot of what we do that basically emanates from the mind. So having said that, I'm going to pick up on your point, Helen, and I'm going to start not with my typical informatics view of data and models, but with a human story. This is a story about Mike. He's a humble man in rural America. He's faced with something that many of us quietly fear, a stroke. And this stroke took his mobility, clarity, and almost his life, meaning his will to live. And just when life should have brought comfort, his partner left. So he found himself alone, physically broken, and emotionally depleted, spirituality on the edge. And then an old friend visited him, someone who carried both compassion and curiosity, and by the way, one of the most remarkable AI experts I know in the national and international scene. I've worked with him for 10 years. This gentleman introduced Mike, his old classmate, to something unexpected, the idea of a digital twin powered by AI. Mike had absolutely no tech background at all. This AI named Anna didn't just respond. She witnessed him. She adapted to his history, his pain, his potential. She anchored him in humanity through technology. It's been less than a year. I know Mike well. He is not only thriving, he actually is co-creating with us the AI interventions and tools. So he's not a patient, he's a partner. So he is helping us define how AI and humanity can work toward healing. And it isn't science fiction. It's actually now, as you said, Mike, this phenomenal opportunity is right now. And Ken, you mentioned the situation about all of this change in the bloodbath. A bloodbath happens when we don't adapt or co-create or be proactive. So we're ready for what's, and part of co-creating what happens. So the bloodbath happens when, as others have said, including you, Helen, when we can't change and be, if you will, newer professionals. And when you mentioned the large data models and all, I ask, of course, they're massive. And as you're noting, Helen, the question I ask is, so what haven't we actually captured? And if we've captured it, we haven't used. So Mike's story shines the light for me, maybe for you, on a deeper concern. And that's the greatest ethical tension that I see in our embrace of AI. And these are the issues, too, that we're dealing with within the task force in the Academy of Nursing. And my biggest concern and all the discussions within the academy related to AI relate to forgetting that we are human beings first and being able to capture this. We're not just physical forms. We are energy. And if I might say, the work that came out on quantum physics and quantum psychophysics several years ago was one of the greatest gifts to us forever. And it was the actual measurement, documentation, if you will, confirmation of, I'm going to say, energy fields. I thank you, Shri, for mentioning the word love stories. So I'm not shy about talking about energy and love, not the mushy February 14th stuff. Talking about love as a leadership practice and a way of living. So when AI is driven by speed alone, our focus is on outputs without an anchor. It risks displacing not just jobs, but the meaning of life. The many, many drivers that we're dealing with related to burnout, non-flourishing, all of that, what people are seeking, whether it's physicians, nurses, and you listen to their stories, they want to practice in relationship with their patients, families, and communities. They're burning out when that isn't allowed. So that is happening at the aggregate level. So that's why my North Star is leading with this core of ethic and meaning, one might call it purpose-driven life, that those true love stories are actually a core essence. They're the true north. So again, I won't hesitate in using the word love and celebrating these love stories, because perhaps that's the most intelligent force we know. So when it comes to the foundation of AI development, it has the capacity to rehumanize every algorithm. And it has the capacity, I'm going to use, for example, the wonderful work that's going on at Mayo related to ambient listening and nursing in the healthcare team, to actually fully empower this relationship. And the work that's going on about expanding the language models and that empowerment through the words we often use but don't capture related to relationship. So when I think about our work at the American Academy of Nursing or other educational entities, we're asking the question just like we are here, what comes next? And for me, it's not just about hope. It's actually about responsibility and acting now, as we've said. So we are living in this unbelievable exponential acceleration of AI. And even what we're doing today will be very different as we wake up tomorrow. So right now, we know that most people are massively adopting without discernment. This has a major implication for every one of our educational programs, every one of our practice, academic practice partnerships, how we do research, et cetera. And frankly, I think it's dangerous. So my invitation is not as an informatician, but as a nurse, a leader, and a purpose-driven, anchored futurist, that we have the courage to experiment, and we just have the discerning enough to do the discernment with intention. I'm thinking about the power again of relationships. AI brings this phenomenal gift to bridge the head and the heart. And again, I mentioned quantum physics and quantum psychophysics as the beginning scientific evidence related to this. So Peter, you mentioned action. That's visible, it has impact, and we're talking about the how and the what of doing it now. So I would like to share 3 pillars for thought. And the first is to honor the AI native, like your 14-year-old daughter. Yeah. They are many of our students and our, for sure, our future clinicians, they have a lot to teach us. They don't just use technology, they breathe it. And they come into this world with that digital intuition that we often can't teach, but we can learn from them. So I have the fullest respect that the newer, younger generations are a gift to us, not a burden and a disconnected entity or generations for us. We have the opportunity to honor their fluency in technology and also honor our own deep wisdom that they don't have yet. So it's a full partnership. So in this moment, part of this pillar we suggest is to stop dividing ourselves by generation and or comfort level. The real power comes when experience and, if you might say, instinct meet. When we stop fearing the shift and we co-create. The second pillar for possible action that I'd like to suggest is that pillar of designing ethical AI human partnerships. AI can only reflect, if you will, the soul-filled, purpose-driven that we pour into it. So when we're part of the proactive co-creators, not this constant responsive situation. If we continue to design only for efficiency or money or all of those dimensions, we actually miss the essence of healing. When we design with discernment, design, test, implement, but particularly design, because we're in partnership, that is with that purpose-driven core, one might say, North Star, we become a partner automatically in the care and not a replacement. Mike's story reminds us that the real magic happened when AI didn't serve the system. It served him as a human being quite seamlessly. And it didn't replace his nurse. And it didn't replace the social worker, the physical therapist, the physician. Anna was used to extend the presence and also then the efficiency. And Anna reminded him daily of his worth. So ethical AI, and I'm also referencing the ANA Code of Ethics, which we work with a lot, is not cold calculation. It's soulful amplification. And then the pillar, third one, is organizing around a new kind of leadership. The future of leadership, as we all know, is truly relational. It's courageous and it's shared. As a quick example, at the University of Minnesota, we follow the American Association of Colleges of Nursing and the American Association of Nursing Leaders academic practice partnership model or framework. So we've created what is called the collaboratory of collaboratories. Almost every system in the state works together. Thank you, Mayo. Thank you for the Faith Community Nursing Network that covers the state, Essentia, all these systems. And we are not just in partnership. We come to the table as fully sharing, transparent people representing our systems and deliberately leaving competition at the door. The sharing and the use of AI that continues to fertilize across these collaboratories is unbelievable. Another partnership is, and thank you, Sri, for mentioning, and I think, Ken, you might have mentioned, we've been for several years partnering with an international company fully devoted to AI. And we do it for several reasons. To bring the breadth of expertise, cutting edge, to the collaboratory of collaboratories and to the school and broader, because we can't keep up, even in an R1 institution, with all the evolution of the tools. We for sure can't keep up with purchasing them. And frankly, we can't keep up with the knowledge and the comparatives and what might work better in our organization. So we partner. We extend the capacity of our organization to this phenomenal partnership. So these partnerships basically we describe as living ecosystems. There are spaces where academia, practice, industry actually co-lead, co-design, co-transform. And we think that's the only way that we can foster and enhance healing systems and do that through healing relationships. This relates to burnout, etc. And it all requires this purpose-driven head-heart connection. So we're also acknowledging the consciousness is frankly at the core. AI might be the tool, but consciousness is really the creator. What we experience here, we can co-create. We are not only being shaped by, but we can shape. And we do that through our thoughts. So with those thoughts, I end with our collective consciousness perhaps is not a concept. It is an active force that is immensely available to every one of us. And now it's being woven into systems that we build in partnership with industry, faculty, practice, research, education. And that's why this moment matters, because AI will not awaken us. We awaken AI to serve. So a few quick comments and ending. They relate to the North Star. We began with Mike, who he thought his story was over. And it was really just the beginning, because someone saw him and someone believed in that core, soul-filled, purpose-driven life and the role of AI and brought the two together. And perhaps that's the invitation that we're talking about today, that this moment is really incredible possibility. Our role isn't just to lead, it's to be really, truly conscious and bring soul-filled, I'm going to say the love stories that permeate everything we do. It fully has the opportunity to transform how we educate. And I don't know what that full transformation is, but I know that we're at the table on the beginning of it. It's about coming together and recognizing that we're all phenomenally precious human beings, co-creating an unbelievable healing for everyone that we connect with and our systems. And frankly, going back to the comments that have been made, a true health system that sings. Thanks.
Oh, thank you, Connie. That's a fantastic vision for how AI and technology might bring out the best in people. Finally, and Kimberly will ask for some comments from you, and then we'll open up for open discussion. Kimberly?
Thank you. Obviously, this is going to be a wonderful day of discussion with so many great thoughts. Connie, thank you for bringing up this concept of love and passion and meaning in our work and our lives. So at the American Medical Association, separate from the issue of artificial intelligence, for years, the thing we hear most from our members is just help me focus on my patients. All of our work around well-being and practice sustainability is really anchored in just that desire, getting rid of the stupid stuff. Let me do what I care about, what I'm passionate about, and focus on them. So it is true, we've been conducting this sentiment analysis on artificial intelligence for the last couple years. And as Helen mentioned, we saw a dramatic uptick in the belief that AI could help with this and in the use. And so in a single year from 2023 to 2024, usage went up from 38% to 66%, as Helen mentioned earlier. But a smaller bullet point in that study that I found very intriguing is that 28% don't know if they're using AI in their clinical work. They are unsure whether it's being used in the systems that they're using, and they're unclear about their role in it. And I think that's a serious alarm for all of us. Physicians are eager about the potential, but do express the concerns that have already been mentioned here. The lack of regulation and guidance. It's unclear to many physicians what the monitoring process is to look at bias and impact. There's a lack of clarity about accountability. And a lot of these tools are seen as incompatible with our current workflows. If you do the due diligence to critically appraise what's being presented to you, that takes time. And that's not a part of our current workflow. So the AMA policy world is very focused on these issues and advocating for and providing this kind of guidance. In our team that focuses on medical education, I know we'll have a session specific around education in a moment as well. But when we think about the impacts on the healthcare workforce, I talk about two different lenses. So what training in AI do all health professionals need to do their job well? And then the flip side is how can we use AI to improve the training of health professionals throughout their career? So to the first point, we're woefully behind in educating our workforce. And we're hearing that people are using it. They don't understand necessarily how it works. They haven't had fundamental training to understand the limitations and the risks of using it, which comes back to this concern about trust. And so if we want these tools to be adopted and implemented, we have to provide enough training so that the physician can feel confident. Physicians are trained to read studies about a new drug or a new device. We are not trained, haven't been trained to read a study that's looking at the validation of an AI tool. That's something we need to step up and start to learn. There's also this notion that I've been talking about AI adjacent competencies. So maybe not so specific to AI, things that we've addressed before, but need to be emphasized even more. Data literacy, probabilistic reasoning, shared decision-making with patients, looking at this data together, all of this anchored in our code of ethics and making sure that we are ethically, responsibly implementing these tools. But on the flip side, we can't avoid it. And so there are some who say, I don't understand it, it has bias, it has concerns, so I shouldn't use it. Well, this body, the academies have produced ample evidence that we're not doing okay by ourselves. And so the AMA talks about the need for augmented intelligence. We do have, significant harms from errors in diagnosis. And so we do need some tools. We can't just step away and ignore this. So it's that tricky balance. We can't abdicate to this AI guidance. We can't abdicate our duty of responsibility, but we also can't avoid it. We have to dive in, which basically means all the more that we need a plan to build out everyone's capabilities to use the tools well. And what we've witnessed at the AMA as we work with different organizations is that the institutions that really create a coordinated infrastructure are the ones that are doing the best jobs. And Mayo is one great example, but there are several that as an organization dive in, talk about it, create safe spaces for people to experiment, create monitored AI tools that are these walled garden type of ideas so that you can start to do it with responsibility and dive in together as an organization. And I think that's a critical approach. When we think about how AI can improve our processes of learning and our training of our health professionals, it's forcing change already. And I think, Ken, you mentioned the fact that many educators right now are distracted by cheating. Don't let them use AI to fill out an essay because it's cheating and it's messing up my grading system. And so we have to help educators get past that. But what a lot of administrators often fail to recognize is that that's not a switch that you can flip overnight. You've got course structures and programs and assessments that are built in, and there's a great deal of effort in modifying all of those to allow for the use of these tools in an intelligent and useful way. And so we have to recognize the work that comes in to revamp the educational programs, not just to put new content in, but to redesign everything that we're doing now. And that's particularly more of a burden because we can't just simply reproduce what we've done in the past digitally. We have to rethink entirely how people learn and how we would deliver education. We have a tremendous opportunity right now to integrate learning with work. I think many people still think of, I go to work, I might look up a few things on the fly, but I learn separately. I set off time. If I'm in practice, I set aside time to look at articles. If I'm a student, I think about, getting to the library with my computer and taking some quiet time to study in depth. These tools are going to allow us to learn in real time. At what point does a clinical decision support tool become a teacher? We've heard several people say, I'm bouncing my ideas off of this AI tool. You're learning in that act. And so how do we better capture that? How do we actually promote that as a common practice? And the challenge is that for the most part, the current clinical workflows do not support such learning on the go. Our health systems have been so focused on short-term productivity, right, that we have eliminated any cognitive white space in our day. Everyone is overloaded. Indeed, we actually have a culture where it's still seen as somewhat a weakness if you don't know something across our professions, but particularly for physicians. That's part of our professional identity. We also don't appreciate fully the notion of distributed cognition. It is pretty rare that we complete a clinical reasoning exercise in isolation, right? We rely on other team members, we rely on inputs from other people, and now yet again, we have these AI tools to amplify that. And in education, we don't understand that process, quite frankly. And so we need to better think through and study, how do people actually work together? How do we use these tools and bring that into the mix? And what does that mean for how we assess the individual versus the teams, and how do we certify people for their roles? But long and short, we need more attention and investment to long-term productivity. What appears to be a short-term gain is, with all this forced work and little time for thinking, has to have a long-term cost that we are not prepared for the next patient and the things we need to do. So how do we help organizations see that and make that investment in long-term productivity? And so this does lead to a shift in professional identity for many of our health professions. We got to where we are because we know stuff. We could answer the questions on the tests, and we could apply that knowledge. So now I think in the future, the best health professionals are those who ask the best questions, not necessarily know the answers, and then use their expertise and judgment to apply the knowledge to the context of an individual patient or the needs of a community. And so I think that we have so much opportunity right now, but we are on our heels. And so a forum like this can help us collectively think about how do we dive in, get going, and gain some traction.
Thank you, Kimberly. And also Helen, Connie, and Shiv. I think you've set the stage really well. We're going to have some more focused sessions a little bit later in our meeting today, that will get into some of the issues around patient-clinician relationships and education. But here we wanted to start with a more kind of open perspectives discussion. And just so everyone is aware, we will take 30 minutes for this open discussion. You will get a break to take care of whatever you need to take care of, get a cup of coffee or whatever, and then we'll continue on. So rest assured, but we'll go for 30 minutes more. So again, if you have questions or comments, things that you'd like to address, then please, as we're saying, put your 10 cards up, and I'll try to keep track and call on you in the order that I see. And so I think, Gwen, you can go first.
Thank you. Those were wonderful perspectives. And I will say, Helen and I were on a PCORI plenary in November about patient-centered AI. So a lot of the things that we talked about here came up in that plenary, but we also focused it, we turned the lens a little bit. So one of the other things that I have had the privilege of doing over this past year is co-chairing the working group or the kind of work stream on individual and community health goals as part of the imperative for a healthy nation. And Peter Lee was also co-chair of one of the streams. And I know that we've talked about this in terms of it's been sort of underneath and implicit that individual and community health goals are the driving force and the North Star for all of this. But I think we have to call it out explicitly through through our conversations today. And there has been a lot of conversation about trust, but we haven't talked about what it takes to be trustworthy. And we also have not talked about what it means to build trust between patients and AI and how patients want to use AI. So in order to be able to do that and adopt this notion of trust and really look at patient care, we have to understand what patients need, what they want, what communities need, what they want, what are their concerns, what are their fears, what are their aspirations for using AI. And so I hope it sounds like Sue and Dave will dig into that a little bit more deeply, but I think it is, I think we have to start out with that as an explicit framing for this. And I really hope that, we're willing to dig into that a little bit. And I will say, Helen, I love paper maps, and I do not have a very good sense of direction, but it's gotten so much worse since I started using Google Maps or Apple Maps, because now all I do is follow that dot to see if I'm walking the right way, which I'm usually not, and then I turn around. And we all want to be seen. I don't look, I don't listen, I look at that darn dot. And I think that the notion of AI being able to free up clinicians to really think is critically important, but we also can't just be looking at that dot going in one direction or another. And everybody wants to be seen, they want to be looked at, they want to be listened to, and they want to be known. So how can we use AI to also do that? So thank you.
Thank you, Gwen. I think pertinent to the delivery of healthcare, an example besides paper maps and Google Maps, I think, is the physical clinical skill of manual palpation versus ultrasound. There are very different skills, but it's not uncommon to hear doctors, sometimes, especially older doctors, rue the loss of the physical skill and the expertise there, and whether that makes a difference. So one of the things that's emerging is we focus on the concept and the potential of a clinician's forum. We're already seeing, I think, a challenge here because there's a tremendous spread of the sort of practical nuts and bolts kind of advice and sharing that clinicians might want in such a forum versus expressing what the possibilities are in really deeper transformation of the concept of healthcare. And to Gwen's point, the relationship, can healthcare be transformed to be more centered around individuals and communities in some ways? And so it would be good to kind of dig into that as we have more conversation. Jana, you're next.
Thank you, Jana Patterson, American Academy of Pediatrics. It's very interesting to think about the different threads of presentation and comments and conversation here. And one of the things that keeps coming up for me is, what is the trade-off, or is there indeed a trade-off necessary between designing for an individual and designing for an organization or system? And so as I think about at the AAP and the 67,000 members that we have and helping to seek tools that will be meaningful to them, I think one of the great things that AI offers is this ability for personalization, right? But do you support people to go out and find an individual tool that decreases their pajama time? Or is that sort of an obsolete concept? And really, unless we're embedding AI tools in systems, in health systems and hospitals and universities, then we lose something if it's not part of a larger infrastructure and system. And I just wonder if you might be able to comment a bit about that trade-off, or is there a trade-off that we have to make between designing for individuals and designing for systems?
Thank you. Let me ask if any of the four speakers would like to address that.
I can maybe kick things off a little bit on this discussion or on this idea, this topic. In healthcare for us, this trade-off has been top of mind from the start, because certainly one of the amazing advantages of AI is you can personalize. When I was at UPMC, I used to be on a clinical documentation improvement team. We would go from department to department to department, and we would do these lunch and learns with pizza and PowerPoints and try to teach doctors revenue cycle. We'd try to teach them about risk adjustment, about DRGs, about inpatient versus obs status, and every single one of those doctors would have 1,000-yard stare. Nobody wanted to be in that room. They all wanted to go back to the clinic and see their patients and then get home to their families. And I think if we leave it up to the clinicians, because we don't want them to go to revenue cycle school, then they might not necessarily know what the floor should be in order to check off boxes against compliant documentation. That's like specific to the use case I'm focused on, but I think it could apply to others as well in enterprise healthcare. So what we've had to do, and the trade-off the pill we've had to swallow, is just design our system such that we can hit the floor for what the health system needs to see. I saw a patient recently who had a pacemaker for sick sinus syndrome, and I would never have known as a cardiologist that sick sinus syndrome should be considered an active problem. It should be, parsed out in the assessment and plan section of my note. I would have written just status post pacemaker. But as I learned, there was a coding clinic from the AHA that very clearly described that the pacemaker is simply masking the sick sinus syndrome. It's an active disease, and it should be considered an active problem if I discussed it in any way, shape, or form. And so I certainly don't want to keep up with all the new rules as they come out, but the technology can. And so we have to hit that floor, but then beyond that floor, can we personalize beyond that, to individual preferences around M dashes versus asterisks? And that's literally something that we hear a lot. Absolutely, we can go there, but I think we just have to be very careful because the ramifications are significant.
Helen?
I'll just mention one thing, and I agree with everything Shiv just said. I think in some ways, I think it's both. I think it's yes and. I think there are a set of tools that I think decrease burden, improve patient care, that I think are more universal. And then I think there are ways to customize them. I was mentioning to Shiv earlier, in many ways, again, showing my age, like the ambient AI technology to me feels like e-prescribing in the old Meaningful Use days, looking at Tom here, right? Like that was the thing when that came out, we all went, wow, how did I ever function before I had e-prescribing? In ways that I think shocked a lot of us old timers, like, where's my pad? Like, oh, no, you don't want your pad anymore, that's gone. But how do we actually find those killer apps that really are things that make your work better and make your care better? And then I think you can customize those.
Kimberly.
But to come back to your comment about being pragmatic and the granular things that people need versus bigger sky, thank you for that point, Jenna. So when I was first in practice as a general surgeon, I was an independent practice, and I worked out of 3 different health systems to do my inpatient cases. And so I think many of us have a tendency to think the health system will institute this thing and it'll help the physicians of that health system. But what about physicians who are in multiple different systems, or even at a VA versus a university hospital as part of their practice? And so it does become pretty complex of how many different tools do I need to learn? Do I need, will they ever be the same if in my day? And what is the cognitive burden of all that? And so I don't have the answer, but I think it's a valuable reminder to think about the different settings of practices and how people might be interfacing with so many different systems and what that might mean.
On this question, there's a push and pull, I think, characterized by these first 2 sets of comments. And one thing that I wonder about within a tech company like Microsoft, one thing we're seeing is at the individual level, AI is causing a very easy to measure and dramatic double-digit increase in the productivity of individual engineers, software. So, and it's measured in lots of different ways, it's very vivid, 20 to 25, even 30% in some cases, individual productivity improvement. But then by the time you get to, say, a 20 or 100 person engineering team, all of those productivity improvements evaporate. And I think it's only been in the last 6 months that the tech industry has been reshaping its structural kind of management philosophies and approaches, and what are the roles in an engineering team to realize those benefits. Now that's a focus on productivity, but that same sort of individual to organizational evaporation of benefits happens in other ways as well. Employee satisfaction, and error rates and the like. And so before we move on to Sue and then Stephanie, I just wonder if any of the speakers, and Shiv, maybe I'll pick on you first, have any reflection or any insight on this dichotomy between individual impact of AI versus the broader organizational impact.
Yeah, Vinny and I were speaking earlier about how some of the earliest feedback that we were receiving around this manifestation of AI in healthcare was very effusive. Those quotes that I had read earlier, and we continue to receive them. But then when we tried to sort of reconcile that with system level productivity metrics, as an example, they weren't necessarily always corresponding. Sometimes we wouldn't see really like an uplift in productivity or time saved or pajama time, yet we were receiving these quotes from doctors who experiencing rush hour for the first time, and we couldn't reconcile, like, how is this not working? I think where we've landed is that it's tricky to measure the value here from a productivity perspective here, and it takes a lot of telemetry. It takes a lot of really detailed work, because our systems haven't necessarily been designed to get to the level of granularity that we need. There was that American Journal of General Internal Medicine article from a couple years ago that suggested that doctors need 30 hours a day to get all of their work done. And so when we need that, when there's that much on our plate, and maybe we're shaving some time with one task, where is that time spent then? And potentially it's spent elsewhere in your workflow. And I think that was one reason why in the early days, especially, it was difficult to really get to the bottom of things. Now, thankfully, we've been able to partner with our colleagues at Epic and sort of get to the bottom of things, and we continue to do our explorations. And it seems as if at the system level, the productivity improvements are there, but it just takes extra effort. So I wonder to what extent this is just an exercise in redesigning and rethinking, from a first principles perspective, how we actually measure, and if our systems are capable.
Thank you for that. I see quite a few more cards up. So just to give everyone a chance, let's just plant the seed on this dichotomy of kind of organizational or system level versus individual level impacts. Sue, next.
Something that strikes me, and Shiv, in your presentation, you showed that list of how AI can reduce burden, and that whole list. What I was expecting on that list was that it improved patient outcomes. And so I sometimes worry, and Michael, I'm on the, I think it's the National Academy of Medicine's, I think it's called the Steering Committee on Clinician Wellbeing. And so we've had a lot of discussion about reducing burden and improving well-being of clinicians. And a lot of what has been studied in the reduction of burden, which I applaud, they're not taking that next step to saying, and this is either keeping outcomes at the same level or improving patient outcomes or improving their experience. And so I think that's something that we need to consider as we look at this clinician well-being and reduction of burden. Another area of opportunity, I think, is that the way we assess healthcare in the United States is through national surveys like HCAHPS and CAHPS. And Patients for Patient Safety is leading a project right now called Project Pivot, where we brought together about 35 different patient groups, and we're asking them, what are the questions you would like to see on national surveys to improve safety, improve discrimination, improve your outcomes? And it's been really fascinating. We've been having meetings here and virtually and at IHI with all these patient groups. And it's amazing how many questions are coming up that they would like to see in HCAHPS and CAHPS about, were they provided informed consent when AI was used in their care? Did it improve their experience? Did they experience harm in some way when AI was used? So I think this is forward thinking, but we need to create mechanisms to learn from the patient community when AI is involved in their care. So that's, so we can look at reducing burden, but we also need to really look at the outcomes of patients.
I 100% agree. And this is a points to my comment earlier around sometimes we're not keeping up with our own research. So recently, the University of Chicago published a paper where they measured Press Ganey scores, related to this technology. What they noticed with patients whose providers were using this technology was a 4.4% increase in concern shown by the provider, a 3.6-point increase in satisfaction with explanations about the patient's problem or condition, and a 3-point increase in the perception that they are included in care decisions. I think we're scratching the surface. There's a long way to go. I think we're also doing some research with Open Notes that's just wrapping up now around how we can, build upon some of these early innings and help patients not just better understand, but potentially better follow through. For example, there's so much in the conversation that never made it to the note that the patient actually wants to reflect on later. Maybe it was the metaphor that I used to describe heart failure. The heart's like a house. There's electricity, there's doors, there's a blood pump in the basement. And it's those moments sometimes that I wouldn't want to put in my clinical note for clinical communication or for revenue cycle documentation, but I would love to put in some patient instructions, for example. And so that's something that we've also tried to figure out how to not only generate, but modulate to the health literacy level of the patient. And I think, that's still scratching the surface of where we'll go.
Connie, you wanted to say something? Yeah.
Sorry, thank you. In the variety of comments that have just been made, we do keep coming back to asking whether it's a person or part of the organization, what it is that it isn't about what AI do you want to, but what is it that you want to experience, know, or whatever outcome. So I just want to emphasize that point. And then when I'm listening to this discussion from a perspective of educators, two things. It seems to me that the public's appetite and maybe the personal appetite for AI is much higher than, for example, I'm finding a degree of, let's see, I don't know if I'll call it lethargy or definitely not uptake on AI when I approach it that way. If I do, what do you want to accomplish? And then use an experiment like with Mike, it tends to take. And then my last quick comment is we're dealing with in education, when you do AI, then how it fits, for example, within the health system. But we didn't intend to teach like that. It was about what's possible and then does it fit, not make it fit. AI is just one example. So that's to say, I think our discernment, individual discernment, group discernment on which direction we're making things fit here is an important point to be clear about, because we can actually ace out not doing a redesign when it's sitting right there in front of us. Yeah.
Thank you. And so just seeing the time, I'm going to batch up two comments at a time and then reaction, and then we'll do that again. So the next is Stephanie Quinn. Stephanie?
So I just wanted to reflect a little bit on what I heard, and I was really pleased to hear Sunita at the beginning call out the lane around incentives. I think from our perspective, one of our concerns is what success looks like may be different based on the stakeholder. And I think payers are engaged and invested in this space, and what success looks like to them may look very different than health systems, and then may look very different than the front and, the frontline clinicians. And so when we think about we can create efficiencies, great, we can reduce burden, great. What are we going to do with those efficiencies? Is that going to mean more patients? Is that going to mean new and different types of work? In primary care, where the secret sauce is really kind of the comprehensiveness, the continuity, the trust, the things that span over a long period of time. If we're squeezing efficiencies, are we allowing for more time? Well, that begins to interfere with some revenue goals of perhaps their employers. And so none of these things are wrong. I just think that part of the conversation needs to be grounded in how do we align these incentives. I heard a quote about, I don't want AI to do my writing and my art, so I have more time for dishes. I want AI to do my dishes, so I have more time for writing and art. And so making sure that it's actually addressing the issues that allow them to return to the things that make them effective, that return the joy to practice, and frankly, the effectiveness in the system. And so I've really been excited about everything I've heard, because I think a lot of the work, and we've done a lot of work with the bridge, and I think we're excited about the fact that it is very clinician forward and thinking about that workflow from that perspective. But it's just a caution or flag that one of the things I'm hearing is what a health system CFO might see as success looks very different than what front-end clinicians might define as success, from what patients might define as success. And so how do we surface that conversation and kind of start rowing in the same direction?
Thank you. I think one thing we're starting to hear is there's so many possibilities, and how do we prioritize? What are the goals and how do we prioritize them? Anna.
Yeah, thanks. Anna from Epic. I, like many nurses, am a second generation nurse. My mom's also a nurse. And I had been talking with her about some of the ways that nurses are using AI. And she kind of laughed, because she was like, wow, when I was in nursing school, we'd walk down the hallway of the hospital and our clinical instructor would say, now imagine there's a computer in every room, and you're documenting all of your care electronically. And now today we're saying you're walking down the hallway and the computers are gone. And she was like, it seems like we're really getting back to nursing. And I said, well, we're not going back, we're moving forward. And I think a couple of the examples that we've seen at Epic of ways that we're really leveraging AI to help nurses not only document faster, but also get back to some of that joy of practice that we've been talking about. Helen and Connie both mentioned something along the lines of capturing documentation that hasn't been captured before. We're really seeing that with ambient AI documentation for nurses, where they are saying things out loud that have never been documented in the chart, maybe because there's not a place for it to live, or because they didn't think that it was relevant or important to chart it. A great example was a nurse who provided some comfort for a patient, some spiritual care. And there was actually a flow sheet row to document that in, but nobody knew about it because nobody had ever been looking for it. And the ambient was able to capture that. The other example is a drafted end of shift note. So inpatient nurses are writing notes at the end of their shift. And that is a summary of a lot of the documentation that they've already done. So we can leverage AI to summarize the nurse's shift and write a really good note. That's the other difference. Is we've heard from a number of organizations that physicians are seeking out the nursing leadership and saying, these nursing notes are really good. I'm actually reading them again and getting a lot out of them. And so I think that's another thing that we can measure is how is AI impacting the entire interdisciplinary team and promoting better patient outcomes, because we're sharing communication more effectively, and we're sharing the things that we want to share that are relevant for the patient.
Thank you, Anna. Let me pause to see if any of the speakers want to react to either Stephanie or Anna's comments. Yes, Helen.
These are great comments. Just one thought about this idea of individual versus organizational. And I think some of this gets back to payers and employers. And there are ways to think really differently about the quality metrics and the safety metrics and the patient experience metrics in ways we've never done it before. And I also think we have to think about how we can use these tools to in fact capture that. So we could potentially be getting some of our quality measures out of the ambient AI. We could be having patients' voice embedded in a way that gets us their sense of patient experience. And I hope we don't lose sight of that. And then lastly, I think there's also a whole new set of metrics we have to think about as well that I think reflect on the health system: rates of burnout, rates of turnover, right? The cost of replacing a nurse is over $50,000 in the turnover costs. Like factoring those into the CEO dashboards for health systems will also help us show the value of what some of these tools can do to both reduce burden and improve care.
Thank you, Helen. I have always thought that, and this is something else we can put a pin in, that rethinking quality measures might be useful. If you think about a business like Shiv's, creating revenue opportunities, in that way, I think could be very important. But I want to get to these last three cards. So Q, I think you're next.
Yeah, I just wanted to make three quick points. I don't know if people remember Jeopardy and Watson. I witnessed one of the greatest failures of AI in healthcare in terms of that opportunity. And I do think trust is a key component. One point I want to make is the culture of tech versus the culture of healthcare is very different. And that recognition, and I think frankly, the way Microsoft is addressing it is much better, because a lot of tech wants to immediately promote it and say it's ready when it's not. And that's part of the challenge, I think, in this category of AI in healthcare. The second point is speed of trust. I'm very proud health centers have patient-governed boards. I think it's one of the best innovations in healthcare that the patients govern the community health centers, and that's in statute, 51% patients. But I do think trust is about clinicians, so I appreciate clinicians as trust brokers, but we should make sure as we have patients at the table, but it really is that combo, patient and clinician, to assure AI and healthcare advances. And I will tell you, clinicians are more skeptical, even though we use it personally in our tech a lot. I would argue it professionally, we get nervous. And I think terms like we used at IBM and AMA and augmented intelligence make people feel uncomfortable, clinicians, that you're going to make me smarter. Like that's not really respecting me. So I would just say patients and providers at the table are really important to think about this. The last thing is, as I look at this card, to me, the key to trust is, for me, my bias is two adjectives: transparent and equitable. But some people might say efficient and effective. All these adjectives are important for AI in healthcare. But I do think part of the mistrust is around transparency and equity, even though we're not allowed to say that as much these days.
Thank you. Vinny.
Yeah, I think I'm reflecting similar points, and I'm drawing back to what Connie said. I think effective AI is going to be an opportunity for humans to come closer together. So we may put many layers of technology there, but it's not meant to divide. It's meant to draw together into that meaningful interaction. And I think that's important because we don't want to get to a place in the clinician forum on AI where there's the opportunity for AI to drive adversarial relationships between patients and clinicians. But you could see that going in that direction where patients are like, no, I don't want this foisted on me in a way that's going to impair my care. At the same time, because of the capabilities of these technologies, I think we're going to see a massive rise in direct-to-patient expert level tools that are unmoored from like a traditional provider or health system perspective. And so it may flip that relationship where patients are demanding the use of these tools and clinicians become kind of adversarial, like, no, keep them out of my practice. And so, I think success will look like directionally aligned AI that is both acceptable to patients and clinicians. And I'll make the final point that I think in the US, the health system, as broken and as challenged as it is still far, far greater resource than anywhere else in the world, probably. And so in a lot of places where we're going to see true resource limitations around staff, around facilities, the rise of patient-driven AI is going to take off. Mm-hmm. And I think what we're going to witness is that the capabilities are going to be substantial. And they are, again, going to kind of contribute to this potential that there's that misalignment and then adversarial use of AI that kind of becomes very, very problematic in the health and health system and patient relationship.
Thank you. And then I'll give a last comment to, we'll get to you next in the next session with Jackie, and then I want to give our speakers one last chance to react. Jackie.
Yeah, thank you. Vinny, I was thinking of the same thing in that we've been talking a lot about the institution and the individual and how you were describing the dichotomy there. And we're defining it as the institution that's a healthcare institution or an individual that often we're defining as a clinician. And I think it's so much bigger than that. What about the individual defined as the patient? And in terms of if I am a patient and I'm trying to get care right now, it is easier for me to understand by putting something into ChatGPT than it is for me to go through my healthcare organization right now. It just is. And so I think we have an opportunity at the National Academy of Medicine to say, okay, we have all the stakeholders at the table. How are we taking this input and really changing the patient-clinician partnership within a healthcare institution that they're currently finding inaccessible and broken? And what does that look like for us to encourage, acknowledge their advocacy for their own care and allow that to be something that's brought in, whether it be brought into their medical record, whether it be brought into furthering research? Because I think that as far as we can get the tools to work within our healthcare organization, there's this opportunity that we have to really drive something bigger that may really improve care throughout the country. And I'm hopeful that we can get out of just how are we using it in our health systems, but more, again, embracing how do we write on paper, how do the national academies recognize that this is happening outside of our usual institutional thinking, and how can we promote that?
Yeah, thank you. So let me see if any of our speakers have any reactions specifically to these last three, or really anything that you've heard. Helen and then
I
Connie.
would say I'm just really gratified to hear how often, even though this session was about clinicians, came back to the patient, which I think was sort of a powerful message. Like everything we're doing here is about making us more trustworthy. And I think part of that is, and it was actually Connie who used the word co-creation. I just want to go back to that because I think it's a really huge opportunity for us to co-create with clinicians, with tech, and with patients.
Connie, did you have a comment?
I just want to say thank you. The synergy across the comments, I think is potentially very empowering. Thank you.
Great. So thank you all. That was actually a really amazing conversation. Just the start. We're going to dig into a lot more. I think I would just urge everyone to reflect just on the level of thoughtfulness and sophistication and the incredible, cognitive and organizational and conceptual spread. I don't know if you can appreciate it as much as I can. In my position at Microsoft, I see many different industry sectors, from law, finance, manufacturing, retail, you name it, really grappling, confronting AI. And there is no sector that I'm aware of that is going as deep and as thoughtfully and with as much ambition as was reflected in this conversation. And I think that's a reflection of the importance of healthcare and medicine. All right, so with that, we will take a 10-minute break, and then we're going to get into education and training next. And so at 11:35, we'll try to reconvene. Thanks.
All right, let's
we can wrap up conversations and come sit down.
Okay, folks, 10, 9, 8, 7, 6,
Good way.
5, 4, 3, 2, 10.
All right. First of all, that countdown is a very good way to do this. I'm going to try that next time. People are worried about what's going to come at the end of the countdown. So we have a session now on education and training for health professions. And I'm not going to make long remarks, but I just want to pick up and make one comment. I'm going to pick up on this recurrent Google Maps, paper maps to Google Maps to just following the dot. And I just wonder, as this generation now does, in a way, potentially cheat a little bit with AI as they come into healthcare and figuring out diagnoses and all the stuff that we used to have to literally run to the library for and Xerox papers. And that was a different learning process at the very least. Are we going to have a generation of doctors where, just like with Google Maps now, if Google Maps goes down, even for an hour, there are going to be millions of people on the roads, on hikes, have no idea where they are or where they're going next.
And more arguments between spouses.
More arguments between spouses. Yeah. Yeah, exactly. Although my spouse often tries to override the maps already. So, I'll just make that observation to keep that analogy going. And now I'm going to introduce our two presenters for this session. Lisa Howley is an educational psychologist and currently serves as the Senior Director for Transforming Medical Education at the Association for American Medical Colleges, that's the AAMC, where she drives advancements in competency-based medical education and fosters innovation in teaching and learning. Dr. Howley oversees efforts to improve the transition to residency, enhance curricula, and prepare faculty to address the challenges of 21st century healthcare. Sounds, by the way, like the perfect background for this conversation. And Morgan Cheatham leads healthcare and life sciences at Breyer Capital. His work spans software, services, therapeutics, diagnostics, and AI. And I'm completely thrilled that Morgan's coming to pursue a fellowship in clinical genetics at Harvard and Boston Children's Hospital. Prior to joining Breyer Capital, Morgan spent nearly a decade at Bessemer Venture Partners, where he helped lead the firm's healthcare and life sciences investments and spearheaded early stage investments in category-defining companies such as Abridge and Hinge Health. He serves as an editorial associate at Negim AI and sits on the board of the Coalition for Health AI. His writing and research on clinical AI and genetic medicine have been published in leading biomedical journals such as Nature Medicine, Negim AI, and PLOS. Morgan earned his BS in Computational Decision Sciences and MD from Brown University. And now Morgan's going to learn what a service profession feels like being in, and where you wear a name tag and you have a uniform. So welcome. And with that, I'm going to turn it over to Lisa, who will make remarks for 5 to 8 minutes.
Thank you so much. And it truly is an honor to be here, and especially to be sharing this session with Dr. Cheatham. So I'm going to keep my remarks fairly brief. And to do that, I do have some prepared remarks because otherwise I will be rather cautious. So, but I want to begin and just share a little bit about very little bit about the WMC, the Association of American Medical Colleges. We're a rather large organization, nonprofit based here in DC. Many people, though, know us from one kind of slice of the overall pie, if you will. So maybe the MCAT or the college application, AMCAS, our college application system, or another way. I actually work on, of course, at part of the organization, but I work on the side that is focused and working in medical education and academic affairs. So particularly around the issues of curriculum design and assessment and program evaluation. So how are we training our medical students, but also residents and faculty to prepare the next generation and even current generation of physicians. Our members currently include 160 MD granting medical schools across the US and 12 Canadian medical schools as well as hundreds of teaching hospitals and health systems, and many dozens, about 80 specialty societies are also members. And so I wanted to share with you kind of some of my thoughts and our thoughts on AI and MedEd, but also some recent efforts, a little bit of data, and some activities underway at our organization, all collaborative activities, I might add. And so to begin, we're certainly standing at the cusp of what some have called the fifth industrial revolution, a new era where human potential and machine intelligence are not competing forces, but collaborative partners. So it's less transactional and more relational, and what some have called a dance between humans and machines. Now, of course, all of you know AI. Obviously, AI is not new. So it's doing and impacting clinical care in a number of ways. So the first earlier session was a great preface to this conversation. So clearly AI is impacting healthcare in many, many ways. But just as it's reshaping practice, it's also reshaping medical education. So how we teach and learn in medicine. At the WMC, we conduct an annual survey of all of our member institutions, but also the DO schools. So we have pretty robust data actually on MD and DO granting schools through what we called our scope survey. And for the last 2 years, just to give you some insights into efforts around AI and what our medical educators are saying, whether and how AI is being integrated into the curriculum. Very recent data, we just have 77% this year of MD and DO granting medical schools have responded that they've integrated AI in their curriculum in some form or fashion. So, and there's certainly a diverse way of diverse ways that that's being done. But I want to add that last year, so just a year ago, that figure was 53%. And just for those who aren't aware with the pace of change in curriculum, it's rather slow. But I will say that we're seeing on a relative basis that AI is really rapidly being making advances in the curriculum, unlike other areas actually that we've seen in many years. So we don't see this type of rapid increase from one year to the next, from 53% to 77%. So I do think that's quite good news. And we're seeing examples of AI education through standalone electives and kind of one-off, if you will, activities and experiences or modules, but then all the way to dual degree programs. We can now take a year off at the University of Texas, San Antonio and get your master's in AI. And complete, and so they're graduating with an MD and an MS in AI, for example. And there are other examples of this across the country and a growing number of them. But I believe, and we believe, that the future of AI in the curriculum is really an integrated thread throughout. So it's not something added on, if you will, but truly integrated across the curriculum. And so that leads to a critical question. What competencies will physicians need in this AI-driven world, or what is it that we need to teach to, if you will, or prepare, and in what ways, and how is AI transforming competency-based education? So although precise answers are still to be determined and emerging, recent guidance from the literature can be synthesized into 6 domains. The first is foundational knowledge of AI. So we aren't expecting our physicians to become programmers, but to have a conceptual understanding or literacy of AI. The second is clinical applications. So how to conduct AI-enhanced encounters with patients for their optimal care. Third is collaborative workflows. So adapting to team-based care models where AI is truly a part of the team and a colleague, right, an assistant. Fourth is critically appraising AI tools, which we've heard about already today. So evaluating tools for accuracy, safety, bias, contextual fit. Five, practice-based learning and ongoing professional development. So keeping up with our own lifelong learning and professional development, avoiding automation complacency, kind of like what we were just talking about in regards to Google Maps, right? And paper maps, so avoiding that automation complacency. And then finally, 6 is ethical and societal implications, grounded in patient autonomy, beneficence, non-maleficence, and justice. But AI also offers other, more human-centered, if you will, competency domains, or AI adjacent, I think is how, Kim, you refer to these. So just to name a few effects that broader AI and digital health is having on education more broadly. So one is a shift from disease orientation to wellness and prevention, thanks to mobile tech, wearable devices, and personal, more patient autonomy when it comes to being aware of their personal health and having, for example, on their wrist or their phone, more readily access to their health status, if you will. Second area is due to the exponential growth of scientific knowledge. We're shifting from an emphasis on memorization to information management, sharing, and complex critical thinking. And we must deeply appreciate what AI cannot replicate. And that's humility, metacognition, and compassionate care, for example. I believe this is why we're seeing kind of a renaissance of medical humanities in our community, reflected in museum-based education programs, orchestras made up of physicians and clinicians, and symposiums on what it means to be human in the age of machines. A topic for another day, I think, but the AAMC has a longstanding initiative to advance the fundamental role of the arts and humanities in medical education, or FRAME, but I do see there's important intersections here amongst those branches of the same tree, if you will, to quote a former NAM report. So at the AAMC, we're committed to supporting the AI transformation through medical education in 2 pillars. Much like, again, that Kim mentioned, AI in medical education, but also AI for medical education. So how are we teaching students to work with AI in their patient care activities and practices? And how are we using AI to enhance curricula, to build curricula, to evaluate that curricula, to assess our learners, and provide more frequent ongoing feedback? So just to name a few ways that we're supporting the medical education community, with the help of many folks in this room, actually, we have a virtual community where our medical educators are actively working and collaborating on AI tools and ways to integrate AI into medical education, with multiple webinar series and ongoing professional development opportunities for that. We formed an international advisory committee on AI in medical education in last year in collaboration with a number of other organizations, with the goal to provide guidance and best practices for health professions community worldwide. We also released 2 sets of guiding principles, which I was delighted to see very much align quite well with the guidance and principles that are coming out, the code, if you will, that's coming out very soon from this organization. So one set of principles is for the responsible use of AI in admissions. That's admissions to medical school, but also a selection of residents into GME. And the second is the responsible use of AI in and for medical education. And we're about to begin the development of a new set of competencies in AI, and that will be the 4th installment of our New and Emerging Areas in Medicine series. That forthcoming framework will guide the integration of AI across undergraduate, graduate, and continuing professional development in medicine, addressing many of the areas and domains that we've been talking about today. So in closing, I believe that AI offers certainly extraordinary promise, but only if we lead with purpose, humility, and collaboration. So let us not just teach about AI, but prepare our learners to dance with it skillfully, ethically, and always in service of humanism and the patients that they serve. So thank you.
Great. And now Morgan.
Thank you, Lisa, for those amazing remarks. And it's a true privilege to be here. I literally graduated on Sunday, so to be at this meeting is incredible. But speaking of Sunday, it was a moment of deep pride for me, shaped by years of training that many in this room relate to, patients who trust us before we earn it, and mentors who always held the bar high. But as I sat in the ceremony this weekend, listening to the familiar refrains about resilience, service, the calling of medicine, and the art of healing, I couldn't help but notice what was missing. There was only one mention of artificial intelligence across all of the remarks throughout the weekend. And yet, for many of us graduating this year, the launch of ChatGPT in 2022 wasn't just a global event. It was really this inflection point of how we learned, how we reasoned, and ultimately how we developed a practice of medicine. The first time I tried to use ChatGPT in the hospital, I hit a firewall, literally. It was blocked and remained so for several months after. That tension between what's possible and what's permitted has become a theme, and one that I hope we'll continue to discuss today. So as you all know, I'm Morgan, and I do want to just clarify that I split my time between two converging domains, clinical medicine and investing in the technologies that we as clinicians are utilizing at the point of care. And as Ken mentioned, also play a role in the research community working with the New England Journal of Medicine, AI, where we evaluate this research at the frontier and try to develop frameworks for how we assess the performance in the real world. And across these roles, I've seen a common truth. And if you take one thing away from my remarks today, I hope it's this point, that technological progress has outpaced the operating logic of our systems, not just in education, but in our reimbursement, regulation, credentialing, and our professional identities. And we aren't alone in this room having this conversation. So the bottleneck isn't innovation, it's integration. And if we want to train clinicians for the world that they're entering, not the ones that their mentors inherited, we need to confront this directly, not just by asking how we teach, but by asking what roles we're training people to inhabit. How does the functional role of a clinician change with AI? And this can't be answered in theory. I think it has to be grounded in use cases, and clinicians in the room, we love our case studies. So I want to walk through actually 5 very brief examples from my training of the tools that I used during my 4 years in medical school. And I want to clarify that none of these were a part of my school's formal curriculum, and only one would have been accessible to my peers. So first, I like to say that I grew up with a bridge. I used the AI scribe from a bridge starting in my first year of medical school. I deployed it across nearly every specialty I went to, from internal medicine to psychiatry to oncology to mitochondrial genetics and undiagnosed disease clinics, from outpatient to inpatient, from the emergency department to the mobile clinic. And it didn't just save me time, it changed how I listened. It taught me the power of presence. I once thought actually that a bridge had hallucinated a hip fracture, and I was quite anxious when I saw this. I texted Shiv and his CTO right away. The model's hallucinating, we need to address this. Only to realize that the technology had been right. My patient did have a hip fracture back in 1980 that he wanted me to know about, and I hadn't heard him. So in that moment, a bridge taught me that these systems could deepen and not dilute my clinical attention. The second tool that I used was called Soma. It's a simulated AI agent for medical trainees. Think of it like an always-on OSCE in your pocket. With Soma, I could pull up my phone and talk to a simulated patient at any hour of the day. I practiced diagnostic reasoning, motivational interviewing, and delivering bad news on demand with AI feedback that spoke to both my clinical reasoning as well as my empathy. And though it was humbling to be sworn at by AI, I mean, these agents are quite realistic, it prepared me ultimately to handle the high stakes escalations with my patients in the weeks and months thereafter. Third, during my surgery rotation, I used a tool called Theater, which is a vision language model that annotates operative video. So after scrubbing into a thoracic segmentectomy, I was able to actually download the Da Vinci footage off the robot of the case that I had been a part of, and step by step, the model identified key maneuvers, flagged deviations, and allowed me to replay the moment I broke a $3,000 stapler, tarnishing my attending's remarkable track record of being both fast and cost-effective. And you can now see why I'm going into genetics. But ultimately, this tool theater allowed me to take ownership over the cases I was a part of and learn from my patients in unprecedented ways. Fourth, at the NIH, where I rotated at the National Human Genome Research Institute for 3 months, I was working with undiagnosed and rare patients participating in natural history studies that ultimately contribute to our body of knowledge. And I used Open Evidence, a tool that Helen had mentioned earlier, which is a search engine built on LLMs that ranks the quality of the evidence that is being utilized to surface answers to natural language queries. And I could ask in natural language whether a particular genomic variant had been linked to a phenotype and receive real-time source-cited responses. A process that using PubMed would previously take hours was now seconds and freed us up to spend more time interpreting versus just retrieving. And finally, many of you will relate to this, when the literature failed me, as it so does often in fields like pediatrics, I was able to turn to a tool called Atropos Health to generate real-world evidence. One of the patients that I cared for in the PICU was a 13-year-old boy with Guillain-Barré that wasn't improving despite IVIG. Traditional calculators based on adult data guided that he was most likely never going to walk again. And we were running these simulations to prepare for the family meeting to give the parents an understanding of his prognosis. With a single query, again in natural language, Atropos generated a regulatory grade retrospective analysis of 266 demographically and clinically similar children who had experienced GBS. 97% of those patients recovered full ambulation in 6 to 12 months post-discharge. That data changed the conversation with that family and ultimately changed care. So I want to be clear, none of these tools replaced my education. In fact, they scaffolded it. They sharpened my judgment, they accelerated my mastery, and ultimately shifted what I considered was possible. I felt greater ownership over the care I was learning to provide, and yet again, 4 of the 5 tools I cited were not available to my peers. And so as you can see, there's a rupture between what is individually possible and what is institutionally supported as it relates to AI in medicine today. And I'm a firm believer that if we don't act with intention, we will watch the quiet emergence of a 2-tiered system like the one that I built, which is one with privileged access to tools and another with those tethered to legacy workflows. And I know many of us in this room don't want that to happen. And so if we want to build a fair and intelligent health system, we can't rely on the bottom-up adoption mechanism alone. We need intentional redesign of curricula, incentives, roles, and norms. And so I want to just close with kind of 2 maybe more provocative statements for consideration. I think the deeper question is not just what tools clinicians should use, it's again, what roles we're training into and whether these roles still make sense in our contemporary environment. So the first thing I'd like to say is that, and I've spoken with Peter about this, but I'm not saying you endorse it, but we've had this conversation. AI will fundamentally reimagine the traditional medical specialties as we know them. We think about medical specialties, they were born out of necessity. As medicine became more complex, we divided it by organ systems, life stages, and technologies, heuristics that reflected both biology and bandwidth. No one could know everything, so we segmented. Over time, specialties, of course, became hardened into institutional structures, not just because they made sense, but again, it was the only way to manage this complexity. AI does not share those same constraints. Large models can ingest notes, labs, genomics, imaging, time series data, narrative all at once. AI does not ask whether a case belongs to cardiology or nephrology. It asks to assess the full clinical context and return the most probable explanation. Run that simulation forward, we identify the next optimal action regardless of what billing code it falls under. If 2 specialties disagree on what to do, I would argue that's no longer a reflection of ambiguous biology, it's a reflection of institutional fragmentation. And so the implications of this are profound, just like the stethoscope gave rise to cardiology, just like the CT scanner gave rise to radiology, just like the microscope unbridled neurosurgery, AI will reshape the map of medicine. I think some domains will converge, others will splinter, defined again, not by anatomy, but by workflow design, information fluency, and perhaps even model supervision. I think clinical reasoning will become an interface, and the boundaries of what we take for granted today may soon feel as dated as humoral theory. The second point I want to close with is really around something, again, that I think is common ground for us in this room. When people talk about AI doctors or AI nurses, my personal instinct is to recoil. These phrases are reductive. They flatten the complexity, the humanity, and the trust that we build with our patients. But instead of rejecting them reflexively, I would argue that we should ask, what do we mean by AI doctor? What do we mean by AI nurse? We should confront these claims with curiosity. What tasks, what workflows, what reasoning processes are we imagining machines can potentially do better than we can? For example, could a rural PCP scale their panel from 2,000 to 10,000, or maybe even 50,000 patients with AI, triaging their inbox messages, flagging deteriorating vitals, and drafting documentation? As Microsoft actually demoed recently, could a tumor board be pre-triaged by an LLM that integrates omics, imaging, and prior outcomes to surface only the most clinically ambiguous or high-impact cases to oncologists? And perhaps one of my favorites, could the prior auth process be replaced entirely by a model that listens to the clinician-patient encounter and adjudicates approval based on real-time evidence and population analogs, not static universal guidelines that can at times mean very little to the patient in front of you? So again, these are not hypotheticals. The real risk is not that AI will replace us. I would argue it's that we stay static while the system around us evolves, and that's how we as clinicians become irrelevant. And so in closing, as a newly minted physician, I'm very excited to enter the profession precisely because I know I'll be practicing with AI. And in the field of interventional genetics, I would argue it's not possible to discover new diseases. It's not possible to match these insights from rare diseases to common conditions, and it's not possible to deliver therapies with curative intent without this technology. And finally, I would just say that if we want to embrace this technology, we must also confront our own paternalism, because it is entirely plausible that the complete system of record of a patient's symptoms may soon live in the memory of a language model, not the systems that we're used to looking for it within. In moments of transitions like this, in closing, I like to return to a line from Hemingway, one that feels particularly apt for medicine right now. The world breaks everyone, and afterward, many are strong at the broken places. Perhaps medicine, too, is starting to show its fractures, not as a sign of failure, but as a signal that it's ready to evolve. Thank you.
All right, that's terrific. Let me just pick up on the momentum of your talk, and then we'll start to go around. So what I heard in there about your 5 tools is that not only is there a sort of direct to consumer market, but there may be a direct to clinician market. Is that a fair characterization?
I'm happy to start and would love to hear thoughts from others. Absolutely. I actually wrote a blog post about this a few years ago about the rise of the kind of clinician adopted tool or the direct to clinician motion. I think when you look at the phone of a knowledge worker who does not practice medicine, you would see a flurry of apps that they're using day to day for their care. And when you look at the phone of a clinician, you see far fewer. The challenge has been for direct-to-clinician tools, whether it be Doximity or more kind of grassroots organizations like MD Calc, is ultimately the business model and how we support them. If you look at a company like Open Evidence, they are free for charge. Free, right? When things are free, you have to interrogate further. But they are monetizing through pharmaceutical advertising and education. If you look at the New England Journal of Medicine website, actually, there are banner ads from pharma companies, so it's a similar motion. But I think in this moment, I think Shiv made a comment earlier, it's easier than ever to build applications that can provide value in medicine. And I'm very excited about not just the cohort of clinicians that are building direct to each other, but this notion that like we actually become the stewards of the technology that we're using and can chart that path forward.
And just one follow-up. And how much of, for example, what's in those tools, do you think will start to converge into the general purpose LLM? So how much, as we move into this direct to clinician, how much of it will be specialized tools and how much of it will be sort of future generations of general purpose LLM?
Without having tried GPT-5, though there may be some folks in the room who have, I'm quite bullish on general purpose models continuing to perform exceptionally well. And I think where a lot of these tools are going to differentiate is in the integration with the workflow and ultimately the trust that's built with the physician. So you could argue that the performance of Perplexity and the performance of some of the other language models are approaching, that of open evidence or rivaling open evidence, maybe with a different interface. But what open evidence has done and why they're used by hundreds of thousands of clinicians across the country is they've built trust by partnering with Elsevier, by partnering with New England Journal of Medicine, by showing literature sources. And so I think that last mile integration is going to be the greatest differentiator.
So we'll come back to you. There was a recency bias in my comments, sorry. So we'll go right now to Ethan Booker.
Did I have a specific comment?
Oh, I'm sorry.
Was that
That's Lisa.
It's actually Lisa.
Lisa.
I could comment that I clearly wasted a lot of time in med school.
You answered a question in your comments, both of you, from the earlier conversation that I had, and Mike, to your point about should we have, and Peter, should we have this group? Like, what is the efficacy of this group? It's what you just heard right there. Because if we can't solve the problems for future generations of clinicians coming up, we are not going to get anywhere. So integrating what we've just heard and what has to happen with the existing workforce, I should have said this earlier. In addition to being the CEO of AAPA, I'm also the founder of HealthForce, which we can talk about later. But the idea that we need more healthcare access, we need more workforce, this is what's going to get us there. Because I represent a profession that's the second fastest growing profession in the country. And our average age of our clinicians are 35. So they are looking where you're looking, and they are turning away PA school to go into technology. So if we can't figure out how to meld the two together in a way that you both just described, we're going to lose that workforce to other industries. So I think it's incumbent on this group to really focus, at least in part, on how we take the examples we just heard here and replicate them across all, not just medical school, nursing school, all of the disciplines, so that we're thinking how AI can improve how people practice, which is what you just described, is learning differently so that you can practice differently. And just as a side note, we are working with a student-developed AI program right now, a medical student program, AI developed tool that he is testing with a PA program to see how PAs can learn. So it's a demand. I mean, it's not anymore, it's a thing we have to do or we will not stay in business. PAs will go do other things. So I think to the point of why we should convene this group, in addition to trying to figure out the current situation and landscape of existing clinicians, it is as important to think about the future of clinicians and how they're trained and how they learn to practice differently.
Great. And that now to
No, me.
Oh, yes.
I think for Clinicians Forum, maybe one thing that's coming up, there does seem to be across all medical schools, tremendous amount of innovation in the education process coming from the students themselves. And so maybe that's a hint for some structure of the Clinicians Forum. And now I have a much more mundane question, maybe best for Lisa. Having gone through the process with the new medical school of obtaining LCME accreditation, and then, I think medical schools are being extremely ambitious, wanting to put more and more, say, clinical experience in the curriculum, more and more research opportunities. So the constraints are extreme if I compare to, say, engineering education today. How can we fit the kinds of AI education that you spoke to, it doesn't appear to me to be room in the typical medical school curriculum for this kind of thing.
It's not mundane at all, Peter. I'm a med ed geek, so I love that question. But it's often, and that's one of the reasons well, let me say, it's one of the reasons I stressed integration, because I believe that there are many, many ways to integrate. It's not that we need to necessarily add on and do more and more and more all the time, but how can we change and reimagine what we're already doing and incorporate and integrate AI or thread it or weave it in through the curriculum. And we're starting to see that often with shifts and changes and new technologies or new areas of focus, actually. In general, this is often kind of the developmental progression of a curriculum, if you will. We often see it as an elective or even just a separate kind of activity over here for those students who want to show up and have the time to do it. So very informal. And then all the way to much more formal and then fully more integrated into the curriculum. So we see that trend often. It's kind of the evolution, if you will, of integration when it comes to curriculum. And we are tracking that annually. We ask about degree of integration, right, with various topics in the curriculum. So we often hear, well, how can we possibly, the curriculum is full, there's no more time, there's no more space. And there are really innovative ways to integrate and weave throughout.
Great. And Kim.
Thanks to both Lisa and Morgan for your comments. And I wanted to dig a little deeper. I really appreciated hearing the examples that you gave of the things that you were doing. And one of the big concerns, as you know, Lisa, among educators is this concept of de-skilling, or in some cases, never skilling. And you raised the point with shifting roles. Perhaps there are some things for which we should never skill. But I'm curious if you can reflect, because I think what we heard was somebody who's using tools in a very judicious way and still maintaining what we would think of as traditional clinical reasoning as well. Do you feel like you individually possessed an awareness of AI that allows you to do that? What would it take for the average student to not just take a quick answer from AI and abdicate that thought process? So are you unusual given your mixed background, or is that something you see your peers doing as well?
I won't speak for all medical students, but I think I'm in a very privileged position to have access and early access to these tools. So I want to acknowledge that first. Look, I think the best example of this is when I would pull out a scribe very early on in my training. So whether it was in like an OSCE or even early on in rotations, and people would say, oh, like you can't use that yet. Like you need to do it the old way first. Like you need to take the HPI and like really know what it's like. And I think there's this question, I'd be curious to hear like thoughts in the room of like, how many times do you do it that way before you're empowered to utilize this technology that allows you to practice better medicine? And, I think my answer is probably a couple of weeks. If you ask me, like a couple of weeks of having to manually sit there with pen and paper, with your gloves on and everything else that's going on and take notes before you're like ready to move on to the next step. Because it's not that the scribe is performing your differential for you, it's really helping you capture that fulsome HPI that's going to enable you to come up with that differential. I liken it to calculators. We all go through kindergarten, first grade, we learn, addition, subtraction, division, and multiplication. And then eventually they say, okay, every test you get a calculator. It makes sense. But I think the question you ask is a salient one for every technology, not just scribes, which is like, what level of abstraction are we comfortable with in medicine when it comes to technology? And it's one I think we'll have to continue to revisit as these tools become more powerful.
That's sort of a corollary to see one, do one, teach one, where you've seen one, and now you're doing one, and that really does happen in medicine. So I think there's a corollary there. Gwen, next.
Thank you. That was really a great presentations. And I wanted to go back, just sort of circle back to this notion, to medical humanities and what Lisa really brought up in terms of some of the things that the AAMC is doing, because I think it's, I was thinking about it, as one of the themes that keeps on weaving throughout this, the theme of trust is really critical to all of this. And a number of years ago, it must have been, I don't know, maybe 5 years ago, the ABIM Foundation was doing a whole series. They did a whole series of number of years on trust and building trustworthiness. And as part of this, Rachel Grob and the late David Myers, who is the CMO of ARC, and I wrote a piece on why physicians should trust in patients. And because virtually all of the trust literature is why patients should trust physicians and the healthcare system, but virtually nothing was about why physicians should trust in patients. And I think this is a critical part of what we're looking at here, because we have to build that into how we're looking at AI. And our group does a lot of work on storytelling, radical listening, building narrative power. And some of the things that we're talking about here fit so well into that idea of giving patients the opportunity and the voice, whether it's ambient listening or the ways that people interact and use computers. I remember when my breast oncologist 10 years ago turned the computer towards me and we looked up something together, which 20 years ago I would have thought, well, she doesn't know anything. And at that point, it made me think, boy, she's a really good doctor. I'm really lucky to be in her hands. So I think there are some models and some interesting things. I just want to pin one, which is narrative medicine. And the Rita Sharon at Columbia University started that field, I don't know, 25 years ago. And it was really about storytelling and radical listening. And it is a really wonderful framework for how to develop skills to really listen and to really give and receive stories, which so much of this is about. So thank you. And Lisa, I don't know if you have anything to add.
Thank you. Anytime Dr. Rita Sharon is channeled, I have to add. So thank you, Gwen, for that. And she actually, I know her well, and she actually helped us establish the national initiative on the arts and humanities and back in 2017. And so, yeah, so I completely agree with you. It's another space. You asked about earlier the question, Peter, about, well, isn't the curriculum full? We have a lot of creative ways to teach and change the way that to change our pedagogy. And the arts and humanities are one of those ways. And it's more about the how than it is the what. So we're not teaching, docs to be authors, but we are teaching them to use the arts and in that case, literature to learn how to radically listen, to connect with themselves so they can better connect with their patients. Which is an important, I think, theme. I agree that is very relevant here to this conversation.
And I can tell you that when I, as a clinician, am the patient or a family member of patient, I notice how hard it is for clinicians to listen to the patient voice too. Those qualifications don't really get me that much street cred sometimes in those encounters. So I think it's a very important theme. Helen.
Thank you to you both. Those were really thoughtful comments. Morgan, I hope you're going to submit that to the New England Journal. I think that's a perspectives piece. And I think people beyond the AI community need to hear it, because I just don't think people realize how extensive this could be available. But one thing you said really struck me when you said, are we training for people in roles that still make sense? And I think a lot of our patients live at the interstices between specialties, between disciplines, and really what we're building towards is something I think we really have to think, that whole workforce space, I think, is something we have to think about very differently. And just as a quick analogy, which might be of interest to Shiv, my son is in music technology at NYU, and there's just a new arrangement between Sony and NYU's music tech department. And the headline in the New York Times said, and I pulled it up because I thought it was fascinating, we're going to train musicians and technicians for jobs that don't exist yet. And I remember he pulled that up and I thought, that applies to medicine too. And I think we have to think really differently. Yes, we can change the curriculum, but I think we have to take 3 steps back and actually think about what are the roles we're actually training for. I thought that was profound. Thank you.
Yeah, thank you both for your comments. It was wonderful. It brought up a couple of things for me. The first is just frankly, what does it mean to be a clinician right now? I think we use words like work at the top of your license. And that's come to be, how do you reduce the burden? And sometimes come to be, how do you push it to the next person, which isn't always the best thing. But I think what we should actually be thinking about is, if a license right now, if graduating medical school, if you doing the USMLE, if all of those things ask us specific questions about knowledge, but what it means to be a doctor now is not knowledge. Maybe that was 1.0, and maybe putting it into documentation and my work as a doctor is documenting, maybe that was 2.0. If that's taken away and I can actually decrease the burden, what is the new term? Because it's not really work at the top of your license anymore, because hopefully the license that you are earning is one that is allowing you to be more human and really understand what the patient wants. So I'm curious how, as we go through the new licensing and the new medical exams and what it means to be a doctor, if that's going to be something that maybe comes up in how we credential people in the future. So that was the first thought. And then I guess the second thought would be, I think from a technology perspective, I'll give a personal example. I did family medicine for multiple years. About 10 years ago, I had a pregnant woman. It was her 4th pregnancy. I had delivered her first 3 babies, all vaginally. And her 4th one on Leopold's exams, getting back to palpation versus ultrasound, I could tell she was breech. And I was upset because I couldn't get an ultrasound appointment and I didn't have one in my clinic. And I tried calling, I tried sort of pleading, please let OB take her in to be able to get this ultrasound, and no appointments, et cetera. And then I kind of pleaded to get her to go through the ED to try to get to radiology that way, and same thing. And about a week later, she ended up breaking her water, had to have a C-section. And I think, to me, that was an example of like, wouldn't it have been great if I actually after that went out and bought my own handheld GE ultrasound, for just so you know, and got training in ultrasound. But I think it was an interesting example of like, I was not empowered, although the technology was available. And what would we do as clinicians if those 5 technologies were available and I could put them on my phone? Could I, in the future, maybe change patient outcomes because I actually am able to empower myself? And what would that look like in the training of physicians to know that they can leverage and empower that kind of technology on their own, perhaps even sooner than they can through their institution?
I remember in the emergency department, we were at Boston Children's many years ago, we were not allowed to use handheld glucometers. And we'd have patients come in DKA. So we would beg the EMTs, well, we wouldn't have to beg. We'd ask the EMTs who brought them in to please use their glucometers that they were allowed to use. And then we would get this sugar instead of waiting 20 minutes for a kid who was really in tough shape. Shiv.
Amazing comments. There's a researcher at Anthropic, Ben Kuhn, who recently wrote that he believes there are 2 attributes that are the highest leverage for people to be the most effective in this new AI era. And one attribute, he says, is agency, and the other is taste. So taste, he interprets essentially as a proxy for judgment, thinking deeply, being able to reflect on your own thinking, finding new angles on problems, seeing things people don't see. Agency, meaning avoiding over-reliance on permission or encouragement, the way, rising trainees, find ways to figure out new tools, not being caught flat-footed and always working backwards from the root goal. When I think about being caught flat-footed, the first patient I saw as a resident in Ann Arbor at U of M was a professor at the University of Michigan. And, I walked in that room with probably a good amount of arrogance, thinking I was going to drop some pearls of wisdom on this patient and let her know what the care plan is going to be and like move on, with my merry day as a newly minted doctor. And I had no idea what was really what I was in for. I walked in this room and she immediately started to quiz me on whether or not she had multiple endocrine neoplasia type 2A or 2B. So it's like straight out of the MCAT. And so I sort of adjusted to the patient population of many professors and PhDs and university folks in Ann Arbor very, very quickly, but I was caught flat-footed. But thankfully, I think I was like agile enough. I said, I don't know. And I turned on the computer in the corner of the room. I think I went on UpToDate and I just read out loud. And I just sort of like figured it out with her together. And I think that's the new world that we're all in. That's the new world that rising medical students, residents, and fellows are 100% all in, that they're prepared for. And I think part of our challenge now is to sort of keep up with this new world that I think we're going to constantly be in tension with in relation to also like the trust question that clearly is like a thread through all of our conversations here.
Now, Vincent.
Yeah, thank you. Just a quick response to Jackie's comments. I think the new currency is insight or information management rather than knowledge. So rather than being the deepest, having the deepest fund of knowledge, it's being able to draw from the sources and then make decisions, because we know that the sources of knowledge are much more at our fingertips than ever. But I wanted to reflect on Morgan's comments and say that I'm very inspired by them. So I'm glad that you've joined the profession. But I think they highlight an existential crisis maybe many of us have felt ever since ChatGPT, and we kind of I kind of pushed it to the side, because on the one hand we are taking advantage and thinking deeply about AI, innovations from Epic that have scaled to hundreds of millions or maybe billions by now, a bridge being disseminated so widely, and other things in imaging, et cetera. And so on the one hand, we can be proud about the speed to some extent. And yet on the other hand, I feel like a dinosaur, you know what I mean? And as someone who has a leadership role in this context of AI, it's not even close to fast enough, given the pace of technology. And that's as we address this, I think that's going to be a fundamental discordance between the pace of what is available in technology and how we can, as humans, adapt to that, not only just individually, but in the structures of training, licensure, and then finally, how we design our healthcare systems, which, today are just not equipped at all across many dimensions to be able to integrate this technology effectively.
Right. Yes, speed. I'll just point out that a couple of years ago, when the AI Code of Conduct was, that project was getting started here, it was really about trying to figure out ways to push AI into healthcare. And now it's at the tidal wave and trying to deal with that. Things have completely changed, right, in just a short time. So now I'll go on to Gina.
Thank you. As I was listening to all the conversations and the comments, thank you. I was reflecting, when going through pharmacy school, one of the key skills that you learn is evaluating medical literature and also evaluating medications from the lens of the mechanism of action and the general category, not just one drug after one drug memorization. And I think when thinking about AI tools, we really have to integrate the evaluation of a tool. So how does it work? Why does it work? Where does it pull information from? Is it appropriate for the process that I'm trying to apply it to? Is it appropriate for the patient that I'm using it on? And I think that systems thinking is what you were talking about earlier, Lisa, about integration. So it's not about having a new course, calling it AI, and then saying, good, all our clinicians moving forward are now set, or about requiring master's degrees on AI for every clinician, because that's also unrealistic as an expectation. I think it's more about training them to understand how those tools work, having almost a core fundamental training in what is the process that I'm trying to accomplish? What is the scenario that I'm trying to solve, so that we have a true understanding of why am I documenting and what am I looking for in the documentation. And instead of you as a student saying, I don't want to have to write this 100 times before I'm allowed to use the tool that's available, but understanding, kind of breaking it apart and saying, these are the skills that we're trying to teach you. These are the skills you need to know, and now use this tool and assess it critically. Because I think our new generation of students, learners, residents is going to be eager to embrace some of these tools, whether for a shortcut or a curiosity, or because they're trying to enhance the process of care. But they're not always equipped to have your savvy of understanding, is it okay for me to use this tool, and how do I flag a hallucination? Do I trust it or do I not trust it? And I think that critical thinking process of picking apart the technology and making sense of it and then applying it back to the process in a responsible way will be important.
You want to say something? No. Okay. Thank you. Now, Shauna.
Thank you to our speakers. Your comments have prompted me to think of what system can we collectively build to prioritize the needs of our patients, and not just their current needs, but their future needs. And I think in order to do that, anticipating 5-10 years ahead and thinking about what do we wish we would have done or wish we would have known now. And I think the trajectory of patient ownership of their data, the already democratized intelligence of the medical profession exists at the fingertips of patients. And how do we enable them to provide their own judgment, allow them to maintain their autonomy as human beings, but also as intellectual equals? And I know that that sounds odd, thinking about it from a knowledge, the ability to capture knowledge as a clinician. It's truly the foundation of the profession itself, being able to trust the brain, trust the archive. So now, is there opportunity to change the paradigm slightly and rely on our clinicians more for their ability to critically think about things, to be able to make multiple connections across sectors? I think there's also opportunity to support our clinicians in co-developing different AI solutions or different tools, in providing a very real environment where clinicians can get their hands dirty. One example being at Mayo, we're working on a partnership with our multidisciplinary simulation center to be able to, where normally clinicians are tested and evaluated and educated in the simulation center, but changing that to give them the opportunity to be testing out or partnering with our different innovators to be able to co-develop solutions through an iterative process, but also giving them the opportunity for early exposure and also to be able to co-create entirely. Thanks.
Great. And Sue.
Yeah, Shauna, thanks for that. You said a lot of what I was going to address, but something as we think about AI in the future and healthcare in the future, we cannot ignore the patient of the future. And that is creating an entirely new dynamic. And so as we think about training and education for clinicians, I really think we need to integrate this kind of thinking in that how does the role of the clinician I don't know if I want to say change, but how do we advance the clinician to be prepared for this democratization of knowledge? And I think there's a whole world there. I think that we're going to find that it is important. The agency of patients is important. And that I think if we're helping patients be the best patient, then the doctors will be the best doctor. And so somehow we have to change. Currently there's a culture, I believe still, that informed patients are not necessarily encouraged. Doctors talk about patients coming with stacks of Dr. Google things. And I think we need to shift the culture to celebrate the informed patients and help patients become more informed with AI.
Great. And now on to let's see, we've got Anita. Oh, Anita, and then, yes, Anita, and then Dave.
Yeah, I just wanted to say thank you both for the presentation. That was amazing to hear. Being a chief nursing officer at both Stanford and Cedars-Sinai in Los Angeles, I felt like I shut down more technology than I ever let through. So Morgan, I'd like to hear did you get approval for all the tools that you were using? Were they tools that you could, yeah. So did you get pushback on that? So I guess what I'm saying is I think that's the piece that we need to be working on is the bottleneck that organizations and institutions, currently have in place. And you could teach people how to get around that more. I mean, that would be really beneficial for the forward movement of this. Can you tell us a little bit about how you actually went about implementing the tools yourself and, avoided the pushback or what workarounds you used, or I'm just interested in that. Yeah, it's anonymous.
There we go. The good news is Boston Children's actually has its own instance of ChatGPT that you can put patient information into. I've been getting emails about this, so that's very exciting. Honestly, with most attendings, I would just say, like, let's try this, and if it works or does something interesting and novel, we can publish on it, and that was enough of a carrot to inspire them to pay attention. With certain data assets, particularly with the Da Vinci, I had to go through protocols for scrubbing the PHI from the system, but most of the vendors I was talking to were also comfortable working with me on that to make sure that nothing catastrophic
so
was.
you built the scrub PHI.
Yeah.
Okay,
Yeah.
that answered my question. Thanks.
Great. And Dave.
It's getting really juicy now. We're starting to tread into the area where leading patients are doing. The discussion about you've got your own tools that other people don't have and buying your own ultrasound. The pillars, I'm not kidding, are crumbling of the paradigm that says the value comes from the institution because they're the ones who, number one, has the money, and number two, knows what's important. And where trust really starts to erode is when the people who are saying, trust me, are outed as being out of date. All right? So I really hope you'll be hearing in our talks this afternoon what we out here are doing. And what's really called for is getting rid of all assumptions about who knows what. In my recent keynote speeches, some of them I'm titling The Evolution of Who Knows What. Because if we have that wrong, then everything else we think is even imaginable, it turns out to not work out well. So I'll leave the rest for later.
Jana, I think I skipped over you because of my bad handwriting, which, it should be a thing of the past for physicians, but it's not yet.
No problem. I just wanted to come back to the challenge we're facing for education again. And I'm going to start with a confession because I'm sitting here thinking about Shiv's comment about the yearbook photo this morning and reflecting on the fact, Peter raised the see one, do one, teach one moniker that we all know so well if we're clinicians, and reflecting on a proposal we submitted, in fact, this month to do an AI course for clinicians based on the see one, do one, teach one moniker. And I'm feeling a little embarrassed because as I sit here and reflect on that paradigm, see one, do one, teach one is something that now AI is going to do all in one go for a clinician. It's going to show you one, it's going to tell you how to do one, and then it's going to tell you or show you how to teach someone else. And so all in one instance, right? You've already whipped through see one, do one, teach one. And so I think about how we've learned to use other technologies, as you come up through. There may be other people in this room who took a typing class like I did. And then we had a computer class. Remember that? And it's like, wait a second, are we really going to go back and do an AI class? Because I think what we're moving toward now is for true education is that everybody has to know how to use this. And you're gonna learn how to use AI from your mentors and clinicians who may look different than they have in the past. As you said, your mentor may be Morgan, and you may teach him a few things about how to listen to the heart, but he may teach you what to do with that information and how to use it, right? So I think that we have to challenge ourselves to think about how we're approaching education in this sphere differently so that we don't go back to having an AI class like we did a typing class and a computer class, but where the infectious disease attending is going to see one, do one, teach one all at once with a mentee, or the mentee is going to show the attending how to use those tools to do those three things all in one go.
Great. So tents are down, and this is perfect timing. Let each speaker give about 60 seconds of final observations, and then we can go to lunch even 3 minutes earlier than Sunita was going to otherwise allow us.
So thank you is really what I want to say for not just the opportunity to share, but more importantly, for the opportunity to listen and be a part of this great discussion. And again, and learn especially from my co-speaker during this session as well. And I just want to, one word that one of my favorite words as a medical educator is humility. I do a lot of work in faculty development, obviously meet quite often and have the pleasure of working with medical students. And that is the one kind of characteristics, trait, competency, whatever you want to call it. Humility is so critical and important. And many of you have shared your own, expressed your own, demonstrate how you are humble and how you express humility in your own work and in those learning environments. So thank you for that. And I think we need to foster more of that across all of our professions, especially within medicine, I will say, since that's my space. So thank you.
Thank you. Again, it's a privilege to be here and to share this podium with Lisa. In closing, I would go back to the one thing I hoped everyone took away. And I think this conversation, even just hearing the responses to our remarks are energizing, but the technology and the innovation is no longer the barrier. And so if we now focus our attention to what actually is, then I think we open our eyes to the business models, the incentive structures, and the economic arrangements in healthcare that are ultimately going to hold this technology back. When I think about how we will finance AI, like I'm coming from the state of Rhode Island, I went to Brown. We are the second lowest reimbursed state for Medicare and Medicaid, right above Mississippi. And so when I go to Lifespan or Brown Health and I show them one of these flashy tools and I'm excited about it and I show them the impact it had on patient care, they can't adopt it. And so I would just, ask all the brilliant minds in this room who've far more experience in this work to spend as much time thinking about how we redesign these business models to support this technology over time, equal weighted to understanding the technology itself. Thank you again.
Great session and fantastic presentations and iteration with some really amazing insights from the whole group. So thank you. And now we go to lunch.
It was really great to see all of the great discussion over lunch. And it seemed like we could spend another 2 hours just out there eating cookies. I brought my own here, which is good. So now we have our next session on the impact of AI on patient experience and patient-clinician interactions. And again, to set the stage for our discussion for the next hour, we have two really great speakers. One is Sue Sheridan, founding member of Patients for Patient Safety, that's PFPS US, and the Director of Patient Engagement Emeritus at the Society to Improve Diagnosis in Medicine. And then after Sue speaks, we'll have Dave DeBronkart, He's a cancer survivor, someone who has been disrupted by tech in his previous career, student empowerment through improving people's resources and agency, especially through access to data and knowledge, and the curator of Patients Use AI blog. Sue, why don't you get us started?
Thank you. If Dave is a free radical, I think that's what you called yourself, then I'm the Wild Wild West. I'm coming in, let's see if we can get the slides up there. I'm coming in from McCall, Idaho, that is considered frontier territory, and it's right in the middle of the state. I'm going to talk about how AI has empowered me and my family. We can go to the next slide, please. Oh, that's me. Okay. I am empowered. Okay. Okay, here's the state of Idaho. You can see that red ring. McCall, Idaho is at the intersection of the elk and the pine tree. And about 30% of Idaho's counties are designated as frontier, meaning we have fewer than 6 residents per square mile. You can see on the bottom, that is the view from my home. I live in the mountains. We're about a mile high. Population where I live is 4,000, which is one of the biggest cities in the county. We're also designated a health professional shortage area, which means there are more than 3,500 patients per provider. So as you can imagine, it's hard to get an appointment in McCall. It's also designated a medically underserved area. So I'm just kind of setting the stage for you on how living in the mountains in Idaho is a wonderful experience. But to get optimal patient outcomes, we have to access AI and technology. So I want to give you some examples of that. Now, usually when I speak about healthcare, I speak about my late husband, Pat, who died from the failure to communicate a malignant pathology that got lost in a healthcare system that I think AI could have prevented. That was over 20 years ago. And I often talk about my son, Cal, who is 30 now, but he suffered brain damage from his newborn jaundice, where his value of 34.6 never really got the attention it should have. And I think had AI been engaged in his care, it would have been setting up all kinds of alarms. But this time, I'm going to talk about me. Both Cal and Pat had diagnostic errors. And so I've spoken nationally, internationally about patient safety and diagnostic errors. And this time, I'm going to share my story and how AI came to my rescue in Frontier, Idaho. So this is a picture of me. Now, this is Dave DeBronkart. I'm going to talk next. We're kind of a tag team here. Wild Radical, Free Radical in the Wild Wild West. And this is when I was up in the mountains. I was in McCall, and one morning, I actually went that lake that you saw. I'm part of an open water swim group. So we swam a mile that morning, and some of my swim colleagues said, "Hey, there's something going on with your face." And so I went into our home, and my husband, who is a physician, said, "We're going to the hospital." And I felt fine, except that I'm experiencing this weird kind of right-sided facial kind of pain, and my tongue was a little numb, and I'd had that for a few days. But when my face started to droop, then my husband said, "Okay, we're going down to the big regional center," it's called going down the mountain. It's about a 3-hour drive down the mountain. And ironically, we drove right by our little hospital in McCall, thinking, my husband being a physician, thinking we'd need specialty care down in Boise, Idaho. So we went down there, where I was immediately admitted into the ER, and they did immediately an MRI, and they ruled out a tumor or a stroke. And then the clinician basically said to me, it wasn't a stroke, it wasn't a tumor, so I don't know what it is, but it's probably due to stress. And I asked him, what else could this be? I wasn't convinced it was just something normal. And he said, he said that his recipe for me was to use what he used the term, use benign neglect. That's probably the best avenue for you. And I said, I'm not satisfied with that. And I said, what else could this be? He said, we in the ED don't diagnose. So my husband, being a very seasoned doctor, and he had been an ED doctor, he said, now wait a second. Could this be a reactivation of a virus? Because I had dental work about 10 days before or a week before. Said, no, she'd have more symptoms. Totally blew my husband off. And so he said, listen, my advice to you is go back up the mountain. And if it doesn't resolve in a while, go to your primary care. So we drove back up to the mountain. But as you imagine, we weren't convinced that was the right advice. So we got back up to McCall. This weird pain in my face and my head and my tongue, kind of numbness was continuing. And that night it was really pretty profound. So the next day, my husband and I said, what do? We needed a second opinion. So we turned to ChatGPT. Now, neither of us were experienced in AI or ChatGPT. We were like two kids with a new toy, and we're like, put this in, put this in, put this in. So you'll see our search was really, embarrassingly simple. We put in facial droop, facial pain, and dental work. And and you can see down below, it says Bell's palsy. Now it gave other potential conditions like being head trauma and all that, which I didn't have. So it said Bell's palsy, and it says it can be triggered by stress or viral inflammations. Dental work can trigger it. But what really got our attention is this window. It said most effective if treatment is started within 72 hours of symptom onset. If you don't get your treatment for Bell's palsy within that window, your facial paralysis can become permanent. So we went to the ED up in Little McCall because we called our primary care, and the weekend service said, she can see you in 3 months. You just don't get a primary care appointment in rural Idaho or frontier Idaho the next day. And so we knew we couldn't see our primary care. So we went to the little ED up in our city, and armed with not an answer. We weren't asking ChatGPT for an answer. We were asking ChatGPT for a second opinion, as you could see. We wanted it to inform us about the questions we should ask, about what we should, what kind of conversation we could have. And so, right when I walked into the ED, the ED doctor said, oh, you've got Bell's palsy. We got to get you on prednisone and antiviral ASAP, because he understood this has been going on, for a couple of days. And so he got me on the medication. And by that night, I was already feeling relief on the right side of my face. Unfortunately, my paralysis has continued. They believe I'm going to have stage 2 facial paralysis, probably permanently. It could have been a lot worse, though. And so, I ended up with all these what ifs. What if I had accessed ChatGPT before I went down the first time to the ED? What if the doctor had used ChatGPT? What if he and I together looked at ChatGPT when I was in the ED and say, what could this be? So there were, my biggest what if is, what if I hadn't used ChatGPT and used benign neglect? So, that was my introduction to ChatGPT and how it really empowered me and my husband to get the right diagnoses and the right treatment. Now, you saw the picture beforehand with you see Dave's picture down here. Dave, ironically, around that same time, it was just like 3 weeks after my event, Dave had posted something on the internet. We're both on the BMJ patient group. And Dave had just reached out globally saying, hey, has anybody recently used AI in their own care? And I said, well, I did. And so Dave said, do you mind if I write about it? And we got a lot of attention. This went viral all over the world. WHO saw it, and they asked me to speak about it. And, it was really interesting in that not all the comments were positive about my use of AI. I'm going to stop there. We actually were kind of surprised at some of the feedback we got that, one clinician said I was doctor shopping, looking for the right answer. And others were really very negative about my use of AI, which really surprised us. Now, on the flip side, there were others that said, bravo, an informed patient is exactly what clinicians need. So that really made me aware of this culture. When we're talking about education, we need to talk, well, humility also. We need to talk about this culture that we need to celebrate informed patients and encourage patients. Now, that was my experience with AI. Again, I am not an AI expert at all, but I use it, and my family uses it. So I want to just share, flying here yesterday, I thought about, I'm not the only one up in rural Idaho that uses this. And I wanted to share my story. Chad, who's on the upper left, he has 3 chronic conditions. He has a heart condition, he has interstitial lung disease, and he's currently battling prostate cancer. And he also has protein S deficiency. So he's a complicated guy. He's a geriatrician who deals with complicated patients. But I just want to show how technology and everything is helping him have a good life up in the mountains, but be safe and good care. So he has his INR, he has remote monitoring where he does a blood test. He enters his values. It goes to some national center in the Midwest where they use AI to pull out trigger alerts. And then if he has a high or low INR, it gets kicked back to McCall, Idaho, actually to the pharmacy, our one pharmacy in McCall, where they call Chad, and they actually use AI to determine and adjust his medication levels. So that's one. And then he also has used remote heart monitoring, which the little box gets sent all the way to McCall. We put it on, and then he wears it for a couple of weeks. We take it off, we put it in the box, send it back, and then we get the results in the patient portal. So we are using patient portals, we're using AI, we're using remote monitoring. And then I want to introduce you to my son, Cal. You can see down on the left. He loves this picture of himself. He's actually a comedian, believe it or not. He's a stand-up comic and super speech impaired. And so on the far left, you'll see he uses Murph AI. It's text to speech. Not only does he use that in his comedy, but he uses that in healthcare. And so he's hard to understand. So Cal will get out his cell phone and he can text really well. And he can have a conversation with the doctor. Now, doctors are blown away when they see this. Doctors need to know that this technology is available if they have people who struggle with speech impairment, because it has completely facilitated communication. On the far left, Cal uses telemedicine for mental health. Cal experiences depression, anxiety at times. His disability is a challenge. And so his telemedicine, his mental health is absolutely terrific. He doesn't have to get Uber. He doesn't have to use any transportation. He's got a great relationship with his mental health provider. Unfortunately, Cal just moved to Arizona, and Arizona doesn't allow the doctor who's in Colorado. So we need to change those laws. We need to enable people to use their telemedicine with whatever healthcare provider they need and want. And then in the middle, here's the latest, is teleophthalmology, which I'd never heard of until just last week when Cal went to a new neurologist. And Cal's really hard to test for a refraction for his glasses because he has blepharospasms, the cerebral palsy makes his eyes shut. And so he's just super hard to test. So this neurologist told me about teleophthalmology, where they can actually do a refraction for your glasses via telemedicine. And so it's amazing to see what's out there and how it enables Chad and Cal and me to live in McCall, Idaho, safely with good quality care. It's kind of surprising that we live out there and we use probably more technology than people in big cities, because we rely on our patient portals, our test results, our communication with our doctors wherever they may be in the United States, via the portal we're talking. Unfortunately, a lot of the portals don't speak to each other. So ONC, where are you? Yeah, we need, there you go. We need to talk about how we can really get these different platforms talking to each other. So that is just a very quick story. I know we have time constraints, but how can we leverage the promise of AI to empower patients? I mean, the train has left the station. AI is available to us, and there's going to be more direct consumer AI. Let's take advantage of that smartly and safely. And so how do we help maximize the agency of patients? You know, we're talking about clinician-patient relationships. Clinicians should absolutely maximize our agency. The better we do for ourselves, the better they're going to be our doctors. And so, this is a quote. It was, I think, from Kaiser Permanente, but we are the largest workforce out there. Engage us, empower us with AI. Ensure that clinicians are trained to communicate more effectively with patients about AI and the resources available to them. Something that Chad, Cal, and I have learned is we have to educate the clinician about the AI tools that are available to enable us to have better outcomes. So we are also teachers. We need to change a culture that discourages patients to use AI to a culture that celebrates informed patients. We need to encourage healthcare systems to adopt strategies that enable patients to use AI. And we also have to consider what are the regulatory actions and payment models that we can implement to incentivize the use of AI. And then finally, I'm talking about all of this, positive and exciting use of AI, which I do embrace, but I also see the dangers of AI if it's not built correctly. And so, I'm a strong proponent of, as is Patients for Patient Safety US, that the AI systems have to be built with the patients and the community members and the caregivers to align with the rights and the interests and the preferences that we have. And we need to be involved in co-development and in governance, because we talked a lot about trust. We need to know that this new frontier in healthcare is trustworthy. So I'll stop there and give it to the free radical. And thank you.
Thank you, Sue, and thanks for sharing so much about yourself and your family. It's really riveting. And now to our free radical.
Going to move to the corner because, and I guess I'll use Laura's mic. As a public speaker, which is what I do for a living now, I can't stand not seeing my audience. So, especially since I really care about my subject. Can we switch over to my slides? Okay, good. Thanks. I'm very grateful to be here. For those who don't know, 18 years ago now, I was diagnosed as almost dead with stage 4 renal cell carcinoma. My median survival at diagnosis was 24 weeks. And instead, 6 months later, the experimental immunotherapy that I got had cured me. I haven't had a drop of anything since. Extraordinary. And an important part of my story is that according to my oncologist, this helped save my life. I was highly engaged in my care, even though I'd never heard of patient empowerment. It was just a natural thing to do to try to save my pathetic butt, right? And I had also connected with a good patient community, which, believe it or not, now this was 2007 on the internet, my primary sent me there. My doctor actually showed me where to find the good stuff. All right, now I call that modern. All right, and I went out and started having an I'm not dead year in my life. And then I discovered there was garbage in my medical record and I couldn't get a straight answer out of my hospital. So I blogged about it and I ended up on the front page of the Boston Globe and people started inviting me to come to Washington to testify. It's like, if you want a predictable life, you need a different universe, right? What I didn't realize was that this was all at the beginning of the Obama administration and the $40 billion of high-tech money to install EMRs, and that's why people cared that there was garbage in the medical record. Anyway, I am extremely grateful to the doctors and nurses and scientists who saved my life with my help, right? Some people hear me talk and they think, well, wait a minute. Aren't you happy with the care you have? That's not what this is about. The map of possibilities, this is a mapping conversation. right? What you folks titled it, the map has expanded. And in order to plan accurately, like with any road trip, we need to understand how the map has changed. Let's see. There we go. Right, I'm going to have to make up my mind. So there's this common phrase, patients are the most underused resource in healthcare. Well, now we have generative AI, and that alters what's possible. So I'm speaking here for this group of people. I'm one, there's a famous empowered patient named Hugo Campos you'll hear more about. Grace Cordovano is well known to the Academy. Gilles Friedman is the guy who in the 1990s founded that patient community that helped me survive. And on a call over the weekend, Grace said, you know what, we ought to call ourselves the AI Vengers. So that's it. Game on. Anyway, well, I used to work in marketing before I got sick, so any catchy brand is fine with me. On a call a couple of years ago when generative AI was new, Grace had just read through an RFI having to do with AI use in medicine. And she said, you know what, people need to realize patients are end users of AI because all of the talk was about doctors using AI, researchers using AI, clinicians using AI. Nobody was realizing that patients can have some agency. So she came up with this. I, being the marketing guy, I came up with the hashtag patients use AI. And Grace had listed out these 5 categories of use cases. Patient administrative burden. She is a master at using it to argue with insurance companies. And she is successful at it because she loads it up with the patient's information and the BS letter she got from the insurance company, and boom, 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 boom. But organizing your records, you'll see some examples of these. Eventually, I started a Substack blog called Patients Use AI. In marketing, we know having a consistent brand helps people remember who you are. These are some screenshots of a few of the blog posts there. 2 on the bottom right, that's the Wall Street Journal talking about patients using AI. Next to it, the New York Times, Dr. Chatbot will see you now. That was an article about Sue's case. She made the New York Times on this. And then there's Laura to the left of that. This is a revolution in self-care. This does not mean I've stopped going to doctors. To the contrary, at age 75, I no longer want to drive into Boston to get to my primary. So before I start having problems, I'm actively thinking out what kind of a care relationship am I going to have? And I am shopping for primaries who are more accessible to me. And I'm doing this with my famous primary, Danny Sands, knowledge and collaboration. We are thinking out how we're going to be able to do this. Notice in the bottom left, we seek collaboration, not control. Now, this is a big deal, and there's a lot of it happening. Just to set context, I found this fairly recent article saying Google gets 1 billion health questions every day. Well, you may have heard even just earlier this month, Apple announced that their Safari data says that Google search traffic is down for the first time in 22 years because they have seen the traffic is now going to ChatGPT. All right, so that's an awful, I don't have data that says that that's strictly proportional, but that's a whole lot of people out there who are getting better answers, because if they weren't getting better answers, they wouldn't be doing it, right, by going there. Now, this is the continuation of a trend that's been going on for a long time. Tom Ferguson is this guy. He went to Yale Medical School in the 80s. And he just had this idea of medical self-care. He published a magazine and then a book by that name. And in 1985, this is a blog post I did about an article I discovered. He published The 7 Laws of Self-Care. And the first law, he said, was you are already your own doctor. Now, he said that in the 80s, and obviously that didn't happen. All right, and that raises the question, if you've got an analytical mind, why? What are the obstacles? So let's take a look at what's happened since then. First, people needed access to information. Googling helped that. All right. All it did was give us information. It didn't make us smart. All right. But that was one obstacle. Then there was the literature. PubMed addressed that. You still had the problem of having credentials to access it, but this is like chipping away at the wall. Then measurement, personal health devices. I have a Wi-Fi bathroom scale. I have an Apple Watch. I have a Fitbit. I have an Oura sleep ring, and so on. I've got a whole bunch of data. So this is the objective part of SOAP notes that I start to have. It still leaves the giant question, what does this all mean individually and in context? And ladies and gentlemen, that's where access to clinical reasoning through generative AI changes the map of what's possible where. All right, we need to have physicians who are trained and practices that are oriented around the possibility that somebody like Sue Sheridan is going to walk in with useful information. And so I've been wanting for years, why don't we have standardized patients on which medical students are tested, who are Googlers and have some valid information and changes what the doctor's impression is. It certainly should be true with generative AI now. If that sounds empowering, consider this. In my speaking advocacy work through the last 10, 15 years with some other advocates around the world, I've gotten curious about what do we mean by empowerment. It's a nice, warm, fuzzy, feel-good term, but it turns out the World Bank has done a ton of work for decades in developing nations on empowering women and girls. And to make a long story short, in the interest of time, they just published this a year and a half ago that says empowerment happens by removing constraints. And they put those constraints that they cataloged in this report into 3 buckets: agency, familiar word, but then for our purpose, it's resources, tools, and information. Removing constraints on people's access to tools and information empowers them. And then there's an empowering context. You've got to have a social system that welcomes them doing it. AI is illuminating new terrain on the map. And guess what? While we're sitting here at the Academy thinking about what we're going to do, I can tend to be a little bit irreverent on citing social media things. What you should see a meme that says, patients be like, hold my beer, all right, because they're just racing ahead. They have nobody telling them you can't do it. Here's a trivial example. If you've probably heard of it, but if you haven't done this yourself, you need to. Every one of us needs to be a user. All right, so this is a visit note. I'm exposing my records to you. 73-year-old male with hypertension, hyperlipidemia, blah, 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 blah. I argued for years for access to be able to see these under open notes. Now I got them and it's like, ugh. All right. So, but all right, game on. Next step, ChatGPT, make this legible. And I didn't just ask it to translate into something legible. I got even more lazy. I said, give me a list of action items. And here's one little screen clip of what it did. Problem, hypertension. Here's the description. Here are your action items, right? One way this is empowering, you can do this with your visit notes, you know. One way this is empowering is it makes it easier for me to be a good patient for the doctor. Woohoo! I go in now on a follow-up visit, and like a scruffy 8th grader or something, say, what was my homework? What was I supposed to do? But I come in better prepared. I was astounded last fall when Men's Health magazine wrote to me. Actually, they were referred by Peter's colleague, Carrie Kohlberg, to write an article about how patients can use AI. Now, this magazine, vetting is important to me. This magazine is part of the Hearst family. They have lawyers and medical advisory boards up the wazoo. It took months to get everything approved. But every story from the Substack, from the Patients Use AI blog, that they dug into was validated, and then they came back and added a couple more stories on their own. And I'll just give you a glimpse of some of these. Bert Rosend is this mensch in Portland who happens to have two cancers. He uploads a radiology report and says, make this understandable. And then he's got the kind of personality where he says, now give me the answer in the voice of Samuel L. Jackson. He did. And then he said, now do it in Seinfeld. And it comes back with, what's not to like? Everything looks good. You know what? If you are doing this for yourself instead of making a product, you can do anything you want, right? Be an empowered partner. This is a friend of mine who wanted to convince his primary to let him use ambulatory blood pressure monitoring. She was skeptical. He piled all his information into ChatGPT, and notice at the end, he said, write your response at the level of a JAMA submission. And it worked. The doctor said, great, and did it. All right? Double check important decisions, on and on and on and on. And here's Grace Cordovano. You know what? Men's Health magazine published a European edition of this. The US version was titled 8 Ways AI Can Help You with Your Health. The European edition was 7 ways. You know what they left out? In Europe, they don't have to argue with their insurance company. Isn't that something? Well, so anyway, now people will be skeptical and people say, well, wait, this stuff's not perfect. It hallucinates. This is what I call sophomoric objection. The original Greek meaning of sophomore is a wise fool, somebody who acts wise and doesn't actually know what they're talking about. Because if you have gotten into it and become a user, you know that it makes mistakes, but all in all, it's darn good. It's a real contribution. And Zach Kohani's column here in Nijum, and this wasn't even the AI one, was you can't compare this against fictional perfection. Because the first time I saw Zach talk about this subject was at an event at the Harvard Faculty Club the first year that ChatGPT came out, and he listened to everybody else worrying about the ethics of using AI in healthcare when we're not sure if it's perfect. And he got up there in classic Zach style, and I swear he should have had a cigar stuck out the side of his mouth. They said, I'll tell you what the real ethical crisis in healthcare is. It's that half the people on the planet can't get any, and this is going to fix that. Right? We need to be thinking to pulling apart all the things that go into solving people's problems in medicine, all of which used to be bundled in the thing called MD, and all of it can live there now, but it is no longer a constraint that that's how it has to happen. One more hero here, and then I'll wrap up. This is Hugo Campos, who I mentioned earlier. He's always been a leading user of technology. What he's holding in his hand here is the earliest edition of the AliveCor smartphone EKG. He's a hypertrophic cardiomyopathy patient with an implanted defibrillator. And when I asked him early on, people were saying, Hugo, this stuff hallucinates. What do we do about it? He laughed at me over the phone. He said, Dave, I don't use it to give me answers. I use it to help me think, right? And that is the correct way to do this. Now, among other things, guess what? Thinking is a muscle, right? It's like a muscle. You use it, you get better at it. Now, what I showed you before was a trivial example of just analyzing, simplifying your medical records. Hugo faced a year ago a nasty example of what Zach was talking about when he said people can't get care. Now, he lives in Oakland, and he is the caregiver for his 93-year-old father, who developed a horrible rash. And so they went to the PCP, and the PCP got a referral. And at Kaiser, the referral to the dermatologist was just 4 months away. So his 93-year-old father has this horrible rash, can't sleep, itch, 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 itch. Hugo sat down, and this took a couple of weeks, all right? But he uploaded photos, He uploaded all the lab results that he could manually copy and paste. I want us to automate collecting this stuff so it's not a burden for the ordinary person, right? And narratives, descriptions of things. And then his prompt, I know this is too small to read, but basically he said, he gave it a persona. He said, you are a fourth-year resident presenting to your attendings the case of a 93-year-old man with blah, 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 blah. Look at the information I've just uploaded, et cetera, et cetera, et cetera. Give me your differential diagnosis in a 4-column table where column 1 is the rank order, column 2 is your diagnosis, and in column 3, give me your clinical reasoning that leads you to that. Now, you can do that right today with your own chat GPT. And number 4 is what you would do, what you would recommend for actions. And it came back with this. And it gave him 5 potential diagnoses. This still didn't solve the problem, but he, after looking at this for a while, he realized that for 3 of the 5 things, the recommended actions were the same. So while they were still 2.5 months out from the dermatologist appointment, he tried them, and guess what? In 3 weeks, the problem was gone. This is medical self-care. It does not mean nobody needs doctors. But for heaven's sake, shouldn't we figure out ways, if we are truly committed to everyone having good care, shouldn't we figure out how to make this more possible for more people around the world? Even here we have physicians that we can't get at because of the glorious US health system. I don't know. On the other hand, there are parts of the world, I'm told, where there are essentially medical doulas, people who are go-betweens, and they may be using ChatGPT. There is the question of why all these stories are not noticeable to people at the academy, people who work in medicine. And this is actually an investor slide. This is from Andreessen Horowitz, the famous Silicon Valley investors. And the first fall when I spoke on this subject, I found this, and this is a really good market map where they took all the use cases, the so-called jobs to be done in healthcare, and you could call this a 2x2 where you have clinical or non-clinical, whatever. The y-axis is clinical for non-clinical. The x-axis is professional facing and consumer facing. So on the top right, clinical, professional facing, you have clinical decision support. In the bottom left, you have patient financial assistance. Here's my question, and I mean this, and this is really important for a mapping exercise. Can you find the blind spot? And the punchline here is that you don't have to read the fine print there. The answer, there's a lot going on outside the consumer-facing wall of the healthcare system. All those blog posts about things people are doing, it's off the map. And our map in this mapping conversation must expand, or we literally won't know what we're talking about as we design the future of care. And just to bring this to a conclusion, Hugo himself, a year ago, published a science fiction fantasy that he called Howard, My Healthcare Agent. He speculated that this would be, I think it was GPT 8.0 or something like that. This was years into the future, where he would have an agentic AI, agentic meaning an AI that has agency. It can decide to do things and do them on its own. And he wrote in there that it took me months to gather all my medical records and load them up so that Howard could know everything that's going on with me. And he imagined that Howard, his agent, talks with the physician's agent as well, and they co-manage the care. This is now so close, I can practically taste it. People are talking about consumer level agentic AI being months away now. And we really ought to be hurrying to think, how can we encourage this to happen in the right way? Another one of the Avengers that I mentioned is James Cummings. He's the father of 2 kids with extremely rare genetic disorders. And he blogged about this, and he said a priority need is this to have a complete longitudinal health record, because otherwise the AI can't possibly help them. And he said something very motivating in that blog post. No one has more abundant time to dedicate to positive outcomes than patients and caregivers. Nobody wants to tell physicians to spend an unlimited number of hours, but James is happy to spend 3, 4, 5 hours a night if it will help his kids, and he's not alone in that. So here's my plan for exploring all of this together. First of all, as James and Hugo both want, a shared comprehensive record that's accessible to both of us. Please don't make us build our own record, because it will end up being different from yours. We need to get people to bring it all together so that we're working together, collaborative, what we call participatory medicine. Second, collaborative interpretation. It's great if I come in with something for my doctor and I say, ChatGPT said this and this. I'm very pleased that doctors are not hostile to me with this the way they used to be hostile to my Googling. I guess it's got a reputation as not being stupid. But I really want my doctor to be able to interrogate my ChatGPT, right, which is not possible at present. I want some kind of a collaborative AI tool that we can both work with together. And what we can start with is some pilot programs where the smart people in this room figure out how can we have some patient-clinician pairs or patient-clinician teams that try doing this. And when we do it, please, 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 let's keep track of everything that works and everything that doesn't work as well. I'm very grateful for your time on all of this. I really hope we can do this. The map of possibilities for this conversation has truly expanded, and let's figure it out together. Thank you so much.
Thank you, Dave, and Sue both. And so we will have a few minutes for some discussion and questions. You know, one sense, just to start, I feel some sense of relief. In secret at Microsoft and jointly with OpenAI, starting in August of 2022, we had started our project to try to assess the potential of generative AI in healthcare. And the research was moving along pretty well. It was a very exciting project. And then a couple months later, November 30th of 2022, OpenAI made the decision to release a simple free app using a toy model called GPT 3.5, and that was the app called ChatGPT. Within a couple of days, we had been seeing data indicating a huge number of people using ChatGPT for healthcare and medical questions. And this sparked a huge internal debate within Microsoft and OpenAI about whether this should be allowed. Because we were very well aware, especially for the free toy model in that original ChatGPT, that this thing was prone to errors and hallucinations and so on. Ultimately, the final decision, we had even field tested internally a meta prompt that would prevent ChatGPT from engaging in medical and healthcare conversations. The final decision actually rested on my shoulders. And not knowing what to do, made the decision that we would not publicly present the system as a healthcare application, but not impose any restrictions. I do wonder where we would be if we had done it differently. And I think listening to both Sue and Dave, it gives me a sense of relief that, that we let things go. But it does now raise a bunch of questions. And so let me start to see if anyone has any reactions or questions they'd like to offer. Ken, you had your tent card up before.
So I wanted to react to these two amazing presentations, very inspiring and very resonant. I'm sure with a lot of people in the room, with their experiences in healthcare, they can't be perfect. By the time you've had your own healthcare and been involved in the healthcare of your family members. And one thing is with Sue's example of her husband coming in and making this case is, I just want to point out that even when you've got the qualifications of a physician, when you're in the patient role, you are often treated the same way. And so it's just sort of like an extra lens on this problem and very evident in that story. And also, along the lines of what are we comparing this to, as Dave pointed out and Zach has written about, that example of the GPT diagnosis being better than the clinician diagnosis wouldn't show up, because in the scenario, in the current literature, we would be comparing to the doctor getting it right. And frankly, that doctor was not smart. That was like not a smart thing to say. I mean, that is a classic set of symptoms, and there's nothing normal about having those symptoms, even if the doctor didn't realize it was a Bell's. And that level of performance, which is not uncommon among doctors, and it could be the doctor was even a little bit allergic to another doctor telling him what to do. Right? So there's a lot of dynamics there, and none of that comes out in the testing. And these models might be superior. In fact, along these lines, Vinay Prasad, who's now in the FDA, had a tweet not too long ago, very interesting one, where he said one of the most valuable things about going to medical school is so you can interpret for yourself and your family members which medical advice to listen to and what not to listen to. And I have to say, I have found that also to be true. And I'll make just one more observation. When in Dave's really this activated AI-enabled patient vision, is that doctors will not, especially now, I think, more than the old days, will not go 1 inch out of their specialty in making a recommendation. Even within their specialty or subspecialty, they'll say, no, that's not my area, right? Different specialists, ophthalmologists do different parts of the eye. And yet the activated patient, taking care, has to become a specialist in all these areas. And it's a real irony when the doctor won't make that, even though they're trained to do it. And so I think these are other opportunities for AI that sort of came to mind as I was listening to these two incredibly powerful presentations.
That last comment reminds me about the joke about the cardiologist asking ChatGPT, explain this nephrology report as though I was a cardiologist. Yeah. Kimberly.
Well, thanks to both of you for sharing, especially sharing so personally your experiences and your frustrations, and thanks for the leadership that you do. I was thinking about some of the barriers, and we've alluded to this of professional identity being wrapped up in this, and we've talked a lot about humility, but I was always so struck by Morgan's comment earlier. And so if you did have a doctor who was willing to get on ChatGPT with you, you're going to hit a firewall in many places, because organizationally, we haven't built the infrastructure to support that kind of interaction. And so you're able to access more tools outside of the system maybe than the physician can. That's an infrastructure problem that we need to address really quickly.
Susan.
So I had not had an opportunity to meet these two folks previously, but we've had some phenomenal conversation. I had stepped out of the room to talk about some Dole Act legislature that I'm leading called value-based healthcare. And I talked to my organization, some of the leaders at the top, about outcomes, and patient at the center of those outcomes. So first, thank you for letting healthcare move forward with GPT. That I think has been a positive way forward. And we already made some conversation, an engaging conversation about what the VA may be able to do, since at the current time, we're still not really regulated with payment wise as other health systems. If there's something that VA could do, and pilot really leaning in so hard into patients, their perceptions, their level, and the way that patients engage to drive the better healthcare outcomes, and really look forward to doing that. But just thank you for your leadership and your thoughts on that. It's phenomenal.
Sue and Dave, I wonder if you have any reactions to these last two comments. In particular, when you go into a doctor, in some places that doctor won't have the same easy access, at least within the walls of the clinic. So is part of maybe the resistance, Sue, that you encountered, does that contribute to this problem?
I would have to say that in my encounter, it had nothing to do with that. It had everything to do with the clinician himself. But, I can see that this could be a problem, in healthcare systems, and it could be something that we patients advocate for. Because right now I'm trying to think of the policy and regulation agenda that we can really call for, and to break down some of these barriers. It's hard for doctors sometimes to be the voice, disruptive voice inside the healthcare system. We can't get fired. And so, this is something I think is really important, that I didn't know that there are barriers like that. And so, that's, thank you for that. I want to make one unrelated comment that I forgot to mention, is that we talk a lot about the baked-in biases and the creation of disparities in some of the algorithms of AI. But what I saw was kind of how AI can kind of buffer implicit biases. Because when I went in with my husband and the doctor said, this could be stress, Sue. I kind of looked at my husband like he was doing him a favor. I mean, it was obviously he's thinking I'm a stressed out woman. He never asked me about my life and if I was stressed. And so it's like when we accessed ChatGPT, it didn't know I was a woman. It wouldn't like with my son Cal, when he put something in, when I take Cal to the doctor, when he goes to the doctor, everything is because he has CP. And one time he went to the doctor, I don't know how many times, he had a broken back. But the doctor kept saying, oh, muscular contractures, that's old CP thing. So you know what? When he can put things in, ChatGPT doesn't know he's disabled. It doesn't know if you're overweight or old or whatever. It's really focusing on the symptoms and the problems and not what we look like. So I think there is a benefit to using AI in some cases where biases can be, buffered. So I just wanted to put that out there. I forgot to say.
Thank you. Dave, you got a response also?
It makes me think about that old New Yorker cartoon of the dog saying, right, on the internet, nobody knows you're a dog, right? With ChatGPT, nobody knows you have CP, right? It's the flip side of the bias problem. So, Peter, it's a perceptive question. And my experience, you can imagine I've gotten a variety of reactions from different doctors through the years. My experience is we have the long-term question. How do we want things to be, right? But then meanwhile, I've got a toothache or I've got something I need taken care of now. I'm not going to refuse to work with a doctor because they have an attitude about my use of tools. Especially since I have real compassion for all the pressures that physicians are under these days, especially in this country. I'm moving forward, getting done what we can with what we have at hand. And I think that's a good thing. So
there's a paper, last month or 2 months ago in the New England Journal of Medicine AI about the issue of bias and showing that there are significant biases present in all of the leading language models. At the same time, the study showed that these same models are almost superhuman and, of course, tireless in being able to spot biased decision-making made by either people or by AI. And so it's a subtle issue, and it's reflective, I think, of the tendency in human beings also being biased, but also being very good at criticizing other people's biases. Yes, Dave.
A very easy way for those who don't know, if you think something is a hallucination or bias or something, trivial way to do it is either open up a different AI like Perplexity or just a new session of ChatGPT and ask it about that finding from the first one. And it will often, if there was a hallucination, it'll say, that's ridiculous, that's not true. Right? So, and that's my point in bringing this up is that what users are finding without any schooling on the subject is that there are ways to cope with the real world impact of these problems.
We're almost at the end of our time here, but seeing there are no other 10 cards up, I have been wanting to ask a question, so I think I'll use the chair's prerogative to do that. The two of you are obviously extremely engaged, intelligent consumers of healthcare. And so I imagine that the questions you're asking are good ones. And we saw examples of the kinds of prompts and so on. But a lot of consumers will ask questions. If we just think back to the pandemic, someone might ask about hydroxychloroquine or ivermectin or who knows what. And so to my mind, at least as a technology developer, this raises extreme challenges because the ability to discern good science from bad science or truth from falsehood is one of the most challenging areas for AI. How do you two see that? Because consumers will ask, it's not like a doctor or a nurse that will ask expert questions. Consumers will ask all sorts of things.
So I will jump on this. First of all, the bottom line of this is there is no juice at the end of that trail. Okay, I've seen lots and lots of people through the years try to figure out, wait a minute, there are stupid people, which is true. I have relatives who are undoubtedly stupid. I know I have a relative who denied that COVID exists, ended up in the ICU and insisted on ivermectin. All right, and what can you do? You know what the bottom line is? Democracy is a bitch. Democratizing knowledge opens Pandora's box. You're gonna let these people vote. And the remedy. My very first testimony at, I think, HCVHS, I think, in about patient access to the medical record, I ended up addressing this I spontaneously came up with a rhyme. I said, the solution is not to restrict and constrain, empower the people, enable and train, right? What we ought to be doing, and I have about a dozen action items to submit by mail later. One thing we ought to be doing is as we rev up the professions to get into this concurrently, not 6 months or 6 years later, concurrently be doing what we can in mass media, TV shows, you name it, to help the public wise up as well. And if some of them don't particularly respond well to white coats on TV talking, then put it in their sitcoms or whatever, whatever way they're, was it you that told me about the term designated driver came from a TV show? Yeah. All right, LA Law, was it?
That's right.
Right, so yeah, let's go into where they get their information and infiltrate that and raise everybody's knowledge level. The fact that some people are stupid doesn't change how to get to the best possible future.
Thanks, Dave.
By the way, I think my life is complete hearing the phrase democracy is a bitch in the hallowed halls of the national academies. That's the
Again, I have to again, a disclaimer. I'm not an AI expert in any stretch of the imagination. I just use it as a very common person, and so does my family. But my question is, how are some of these platforms developed? I mean, my husband's a doctor. He has open, what's it called, open evidence. And so if you were to search in open evidence about ivermectin or whatever it's called, chloroquine, would it come out with bad information?
It might, because it may not have been exposed, or it's probably been exposed to those two specific things, but there are other pop science remedies that you might find on social media that open evidence will never have been exposed to, and therefore could be very dangerous in the hands of a consumer.
My point is, as you develop these platforms, and my husband, who uses the open evidence, says it has never failed him in his own healthcare and then in medicine. It can be refined and refined and refined, can't it?
Yes.
And so I would assume that if some of this is getting into like open evidence, that it gets refined and that there's, some type of monitoring of all that. And then also, I don't think open evidence is available to me, but why not? Why isn't the best platform available to everybody? So if you're going to get platforms that have junk science in it, then push them out. This is free market. Create a platform that doesn't have it. I mean, it probably sounds way too simple, but I know that AI can be tested, refined. So that's kind of my simple answer.
Right.
Can I add one thing on top of that? Don't laugh at me. I'm an advocate. No, seriously. So Jeopardy Watson was a big deal in the patient empowerment community because here we were with our first big experience with computers, quote unquote, knowing everything. But when IBM rolled it out, and our Jeopardy person isn't here, right?
Yeah, he had to leave.
Yeah, okay, so this is subject to correction
But he did oversee.
from firsthand, if this is a mistake. But one of the people who worked on that project was at an O'Reilly Health event a couple of years later, and they had just inked the deal to install it at Memorial Sloan Kettering to go after oncology. Now, as I imagine everybody knows, several years later and $6 billion later, it turned out that Oncology Watson was no better than human doctors. And the reason was present in that room at that O'Reilly event. The IBM marketing people had decided that they should let the Memorial Sloan Kettering people put blinders on Watson and tell it what it was allowed to look for. As a result of which, it came out with results that were no better than what those doctors had. And so what we had, meanwhile, the empowered patient people, they also, and what MSK wanted was they told it only look at what's in the published literature. And this was before there were preprints, right? So Oncology Watson never knew about any breaking news that wasn't yet in an article. And that hobbled it. And I bring this up because this is a different version of bias, of institutionalizing bias. And if I've said anything wrong here, I know you walked in the middle of this, please feel free to correct me. But so in I showed a slide of Tom Ferguson, and he published this white paper that he was working on was published posthumously. One of the things in there was what he called the lethal lag time between the first moment a fact comes into human awareness and the time that it's out in in practice being used. And several of us in the room says that means that Oncology Watson will never beat the lethal lag time.
Yeah.
So thank you both for this great session. And now we're going to go into the final round. And if you've got 10 cards up, you can keep them up because it's an open round. And we're going to allow the conversation to flow freely. But Sunita, Peter, and I thought that one area for focus might be reimagining the assessment of quality in healthcare and the approach to it in this new era. It has come up in the conversations today, and we thought that might be an interesting hyperlink to sort of click from our previous conversations to focus on here. It has been I think our designers of this session, Michael and Sunita and team, really picked amazing topics, really put together an amazing agenda for this. And so it's given us so much to think about in terms of how we deliver care, the clinician and patient interaction, the workforce issues, all are fodder for the conversation that we can go into now. And then toward the end, we will, we're gonna come back also to this question of the clinicians forum. We're gonna have just a round robin. So because there's a lot of people, we'll wanna leave at least probably 10 or probably 15 or 20 minutes so that everyone can make a 1 or 2 minute final statement as we go around the room.
Ken, can I just make one
Please.
friendly caveat or addition to your query to folks? And that is, well, actually two elements of the same thing, not just quality, but quality and safety. Secondly, thank you in advance for doing our homework for us, because we're actually going to do a project on the role of AI in patient quality and safety. So we'll be taking directly your input.
That's great. So I saw Q, I think, go up first.
And I'm just going to reference the IBM situation, which we could spend a lot of time. There should be a case study written on it, but the issues are multifactorial. So, and taking on oncology was definitely a high risk topic versus some of the low risk things that we were sharing before. So I don't have much to add, but I'm happy to discuss it. Whoever wants to know, because I definitely felt like I was on the Titanic and saw that happen.
Yeah, just to reflect back from our just really excellent presentations there. I mean, I think, Dave, your slide that shows kind of like what's in the healthcare space and then what's in the health space, which is largely ignored, is really important. And I think to the extent that AI tools can be developed with both things in mind is going to be really valuable for trustworthiness, arming that workforce, and ultimately, again, not creating an adversarial relationship. I think something that people who are actively developing LLM applications, for example, within health systems know is the prompt is so important. How do you develop the persona to consume the information, to give the output in a way that minimizes, some of these, blind alleys or kind of dangerous things? I suspect most patients don't know that. They're probably just putting in the chart and say, like, what should I do next? But even that simple step, I think, could make a big difference in kind of like the quality of the output. And I guess that's just one example of why I think, kind of like thinking in a co-development, co-creation framework that bridges clinicians and also patients is going to ensure that we achieve the best alignment we can moving forward.
Thank you both. That was really fantastic. And Sue, as a young adult cancer survivor, I had a terrible diagnosis story with being treated like a hysterical woman, patted on the head, the whole thing. And that was 30 years ago, and it's sad to hear that a lot of that is still happening. So one of the things I just wanted to make a little bridge and crossing it, as we talk about crossing the quality chasm. The transformation of AI is the way that AI can be transformational for health is also dependent on the way that what is learned from AI is delivered and how that impacts the healthcare delivery system reform. So if we go back to our shared commitments, it may be that putting in things into AI, they won't know if you're a woman, a man, a dog, what your race, ethnicity is. But if we don't think about social determinants of health and structural determinants of health in the delivery of healthcare and delivery of what we learn from AI, it's not going to fulfill its promise, and we are not going to improve outcomes for patients. Thank you.
Thank you. I too want to thank both of you very much. And the questions and comments that have been made since. One of the most basic points that you bring out that bothers me a lot is why certain databases are not available, just available. And the reason that I'm bringing that up is, to me, that begs a fundamental, I think I want to say, right, that I think we believe in the United States, of non-censor and just really open knowledge to everyone. And my second comment, so I'll just leave that where it is. My second comment is that, similar to a couple other comments in like ChatGPT and these other queries, you know, the idea here is that it individualizes, or in my private ChatGPT stuff on other platforms, it individualizes it to me, so it knows. And so as I interact with myself and that whole experience, a lot of the potential to either customize to Connie and or attend to this bias, I think is a really good point that's been drawn out here. Yeah. And then my last comment is, you know, we talk about patient-centered care all the time, and this discussion really deeply begs again, what that really means and what real true partnership and working together is, and frankly, the fullest respect for another human being. And so I might say that in our healthcare arena, and I said healthcare arena, that maybe all of us in the variety of our professional situations need to listen to the breadth of other views on what we think we are, and help us, if you might say, strip out our structural biases. Like, I need to listen to other professions and to people to know how nursing is skewing the situation, or Connie is. So this discussion just keeps bringing what these things, they seem simple, but they are such basic constructs to this whole discussion. Thank you.
Dave, yeah.
Just to let my own cat out of the bag, the kind of future encounter that I imagine, think of what Hugo did, right, while waiting for the doctor's appointment, with conversations. Now, in his case, he wasn't talking with the doctor's AI, he was talking with his own. But now in my ideal world, I have some condition, something that emerges, all right? I want to find out more about it. I'll use my own ChatGPT if I have to, but I would love to use my doctor's, so that the chatter that we're doing gets captured and can be, if we end up needing a visit, it can all be summarized, ready to go at the moment that I show up, or even in advance, to be reviewed by both of us in much less time. It just makes the whole thing so much more efficient. And I just have to wonder, now, quite honestly, I've been around this industry enough now to know that a real problem with adoption of this is that there are administrators who will object to the reduction in billing. You know, with having fewer visits, some visits turn out not to be necessary and so on. But as a vision for this group to hold, just think about that. And the next time you need a doctor visit, thank you.
Lisa.
Couple of points. One, I want to echo the disparity problem that when you get a result out of ChatGPT, if you're searching your own things, it's going to give you advice based on what it knows about you, but it doesn't realize where you might be located. So the example that I just experienced this problem with my own family where I did use ChatGPT to check out a few things before I actually went on the Epic record and chatted with the people. And the answer I got from ChatGPT was, you need to go to the emergency room. I just verified that with the record. Yes, you need to go to the emergency room. Call 911. I call 911. They say, sorry, we can't come. So there are places in the United States where this happens. It's happened twice to my family. And so, you know, I think if there were some way to, now I could have put in, I'm in a very rural area, now what should I do? But I didn't really think that 911 wouldn't come, but they did not come. So that I would say that there is, well, I understand the notion that it doesn't know I'm a woman, or that's a good thing on one hand, but it can also be a bad thing. If you're not putting in as a consumer, you're not thinking that you need to put those things in, to your point about training and educating. The second thing I would say is this reminds me a lot of, remember when we first started seeing advertisements on TV for drugs, direct to consumer advertising, and then everybody came in the next day and said, I want this thing. There's a little bit of that going on, right? So I think as clinicians, getting used to that sort of, particularly with younger people, you're going to probably get more of this. I think you guys are maybe a little bit an anomaly. The other thing we have to remember is the fastest growing segment of the population is over the age of 85. The highest users of healthcare who probably are not using ChatGPT. So as a clinician, you've got to be trained to be able to handle both of these situations. And as we're thinking about the use case for this group, looking at both of those things at the same time has to be true. We have to look at both. So I think that the use from the provider's perspective of AI is all about efficiency and how you treat people faster, how you get more efficient decision-making. You use the tools that are now available and will come available to you to, expedite your workload of the not so fun stuff. But on the flip side, you really do need to be prepared for the 15-year-old who's going to walk in and say, I know what's wrong, just tell me what I do next, right? So it goes back to the part we were talking about earlier about training. Today's students, the people who are in kindergarten today, who are going to be future doctors in the future, are going to have to learn a completely different way of how they perform medicine. Same thing for all other healthcare professionals. I don't think it's an if, it's a when, and I think it's probably already here. So I think to your point about what you want to study for patient efficacy, patient safety, quality care, all of those things have to be considered.
Thank you. Now, Kimberly.
So I'm really struggling with thinking about the realities of our current healthcare system and healthcare structures. And maybe that is an important voice that can come out of this collective, because right now our incentive structures are not at all aligned with the optimal implementation of these kinds of tools. Yeah. So we talk about reimagining quality metrics, but I wonder if we need to reimagine productivity. Because if we look at health systems, the community-based hospitals could be where this is most powerful. They're operating on, I've heard it referred to recently as grocery store margins, barely getting by. They don't have the ability to access some of these tools. No one seems to have the time to take time to learn them and learn with patients about how to incorporate them into workflow. I mean, it feels like we just have to blow the whole thing up. And so I wonder if one role is to talk about what existing barriers will keep us from getting the most benefit out of these tools, and are there ways to try different structures as pilot projects or something that would be more enabling for the things that we're describing. It feels like we need to make a business case for learning all this stuff. And I don't know who pays for that.
And finally, Jana, and then we'll go to the round robin phase.
I want to say thank you to Dave and Sue again for sharing your stories. I think those are a really important part of this conversation. And there are two themes that come to me as really important for us to come back to. And one is that of trust between a patient and their healthcare provider. And the other is an appreciation of nuance. And I want to highlight a personal example, as others have, that I think illustrates this a bit. And my mother is a very frequent user of the healthcare system now with a pretty long list of complicated problems. And so she often calls me when, after she's accessed her medical record, she calls me and says, you know, I'm really concerned because my sodium is 2.9 and it says in my chart that normal is 3.1 to 6.5. And I say, Mom, 2.9 versus 3.1 at the bottom of normal is not that big of a deal. You don't need to be worried. But her first reaction is, why didn't my healthcare provider call and tell me this? And I said, well, she didn't call to tell you this because it's not that significant. It's technically abnormal, but it's not clinically significant. But if her sodium had been 7.5 yesterday and was 2.9 today, I would have given her a very different answer. But she doesn't note that that would be important. And if she, right now she has mild kidney disease, but if she were on dialysis and her sodium was 2.9, I might also have a very different response than if she told me it was 3.1 last week and now it's 2.9 and she has mild kidney disease. But when she goes into ChatGPT, she's not putting in that she has mild kidney disease, or she's not putting in that her sodium was 7 2 days ago. So I think it's really important that we continue to cultivate trust so that communication and using ChatGPT in partnership with your healthcare provider is a really good starting point. Because I would hope that if she were using ChatGPT with her doctor and talking about her sodium, they could have that conversation of why 2.9 today isn't as significant as 2.9 was when you were in the hospital 3 weeks ago. There's a different context. It means something different today than it did then. And so that she can also start to build the trust that her healthcare provider will call her if something significant pops up. And we all know mistakes get made all the time. You gave some good examples of that. So it doesn't mean you rely completely on waiting to be called by your healthcare provider. But I think also we have to continue to educate ourselves and our patients about what is the context that you can put into ChatGPT that will continue to improve the answers that we get.
Oh, I'll just point out one thing, which is that because of patient right of access to downloadable standardized copies of their medical record, there is an opportunity to have workflows for patients to actually have that conversation with GPT, with generative AI, with up-to-date information, including the labs. And I would see that potentially happening in the I mean, it could happen today, but I could see us trying to sort of memorialize that in some real workflow processes. So we're going to go to the round robin. I'm going to ask Peter to introduce it because I think he's got a good bullet to give everyone. Listen carefully. And because there are so many people and because we have only about 35 minutes, it's really about 60 seconds per person.
Yeah, in fact, I think we have less than 30 minutes, so it's really, you have
50
to stay strictly within 1 minute. And keeping in mind, I think there is a general sense that some concept of a clinician's forum would be a very important and useful thing. But of course, execution is everything in this case. And so as we go around, if you would prioritize one or possibly two actions, activities, topics, services, something, some goal, what would be the top one or two things you would want that clinician forum to help the medical and the world of healthcare more broadly achieve? And so we'll go around, I guess, clockwise here. And, you can pass if you want, but I would invite each of you to say some things. Now, of course, it's tough to go first, but it'll be really hard to go last because you'll have heard everything by the time. Okay.
All right. Yeah, actually, I enjoy going first instead of last because everybody has great ideas in this room by the time you get to the end. So okay, I'll be brief. As a regulator, I look at this conversation through a specific lens, one that isn't necessarily immediately kind of apparent as we talk about clinicians and the workforce needs there. But one of the things I want to kind of throw out there as a area of investigation, and I think something that could be really helpful to those of us that work in the public sector, is to kind of acknowledge, one, that AI is a tool. And one really important question that I think this room has discussed today and will continue to discuss is, how can this tool free clinicians to focus on patient care? And I think that's a really important question, and it involves competencies at the education and post education levels. I think the question that I'm also interested in is what is needed so that clinicians are confident in the use of that tool. So what is the trust scaffolding that needs to exist in order for clinicians to competently use the tools that are at their disposal? And I think public policy has a role to play in that. I think the federal government has a role, but I think public policy in general does. And I think that there's a lot that specialty societies can do in this space, because I want to think not just at the legal and regulatory level, but what are the governance mechanisms? Shiv mentioned that adoption goes at the speed of trust, but also at the speed of governance. And so I'm very interested in the perspective of this group in trying to think about what is their piece of the trust scaffolding.
If I were to organize a clinicians forum, I think fun and interesting would be to have a couple of debates on these really crucial push-pull topics that keep coming up throughout the conversation. So maybe one of the push-pull pockets, I know Vinny did a good job of this at one of the JAMA AI forums, is very similar to what we were just talking about. How, true or false, you need to test every AI use case. True or false, you need a randomized controlled clinical trial of every AI use case, pro or con. And what does that look like? And then what's the action that comes out of it? Was there a decision? And if so, how does that inform governance and framework? Another topic is education. I think there's been multiple other groups outside of National Academy of Medicine that have talked about how do we restructure education. And we've brought up today multiple times that there's this need and want for people to go beyond kind of the traditional education. So maybe there's another pro and con. We think that you should, see one, do one, teach one, versus we think out of the box you should be using every tool. And then I think after having these cool debates, at the end of the day, if we can have these action steps, because I think National Academy of Medicine has this really amazing, to use the word trust, there's trust in this organization to not have self-interest. It's bringing together of so many different organizations. So how is it that the points that are being made there, instead of making another white paper or another, pie in the sky idea, could actually be specific points that we would encourage patients, clinicians, organizations to do in the next 12 months?
My first comment is a thank you for this phenomenal day. And it kind of relates to what you're saying, Jackie, in the sense that it's such a common flowing group with a lot of transparency. And a lot of us are, some are repeaters, some are new. And for that to happen so instantaneously is great. My two comments actually relate to you, Jeff, and they relate to you, Jackie. Those are my top two. Clinical, the education, and my only tweak to each one of your suggestions, because of the nature of this organization, is make it interprofessional right from the get-go. And the reason I say that is there were so many common themes today for, I'm not a physician, but I'm thinking all the time about, wow, that would just relate to nursing. I'd like to sort it out. So those would be my top two priorities. And this is the org to do it.
So we've talked a few times today about being flat-footed. I would actually say we're on our heels. And so I'm struck by the opportunity. How could a group like this accelerate the training that we think needs to happen? And how do we encourage safe spaces for people to explore the tools and try the tools? And I know in the world of education, those who lead educational programs often feel like they don't have much influence in the clinical realm. And so everything gets pushed to a workshop or a classroom-based activity. And one of an organization like this can facilitate the conversation between health systems and education so that you don't hit a firewall and there is a process to be able to engage and start to learn.
Thanks. So I think the Clinicians Forum is a very exciting opportunity. And I think it's one that will help us to reap the benefits of some very innovative technology. I think a very important question for physicians is how they know whether they can rely on a particular technology and for what purpose. What is the intended use of that technology? What should it not be used for? Who has validated and vetted that technology, and just transparency broadly in that area.
My goal is the same as already stated, really on education for nursing and interprofessional clinicians to take away the fear so that we could all work together with our patients. I think it's out there, it's already happening. We need to remove the barriers, but really how do we educate so that, because nobody wants to say where they are in their educational journey. Everyone's kind of, oh, I know AI, I use ChatGPT, do they really? I don't think they do. So I think education and just getting everybody on the same platform, and it's okay to have fear around it, and let's move forward beyond that.
Thank you for hosting this today. I think my comments are related to multidisciplinary education regarding use of in the entire workforce and how to inform the workforce, not just focusing on our traditional training patterns, medical school, nursing school, et cetera, but continuing professional education, because we have a whole generation of providers that have already passed through that kind of training, and we're really going to need to get the entire workforce up to speed, but hopefully in a multidisciplinary way.
I think my two comments would have to be making sure that we have an expansive definition of health. As I was sitting here today, we focused a lot on physical health and not much on mental health and really what that looks like. And that is also a space that is really expanding in terms of artificial intelligence. And so really, how do we incorporate this in terms of mental health as well? I think the other part of it too, in addition to interdisciplinary collaboration, is really thinking about what do the ethics look like? And I think that this group can kind of inform ethics across disciplines. Because I know in social work, that's a issue that's coming up a whole lot. So I'm sure it's coming up in other areas. And how do we use this in an ethical manner and making sure that that is at the forefront of anything that we create as we put it forward as within our own professions.
Thank you again for the opportunity to be here today and hear a lot of really great comments and testimony. I think that I would re-echo again this training notion that everyone's talked about, from all the way from existing clinicians, students, and even the public. This is very important, but more than that, or in parallel path to that, is I believe the National Academy is in a unique position to actually take action on this, meaning that we can sit all day long and come up with great tools and learn how to train people, but we need your help as an institution to go out into where to make the change happen to the academic institutions, to the hospital systems, because that's where the resistance, as Morgan pointed out earlier, that's where the limitations and barriers are going to come. So using your voice to make it real is what I would say. Thank you.
Again, thank you for allowing me to participate. I'm sorry to step out. I figured I'd come back and you'd have it all sorted. Part of my team includes some human factors engineers, and we think a lot about the machine-human interface. And I think from the perspective of a clinician, that interface and how we trust the tools, how we interact with the tools is something that we need to do a lot more work on yet. And I think the voice of the clinician in that interface is so key to kind of understand. And so I think from the perspective of should we do this? Yes, and I agree entirely on the expansive nature of clinician and definition of what targets for healthcare there are there.
Thank you, and thank you for bringing in patients' voices to this table and this round table. I really appreciate how much the National Academies does this, and how much our voices are listened to with real respect and really deep listening. So I very much appreciate this over the 2 decades I've been working with this organization. I think I want to go back a little bit to the idea of humanities and purpose. And when I think about the Clinicians Forum, which I think they're absolutely I absolutely would support that. I think it has to be not just simply interprofessional, but also interstakeholder, because that gets back to the humanity and the purpose, because this is not simply about it. AI is not the end. AI is a tool, and it's a tool to improve individual and population health. So in order to really do that, I think that this forum should be interstakeholder and model all of the shared commitments that we talked about in the beginning. Was the shared commitments are my little because I think those are so fundamental. And so it's great to me when I'm in these different meetings that we go back to these kind of fundamental shared commitments. And so I would love to see this forum also be built on these fundamental shared commitments. Thank you.
I think an effective clinician forum would be one that would answer the question, how can we educate interdisciplinary healthcare providers to be expert users of AI in partnership with patients to improve patient outcomes and physician health and well-being?
Also want to say thank you. Great group, engaged, learned a lot. One of the things that stuck with me, I think Morgan said the bottleneck is integration, not innovation. And I really feel that pressure where if we come up with the ways we wish to leverage, train, and use AI, it's still going to come from all around. It's still going to be different models from all over the place, unregulated, regulated, moral controls, no moral controls, et cetera. So the consideration of thinking about it in terms of, how might we train, how might we even integrate with things out of our control? So where does that model live if it's nobody's model, and how do we deal with that? Because it is coming, it's here in a lot of cases. And I love the patient use cases. I think that they're a great leading indicator of things that we all will have to deal with.
I will +1 the thank yous, and thank you very much for sharing your story. I think my hope would be through a clinician forum that as we move forward with AI, we don't leave behind the assumption that our healthcare system just needs an AI solution. I think there are a lot of issues that still need to be addressed, that AI may not be the solution, and for it to be truly integrated and not just kind of taped onto the side of our delivery system, we need to look at some of the things that are just pervasive and broken in the system, including kind of how how people are paid, how money moves around in the system, how quality is measured. We talked about this at lunch. You know, and I think my second hope would be that we use AI, I mean, selfishly and from a self-interested way. And, you know, primary care is 50% of all ambulatory visits. And so I think from a scaling perspective, there's a lot of benefit at looking at how it could really help address some of the challenges there with access. And really, how do we use AI to attract a different kind of workforce that is going to think differently, that is going to use it differently? So not just training the folks that are there today, how do we begin to leverage this to attract, you know, the future primary care infrastructure we need?
So I keep thinking about, earlier we said about the 6 domains of AI to education of clinicians. And I think that the one thing that the National Academy could do would be to kind of set that first portion of the foundation of AI and kind of what is that. And I think if you could do that in an interdisciplinary way, we could at least have a shared starting point, because the other pieces diverge off wildly based on your discipline. But I also think then you could take that and turning it into a public or patient-facing kind of concept, that so you could have everybody kind of level set to begin, but then also have something that you could push towards the public as this grows, but the foundation should be set. And I think that's what this body could do more than anything else.
Peter, I was thinking about your AI revolution in medicine, AI being a revolution in medicine, and thinking about revolution as a transfer of power. I think that without question, there's a transfer of power happening in a number of different ways on a number of different levels. I'd like to see the forum interrogate that, because I think that's our view into the system of the future. I think we came away from this today knowing we cannot design for the healthcare system we have today. It's changing before our eyes. So I think we have to start looking at that power dynamic shift. The other aspect, Connie, I was really struck by your remarks earlier today and your point about honoring the AI native. And I think that we were bedazzled by an AI native in the room today, Morgan. Morgan was my intern at our Rhode Island Quality Institute. Just want you all to know that's where he got everything, and he knows. So anyway, that honoring, I also think we saw some other AI natives in here today. And we were enlightened by those examples given to us. So that feels to me to be something you think about as we have people come in to talk to the forum and bring new ideas into the forum, thinking about that idea of honoring the AI native was really struck me.
So thank you very, very, very much for having me. I worked hard to try to speak in the way that would make sense to the brains in this room. The best way to get started on this, and we've got to stay current while we start analyzing, everybody collect stories that you hear of people using AI for medical questions with a good or a bad result. We need to know what people out there are doing and pump them into a pile, a database, story-based something, so that they can be analyzed and we can keep track of it as time goes by. And as I was gestating this thought, I thought, holy cow, this is what Susanna Fox used to do at the Pew Research Project 15 years ago about Googling, documenting who did what with what age groups. And it made me think, where's Susanna Fox now? You know, well, she lives up in Northwest DC, but that's.
She actually had a nice report not long ago on the use of AI, Gen AI among rare disease.
Rare disease,
communities.
yeah. Yeah, very good.
That's it, Dave?
Thank you for the invitation. Gosh, to keep it simple. Yes, I think you need to continue with a clinician forum. Like others have said, you know, when I first saw the title and it was for the clinician and I was invited, I thought, why wasn't it the clinician and patient roundtable? Because at the end of the day, I really hope that discussions around AI center on the patient. I think everything should start there. And then, you know, on the outcomes, the experience, the values, the preferences of patients, the definition of patient-centered care, and that everything gets built on top of that.
reducing burden, keeping clinicians from leaving the profession. But I just really don't want the focus to get lost that the beneficiary at the end of the day of AI in healthcare is going to be the patient. And so I hope that focus remains. Oh, and I'd have to say, native AI cracks me up because I barely understand AI. So I can't call myself an AI native. Again, I just use it. And so does my family. But AI native is like that from Frontier, Idaho. Yeah.
So what's really resonating with me is what Laura said about the profound shift of power that is happening, and I see that as an opportunity. As I think about the role that the National Academies has played for me in thinking about care, it's really leading, lending support, advocacy, and recommendations. And what I would like to see now is that around the use of AI tools for patients, to empower patients, to support patients. If I was thinking about this with the whiteboard, which I love to do, I would have the patient, as you've mentioned, at the center and ensure that there are ways that all patients can access these tools, because then around that, I would build the right care team. I don't think that we have the right roles and responsibilities, but I do know that we need to include those in graduate medical education and primary care, as a primary care doctor, shout out there, as critical. But it's going to need to shift the types of roles that we have that interact with the clinicians. And I'd love to see then the payer system then follow along and support and incent the patient, the care team, a different one, and drive it in a different way. So thank you for the opportunity.
I want to echo the thank you for having an interdisciplinary voice as well. Thanks for having pharmacy. Just 3 comments that I had as I'm thinking about everything else that others said. One is seeing this forum serve as kind of an advisory panel for partnership for both development and governance of these tools. So how can we partner with tech innovators so that the clinician voice and the patient voice is at the forefront before they just hit the market, and just how do we help the development and the thought behind that? 2 is I think we should start thinking about the future of the workflow, the clinical workflows, and how do we prepare our clinicians for the practice of the future that will look very different than what we do today, so that we're not surprised, and so that we prepare for tasks that will be eliminated and potentially should be eliminated as a result of AI. And then the third is just maintaining the focus on intent. The intent is patient outcomes. How do we improve the patient experience? That's what we're here to do. But the pilots are messy, innovation is messy. And so how can we really experiment safely in this space without holding it back? So those are the 3 takeaways.
I have 3 recommendations I'd like you to please consider. The first is leverage our AICC multi-stakeholder matrix that we created. So remember, we identified exactly how to not only reach these standards, but also how to support our counterparts in research, innovation, in health system and payers to be able to achieve each of these shared commitments. So there's an opportunity there. Offer a neutral co-development space. This is something that I think could provide an incredible amount of value to innovators as well as to our clinicians and our patients. This is something I would like Mayo to develop, but I would even more prefer for it to be a neutral space led by the National Academy of Medicine because of its value. The third is to embolden our clinicians to be the ones to advocate for patients to own their data. So create a space to shift the paradigm with that clearly obfuscates any sort of tension between clinicians and patients in understanding of knowledge, allow them in their credibility in their knowledge and intelligence to advocate for patients being able to meet them at their level.
Thank you again for inviting me to this conversation. I have 3, but they'll be quick. The first is I would just say this is our moment to design the car, not the faster horse. The terminology that Laura used was a revolution, a true transfer of power, not incrementalism. And so instead of having AI happen to us and our patients, I'd love to hear this group or see this group produce a roadmap that in its most intellectually honest form interrogates how the role of various clinicians will change with this technology over the next year, over the next 5 years, and over the next 10 years, and to have that honest conversation in a public setting. Education and implementation, I believe, can follow nicely from that blueprint. Second, I would say this is a quick hit. We should figure out who is going to pay for this sustainably over time and how. And I think clinicians have a unique lens into some of those dynamics, but they are not, I think, the only folks who will have a say in how that unfolds. And then lastly, several people in the room today used the term the learning health system, which takes us all the way back, to some of the origins of the conversations we've been having here. And so I'd like this group to consider how AI can dissolve the barriers between the discovery of biomedical science and the delivery of high quality care, so that this vision that many of us in this room have held for so long can actually be realized, where each patient matters.
Thank you. Thank you to everyone in this room for sharing your experiences and especially your wisdom. This is hard. It is hard to go towards the end. I just will add two things. And one is co-production and co-production at every level with learners, clinicians, and of course with patients, and co-production of curricula, educational resources, and of course the technologies to support those, and of course healthcare as well. But I think there could be a real, I would say, beneficial application of educational tools and co-produced with the many stakeholders in this room. And then the second is equitable access to those tools and resources, regardless of institution type or learner or resources that institution may have. And then this isn't necessarily third, but I do think in this broader context, I think there's been a lot of discussions about the system and the organization, which is fabulous, because whatever we do in education is context dependent, right? So if we have our sites and we create a fabulous kind of tradition or a curriculum that is a wonderful kind of product and experience, but if that's not reflected in the clinical practice environment, if it's not reimbursed, if our clinicians aren't able to use those technologies and tools that we've adopted in the curriculum, then there's a mismatch there and it's problematic. So again, thank you for the opportunity, and I do look forward to continuing with the new council.
I also wanted to express my thanks and gratitude for the conversation today. This has been extremely valuable. I'm looking forward to bringing back many of the themes to HHS leadership. A few of the things that I think would be helpful for the forum. The first would be, and I know this would be difficult, is to survey as many extremely busy frontline clinicians as possible and ask the same question that we're answering right here today, to survey and get an inventory really of the diverse spectrum of views and experiences that clinicians face across the country, as well as patients. I think it's really important, similar to Dave's comment, as far as getting an inventory as broad as possible of the current snapshot of the needs of the ecosystem. Maybe partnering with some of the professional societies here today could be a way to access a larger data set to base the principles and approach of the forum on. Another would be to ensure that the recommendations that come out of the forum are stratified based on potential legislative changes, regulatory changes, clinical workflow related changes, that many of the things that we're discussing really, or some of the really high impact, potentially incentive alignment focused recommendations, Congress may need to weigh in on. There's clearly a number of areas that HHS from a regulatory perspective could have an impact on. One of the other things that I didn't hear so far today is including some type of focus on the liability related and legal impacts of using AI in clinical practice. I know I've heard that that's really a significant concern that could be addressed in this type of setting, and just happy to continue through our efforts at the Office of the National Coordinator, now ASTP, to continue with the dialogue.
I can confirm that it is hard to go at the end. I think I'll echo a lot of what other folks have said. It's very clear that this is not just a change in technology, but this is a big change in practice. And we've talked a lot about training the next generation and curriculum for students who are currently in school, but I would really love for the forum to focus on how do we disseminate education to the current workforce, a workforce that is difficult to engage outside of their already busy working hours and that already has a lot of variation in their comfort level with technology. So I think that's one of the big questions that I would really love the forum to focus on.
I'll just echo a lot, and I'll just say I think one consideration for the clinician forum is whether you want to be kind of strategic or tactical. I think tactical is learning health system and dealing with financial incentives, technology integration, cybersecurity, quality safety. Like when is our evaluation good enough? Like if notes are being if patient message responses are being drafted 1 million times a day, can we say that that is the new standard? Okay, issues like that, and then education and training. I think the strategic one gets more towards like what Laura is raising, where terms like information asymmetry, power transfer, disruption, and revolution come into play. And it's less about the health system, more about health itself. And like, are we arming patients alongside the clinicians to revolutionize health? And some of that will come through the healthcare system, and some of that will come through these adjacent tools. I think if it's not adequately distinguished, the clinician forum will feel like it's not sure which of those issues is kind of top of mind.
I just want to express gratitude and very strong interest for NAC and community health centers to be at the table. So grateful to be at the table. And I don't know if you've heard that joke. If you're not at the table, you're on the menu. So the question of who's at the table, I would just challenge us to think about the unique, diverse cultures of different groups. If you're talking about patients, providers, tech companies, it's big tech and little tech companies. So I'm grateful that we've got making sure you respect and understand different cultures and the different languages that you have to express in order to get to that connection and that trust. I appreciate, it's reference clinician forum. So I realize we're at the National Academy of Medicine. So the focus on clinicians is reasonable, but it ultimately is a whole team effort. And a lot of non-clinicians play a very important role in the role of AI in advancing health and healthcare. So just something, and patients, of course. And to me, the emphasis on with patients rather than for or to patients is an important component. So making sure patients are at the table. I do think primary care and community health centers were patient-centered boards. We could be very practical in showcasing, even locally in every community, how patients are governing these groups. And a lot of the real world examples of AI are being applied in these types of settings. So my other challenge would be for us to get out of these types of rooms and find ways to be connected into actual real world settings and listening and talking to folks and even maybe meeting in those settings so that we're kind of more grounded in the real world if we want to focus on the action versus the theory. And it's hard to have those languages also connect. Last piece is equity. In the moment when we're challenged with Medicaid cuts and a lot of other challenges in our nation's health, and the fact that 1 in 3 people in our country are poor, below 200% of the poverty level, I hope that equity will be a strong focus of this work.
I guess we're around at time, and unless Peter has something to say, I think it's Michael's remarks now. Peter?
Yeah, I just wanted to say another big thank you to everyone. It has been a great
session. I think two things I came away from early on in the morning. I think the push, trying to change the discourse away from fixation on efficiency to other things like quality, that was very informative to me. And it occurs to me that even also helps enable and empower the government representatives here, since the government has been so focused on other things like quality and even in creating incentive structures on quality. There's something there. And then on the patient empowerment, there's this very sharp consumerization of healthcare, urgent care clinics, and so on, and that's leading to more fragmentation care. And so the other question is about whether AI gives us a way to kind of connect patient engagement in the healthcare system better. But really fantastic. Thank you.
Well, thank you. Thanks to everyone. Clearly, I'll just take a couple of minutes to, since you've all been so wonderful in offering great suggestions, sharing your time, contributing immensely to our enlightenment, it's time for your assignment. So that's what I'm going to give you a little bit of. The notion is assume a forum, and a forum that's made up of clinicians and patients and product innovators, has all three at the table, and has a broad and ambitious agenda to change the way we do things. And then the question is, what do we do to organize that forum? And I'll give you 4 assignments. Assignment number 1 is to give us your thoughts, and we'll follow up with a note on this. Give us your thoughts about the identity of that forum, its mission, its primary aim, if you will. For example, picking up on, I believe, Dave's observation about people coming in to their clinician with a rendition of a generative AI and of their issue and goal, and having that as the starting point. Let's assume that the primary aim of the forum is to build trust to improve performance, and to ensure that there is a democratic element. I know, Dave, you said democracy is a bitch. And Jeffrey then said, we need, at the first formal meeting of the forum, we need to hand out T-shirts that say democracy is a bitch, and on the back it says evidence-based. But in any event, if you can give us your suggestions about what you think the identity and the mission and the primary aim of the forum ought to be. Secondly, if you can suggest the near-term priorities, sort of the no-brainers that you've heard around the table and suggested in many ways, the issues that came up related to a focus on the patient of the future, understanding what that is, or focus on a clinician of the future, or trainees as innovators, or the issue of the organizational barriers that are faced within health systems, and focus on what learnings, how we can gather learnings from societies that have very active issues around AI and their own specialty groups, and what we learn about co-production in that respect, what we learn about business models that are going to be essential in the progress. Just sort of those issues that came to mind as really important issues, not necessarily one more important than the other, but things that we should keep in mind as we talk further about the priorities and so forth. The third assignment is to think a little bit about, it's a spin-off of the second, and that is the products and activities that can make a difference. How do we change the decisional milieu? if this is an action forum, we're going to have action products, and our job is to make it at least a little bit easier for the right thing to happen for you and in your settings, then what are the products and activities that would be able to accomplish that? And then the fourth assignment is your thoughts about logistics, the practical elements of developing the kind of forum that can be most beneficial to you and your activities. So we'll stay tuned. We'll send a follow-up note to remind you of those issues. Please feel free to wander beyond the formal request. And my last request is that we, in addition to a very warm note of thanks to each of you and our speakers, a warm note of thanks to both our co-chairs and the staff who put this together. To be continued. Enjoy.